Black.
You want black?
Yeah.
Okay. You want earphones?
Yeah.
No.
So that just
Do I
be
need 'em?
Front end,
It's up to you.
and it's just gonna be running the whole
It just
time.
blocks out
So we're
the.
all done.
Okay.
Yeah, all you should have to do is come in, sit down just like they did, and once you're ready to start, make sure you didn't
Huh?
Testing, testing. I can't hear anything out of it. Testing, testing, testing. Can you hear me? No.
we're working earlier, of course.
So what is this for?
This is something that Jeremy started at Pasadena High School called the Sports Medicine Podcast.
Mm-hmm.
And so came across it just kind of researching. So we shot an email out to Jeremy a few months ago to say, hey, listen, we're starting up this new program. Testing, 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 testing. Can you hear me now?
Yes.
And so he invited us to the radio show. And so we've done the radio show now 3 or 4 times. And then he said, we're going to set this up here. And what it does is that Jihad sponsors it, and it's a podcast.
Right.
So essentially what we do is that we talk about issues in sports medicine and athletic training. And over the last 3 times, we've been able to get on and talk about athletic training and where it's moving from an education standpoint and why it's moving there. And
Great.
it's really caused a lot of problems.
Would it be easier for you to use this one?
What?
You can put it kind of, because this one you're gonna have to look back this way.
Oh, it doesn't matter. Which one do you want? All right, you tell me when we're ready to go.
All right. Go ahead.
Testing, testing, 1, 2, 3. You got it? You want to test yours real quick?
Is mine working for you?
Mm-hmm.
All right.
Yeah. Okay. You ready?
Yeah.
Tell me when to go.
Go ahead.
Hey, this is Dr. Josh Yellen, Program Director for the Master of Athletic Training Program at the University of Houston. I'm sitting here with Dr. Walt Lowe. Dr. Lowe, thank you very much for joining us.
You bet. Thanks for having me here.
Thank you very much. Dr. Lowe, for a little of his bio, he is a team physician for the Houston Texans, team physician for the Houston Rockets, team physician for the University of Houston Cougars, go Cougs, and he has signed on to be a preceptor with our program, and we've signed a nice affiliation agreement with him and his department. I want to ask you a few questions today about your lecture and some of the advances of being a team physician in the NFL.
You bet.
So can you tell me a little bit, how long have you been a team physician now in the NFL?
Well, ever since the Texans were formed, so I started working for them in 2001. Our first football season was 2002, and then previously I had been the head team physician for the Houston Oilers the last 2 years they were in town. So I think that puts me at about 14, 15 years now.
And before coming to Houston, or before getting into the NFL, tell us a little bit about your background and what you did.
Well, like I tell my kids, I graduated from the 27th grade, so the usual route to med school and orthopedic residency, and then I did a sports fellowship at the Crow and Job Clinic in L.A., where part of our job was taking care of the Rams back then. They were still in L.A., the Dodgers, the Kings, the Lakers, the L.A.
What years were you there?
I was there in 1990 and 1991.
I'm wondering if I was one of your patients.
Might have been.
Because I was a high school athlete in Los Angeles.
Really?
Yeah.
Really?
That's where I'm born and raised.
Did you see one of the guys there?
I believe so. Yeah, I was.
Cool.
For a number of different things. I wonder if I came across you.
I looked totally different. I had hair.
I was 17 and had no brain, so I couldn't remember anything.
Yeah, I gotcha.
So you've been in the NFL now for 14, 15 years, and you've been in the NBA now for how long?
Since my first year with the Rockets was 1993 when they were in the World Championship, and 1994 when they won it again, so that was a pretty good start. And then there was about a 5-year hiatus I took until 4 years ago, and then I've been back. So again, I did it a long time, so probably 17 years in the NBA.
And then tell us a little bit about the University of Houston. How long have you been the team physician there?
Well, since 1993.
Okay.
So I think if you actually do the numbers, this will be my 23rd year there with Mike O'Shea, the head trainer, and I came in at the same time. And it's still my first love.
Yeah.
It's still the most rewarding part of the sports experience.
Well, we really appreciate anterior lateral ligament, and what your thought on it is, and what do you think clinically it does?
Well, let's start with what it is. What it is a capsular thickening of the knee capsule on the lateral side of the knee. And it functions much like what I believe, the more I'm looking into it, like the shoulder ligaments do, like the glenohumeral ligaments, where it's not a free ligament through the middle of the joint like the ACL or the PCL or something. And so that thickening gets brought into play by certain ranges of motion, certain rotations, those kind of things. And so that's what it is. Now, how big a role it plays in stability, I think, is really debatable right now, because there's some release, reconstruction, dissection studies that says it plays a big role. There's other ones that say it doesn't play much of a role at all. So I don't think we understand the capsular thickenings of the knee yet. There are some on the medial side, all that. I think they're critical for us reestablishing normal stability when we're treating patients with torn ACLs. And I believe the capsule will begin to play a role in that. I don't think we know what role it'll play yet.
And so looking at that ligament clinically, obviously if you're going to test an ACL, the Lachman test has the most reliability and validity as a test, followed by the anterior drawer. And then we can do a pivot shift or a slocum. Looking at that particular ligament, if you want to include some sort of rotational aspect of it, what kind of test would you do, or would you just rely on an MRI?
Well, I'm not sure we can diagnose that tear clinically. I think it's too subtle. The thought is that those athletes that have a torn ACL and have injury to this lateral capsule will have a greater pivot shift. Okay, and so that is something that should sensitize us to looking closer at that lateral side. In the acute injury, almost everybody's sore laterally. Okay, so tenderness over there, pain over there, because in the giving way episode, the big bony bruise we see happens laterally. But that makes you understand a little more why this capsular issue happens out there too, because all these big compressive and rotation forces are centered out there in the lateral tibial plateau. So I don't think there's going to be much of a office physical exam for the anterolateral ligament, and so I think its injury is going to have to be delineated by the MRI, and that's never been done before, and that's a study we just finished where it's in line to get published, going to be presented at our academy next year, so you can see that ligament in a fair number, about 70% of normal knees. Okay, and in ACL injured knees, isolated injuries to the ACL, it appears to be injured in about 40% of them. And so it is definitely part of the injury pattern that comes with a non-contact type ACL tear.
And so really what you're talking about is that athlete that takes a step, rotates, with the tibia planted, and obviously all that.
There it goes.
Yeah,
right.
And there it goes. And so clinically, in your office, if a patient were to come see you, you do a Lachman first, and then you do a pivot shift, or you go right to the pivot shift, because we all know if we do the pivot shift, we got one time to do it.
Yeah, I will attempt to pivot on the field while everybody's still totally freaked out. I don't even do a pivot on acute ACLs in the office. I do a Lachman, and that's pretty much it. I think that test in my hands is virtually 100% diagnostic. I will pivot them when they're asleep to determine that, but it's just not really nice to pivot people when they're awake.
It hurts too much.
Yeah.
And so in that little 3-minute
I think it can
period,
injure. Yeah.
Right, in that little 3-minute period when all the chemical mediators are influxing the capsule, and they're still kind of in that tissue shock. That's when you go in for the pivot.
Right. And on the field, it's pretty easy to just slides in and out. We know what this is and move on. Right.
Okay. Now, if you were to, obviously the patient's diagnosed and they go in for surgery, and then you refer somebody back to rehab with an athletic trainer, and what's some of your concerns about if you see some involvement in the anterior lateral ligament? What are some of your concerns that we talked about briefly in your lecture, the accelerated rehab of the ACL. And some of the things that I've always been taught, which might have been counterproductive or counterintuitive, was that really focus on the hamstrings, because the hamstrings are doing dynamically what that ACL is doing statically. And then we talked a little bit about backing off that accelerated rehab. From a physician standpoint, tell us a little bit more about what you see.
Well, I think that accelerated rehab has become an oxymoron. Is exactly what I think, and and I mentioned it briefly in there. We've now become very anatomic with our placement of these ACL grafts, and in doing so, we've created a problem by asking tissue that we reconstruct the ACL with, a patellar tendon graft or those things, to actually resist the forces of an ACL. And in the previous days in this country, when these reconstructions weren't very anatomic, these grafts didn't see true forces of the ACL, and so they didn't tear very often. Well, these new grafts are tearing more frequently, and that's a big concern, of course, and that's really, I think, what's prompted this investigation into the ALL and other contributing stabilizing factors that may help us protect these grafts if they are reconstructed or repaired or whatever ends up happening from this. I think it's too early to tell. And then the other thing is graft healing. We've never really studied that or made it a part of us returning kids to play. And now that we have these high forces early on and these grafts, I think we're getting at the point, or I am, where I have to see a living dark black ligament on an MR for me to feel comfortable that ligament's ready to see those forces again, regardless of how good the kid looks. And that's why I said the accelerated rehab is kind of an oxymoron. I think we do need to go slower. We do need to protect these grafts. I think that's going to end up probably being our key to having them heal and get our injury rates back down.
So you're really looking back at something that we all learned in the beginning of school, which is we need to be able to look at the patient physiologically and not necessarily look at them functionally, and make our diagnosis and decisions based on our physiological information, not necessarily on what we see the patient being able to do.
Right, I mean, totally, and we all know after doing this for a while, there's people that do things very early and get away with it, but it's our responsibility to get as many of them back to doing it again and get away with it at the same time.
So going back to that ACL repair, and then I've got a couple more questions for you, and then you've probably got to get going here, but when you go do an ACL repair, are you doing cadaver, allograft, are you doing semitendinosus autograft? Are you doing bone patellar bone autograft? What is?
Yeah,
what's
I'm not all. I don't think you can do the same graft on everybody and have everybody end up good. I think there are places where all three of those grafts play significant roles. In the young athletic population, and I'm 57 now, so that goes all the way to 57. I use a bone tendon bone patellar tendon graft. It is our graft that has the most predictable healing into the bony tunnels we put it in, because it has the patient's own bone and their bone tunnels, and that healing not only happens rapidly, but it happens predictably, and that's not the case with tendon in bone tunnels. Allografts play a role. They play a role in the blown up knee that there's not enough tissue from the patient to fix it, the big knee dislocations where everything are torn, and in guys like me that don't do things that put the ACL at risk very often. A ski trip a year, or a couple of ski trips a year, and other than that, you're in the gym working out, doing a few little things. So exposure is a big deal about re-injuring, your ACL. And I think the young kids that go hard every day, I believe we need to make the decision on which graft has the least chance of re-tearing, and that's our BTB, patellar tendon graft. So probably 75% of what I do, because that's my patient population, are BTB, patellar tendon grafts.
Good. Going back, something that you brought up, I think, were two very interesting concepts. One is that mental readiness of ACL return to play, and the other one is that you brought it up you have a specific, I think you said it was 95 things they have to pass?
No, 15 things.
15 things, yeah, that's what I thought. 15 things. I heard it wrong.
Yeah.
But you have a mental readiness checklist, and then you also have 15 physical things that they need to be able to pass. Can you talk a little bit about the 15 different things and what kind of activities you're looking for?
They're basically a lot of what everybody knows. That the basics are the are the single leg hop comparison. That's a very simple one anyone can do. A timed shuttle run where we have norms for age groups. We even have norms for positions in football. So a timed shuttle run, a timed cone drill, same thing. We have norms for ages, norms for positions. vertical jump off of one leg. There's a couple of landing tests that fit more for the young women than the young guys, that they have to have control of their knee. They have to fire their hamstrings on impact. They have to have a flexed knee and hip, as they do it. Even a single leg squat is one of them, where they have to be able to not only keep their knee from falling into valgus, but they have to keep their pelvis from lowering at the same time. And so there's a bunch. There's some that go out on the field that are more advanced than that we're trying to validate right now. So we're using them in the pro football training rooms. We're not using them in the physical therapy clinics yet. But even the simple ones are very telling. I think, and so I do believe we need to have a test that kids need to pass before they get so-called cleared.
Right.
And if we do that, we're going to decrease the number of re-tears that happen for sure.
And if somebody wanted to access these 15
They
diagnostic
can
tests,
email me.
They can email you directly.
They
What's that
can
email?
It's a long one. It's walter.r.low@UTH, like University of Texas Health, .tmc, like Texas Medical Center.edu.
And Lowe is spelled Lowe.
Correct.
Right. If you want to learn more about Dr. Lowe and some of his background, you can go to our website, www.hhp.uh.edu/MAT. That's for the Master of Athletic Training Program. And Dr. Lowe is one of our affiliates, and you can click on the link that says Partnerships and pull up the University of Texas Health Center Department of Orthopedics. One more thing that I want to ask you about is the mental readiness. I've always believed in the mental readiness, that I can really put somebody on a biodex and show them physically, hey, listen, you're 110% of your unaffected leg, and go down that line. But you know what? When I bring them back to what I like to call the scene of the crime, they can't do it. They can't reproduce it because there's that mental block. So tell us a little bit more about that. We all saw a video that you put up of, we knew that a patient was mentally ready.
Right. Well, that was a little tongue-in-cheek, obviously, that video, but that's always been an interest of mine. And a couple of years ago, Kurt Spindler and the guys at Vanderbilt and the Moon Group published a return rate to same level of sport after ACL reconstruction of 67%. And that, to me, was a shocking number because, seems to me like they all went back when you take care of them as patients on a one-by-one basis, or most do. So that's what forced me to begin thinking about what else is playing a role in them coming back. So this study we're in the middle of right now, we're still enrolling patients, and I think we have about 100 in it right now, and for power we need about 200, which will happen pretty quick. And so we've been giving these questionnaires on a first patient visit and every subsequent patient visit, both pre-op, post-op, as we go through. And it's a questionnaire that has several visual analog scale questions for them just to pick where they are from 0 to 10 on a bunch of different mental issues. Some that are kind of weird, joy, happiness, stuff like that. But other things, do you believe you'll come back and play your sport? Are you worried about it? Simple things that you'd go, whatever. And like I said in there, it's been interesting. I've sort of read through every chart when I go through because they're all in them when I'm seeing them post-op and everything. And these kids actually divide themselves into two groups, and they're the true believers and the true non-believers, and as I start to think about it and look at the individual kid and stuff, I think it's a comment. My take on it, it'll be interesting if I'm willing to write this down the line, but I think I will if it continues as it appears to go, is that there are a lot of kids that never wanted to play this sport in the first place.
And this gives them a way out.
And this gives them a way out, and they come in ready to take that way out from the very beginning.
Right.
And they don't change no matter how good they look.
Right.
On a physical exam. And so I think it's a question of parenting. I think it's a question of why do you play sports that put your health at risk, and probably one that kids don't get to make consciously on their own sometime is sort of the take I'm getting from this. And I believe that's the group that is the predominant group that does not return to play from looking at this. But I'm very interested in the outcome of this study. I think it's going to turn into 20 more studies after it because we know very little about the mental health or mental readiness, and I do believe it's something that's going to play a critical role, not only in coming back, but succeeding after you come back.
One of the things I looked at when I was getting my master's degree was applying this Kubler-Ross 5 stages of death, but obviously to injury.
Right.
And what we found was, anger, denial, depression, bargaining, acceptance, and that third stage of depression that's the one that we had to watch out for, because
Right.
obviously they're going to be angry and they're going to deny that it happened. But once they got it in, how fast can we get on board a sports psychologist if we need to prescribe some anti-anxiety medicines, some depression medicines to get them over, and then finally get them to bargaining and then acceptance, and they go through all these different phases when the injury happens, and then when they're in rehab, and then when it's returned to play. So
Yeah.
I think your study is going to be huge. I think it's going to blow the lid off a few things.
Yeah, totally into that and agree with all that. And it's going to make us all better at doing this, So
before we let you go, because we know your time is very, very
That's right.
valuable, tell us just a little bit. I was as skeptical as you were about dry needling.
Mhm.
And one of my good friends, his name is Seth Kaplan, president and CEO over at Baton Rouge Physical Therapy at the Lake in Baton Rouge, Louisiana. And I had him come and do some continuing education units a year and a half, 2 years ago about dry needling. And I was as skeptical as you were, and I was a patient just like you were, and I said, you know what, I don't believe this works. Show me. And you know what? Boom, it worked. So tell us a little bit about your experience and where you think this is going in the sports medicine world.
Well, so here's my testimony, for that. So I run, I lift, I work out pretty hard, lost 50 pounds in the last year and a half, and have really tried to get my act back together. And part of the issues with that for me has been a left hamstring that just tight, and I could jog at 5.5, 6 miles an hour, but if I wanted to open up and run some intervals or do that kind of stuff, boom, there goes my hamstring, my glute shut down, I can't, and then I'm crippled for 3 weeks, and I get off my deal, and I just fought it for literally a year. And so Jeff Kaplan, our head trainer and physical therapist at the Texas, goes, just let me dry needle you. And I'm going, that doesn't work. He goes, just give me one shot at it. Right. So I said, I got to do something. Let's do this. And so literally 6 needles in my hamstring, 3 of which got major twitches. Never felt them go in, but boy, when they get in that trigger point, where they are. And I go, so what's this doing? He goes, it just resets the neural firing pattern. Your hamstring will let go. I promise you it'll do that. And so I literally got up off of the dang table and was well. And sprinting the next day, no issue, that kind of stuff. So I went, okay, there's something to this, because I was a huge skeptic and didn't think it was going to work. So that transcended for me to watch it a lot more closely, what we do. And, there are a lot of muscle-related things, and the same thing for the release therapists and other things approaching it in different ways that keep guys off fields.
Right.
And little adductor issues, little hamstring issues. They're not all pulls. They're not all injuries. And those things respond very quickly. Your cuff responds very quickly to it. There's just so many things that just resetting the little trigger points makes a big difference. So it's not the end-all be-all cure-all, but as an adjunct to keep function at a higher level and to be able to play when you might not be able to from these issues. It's the biggest change for that I've seen while I've been doing this as a team physician, I think.
Right. It's one of those tools in the toolbox, and before that, our really only access to trigger point treatment was this combo unit of E-stim and ultrasound, and you try to nail the trigger point, and hopefully it releases, and if it doesn't, you went to active release or Grafton or something along those lines.
Right.
Yeah, great.
And I think, like you said, it's part of the toolbox, and when it fits, you use it, and it works great.
Well, Dr. Lowe, I want to thank you very much for your time. We really appreciate what you're doing here for the sports medicine community. We know that what you're doing is making a huge difference in what we all do. So we really appreciate it. For more about Dr. Lowe, you can go visit him at, again, our website at www.hhp.uh.edu/MAT. Look under our link under partnerships. And again, we've been fortunate enough to affiliate with Dr. Lowe and his group. And again, he gave you his email if you have any questions. And again, can you give that to us?
It's walter.r.lowe, L-O-W-E, at uth.tmc.edu.
Thank you very much.
Great. Thanks, Josh. All good.
Out of curiosity, Seth, he's done, he's got affiliate with LSU. He does it all the time. Seth and I, very, very good friends, and I'm good friends with the athletic trainers from LSU. Would you be interested in just throwing something out and having Seth come out and doing some dry needling stuff?
I wish we had it in the UNH training.
Try.
I'm forcing Wayne to send our therapist. He doesn't like it, but I beat him up again about it.
Well, and what I'm doing is, the last year I've been kind of hammering away at Well,
Mike's just so old school.
well, you know, it's one of those things of like, okay, Mondays I have to go to NASA, and Mike can't get it through his head. Like, are you taking the astronaut tables? No, it's not what we're doing.
Right.
Doing stuff up on when they're on station and stuff.
Right.
Cool. Okay. Thank you. Yeah, Sean, listen, Wednesday we're going to stop by with the group. Cynthia said that you're probably in surgery, but maybe if you can, pop your head up and say hi.
Oh, well, I think I had a pretty good day. I had 6 or 7.
Is that Josh? Hey, where's the food?
You got it?
Yeah, I saved it. How do I rename it?
What?
To rename it.
This one. And then the Dr. Phil.
Can I go to the restroom real quick?
They should be coming in. She just finished her talk, so. Go ahead. I'll be here. Got about 5 seconds. All right, so if you're still listening live, then that was Dr. Walter Lowe. He is you heard all about him from Dr. Yellen. So next up we have Dr. Roberta Anding. She is, she is the registered dietitian. She works for the Houston Texans, but she'll talk about that as well. So stay with us. That's what we have coming up is Dr. Anding. So, and of course, I am Jeremy Jackson, the host of the Sports Medicine broadcast, and I'm thankful to be having the help of Dr. Yellen and have some of my students here. I have Dr. Knobloch and Bill Hale. All of them are working into tag team interviews, and I'm running just the technical end. So you won't see me too much on the audio, but I am here. So thanks for listening.
Sometimes, and I have to tell you, I'm James this summer. Yes. Okay. In Fort Worth, Eve Pearson is in Fort Worth, and Amy Goodson is with the Cowboys. Eve Pearson and Amy Goodson. So if she's up in that area, so she's TW Denver. Yes. And if she's in the nutrition exercise science group, Nancy DeMarco is as good as it gets nationally. So she's in an outstanding program if she's there. Interview Houston, you know what it is. not so much.
Did you know Penny Wilson?
I knew Penny Wilson very well.
Her and I got our doctorates together.
Penny was my graduate student.
Really?
Yeah.
She just moved to Colorado. You may have known that.
No, she did her fellowship training for the LEA program. She did it at Baylor with me.
Really?
Yep.
Yeah, she started a year after I did, and then I got done. Or she got done before I. She switched over to more of a obesity.
Yeah. And she did her master's thesis with me.
Really?
We did it with the Girl Scouts, and we did a program on the Texans website. So
probably met Jeremy.
Yep. Nice to see you.
I'm new at this too, so I thought what we do is I just introduce myself, I introduce you, let you kind of get a quick background.
Okay.
What I would like to talk about is more trends and things for athletes, and talk a little bit about what you talked about
Can I piss people off?
I'd love to. So,
This is your show. You're the expert.
Yeah.
So where is this going to be played?
All right, so right now it's actually streaming, so everything you're seeing right now is streamed on Google Hangout, and there will be on YouTube, on my channel there.
Okay.
And then once I
But
get,
it's all radio.
well, no, this video, it's
Okay.
the webcam there.
Okay.
And so then afterwards, I'll put your talk in there together with this interview, and then post those on the sports medicine broadcast.
Okay, so I don't have to do my whole PowerPoint
No,
again.
no, no. This is just follow up. This is just.
Kind of informal.
Okay. I did a radio show for 6 years, so.
So you sit at one of
You'll
those
probably tell me what to
microphones
do.
and- Yeah.
No, Dan Riley and I did a radio show first on Sports Radio 610, and then we moved over to 790.
This is Jen goes off. She'll be a junior at Texas A&M. She's an athletic training student. So.
Awesome.
All right, so they're recording. You're good to go.
No, I don't hear anything. Is that all right?
Well, talking to your microphone.
Testing, test.
Testing? We're all right? Okay. Ending. Mhm.
Sorry. She's just given a great talk on sports nutrition. I'd like her to introduce herself briefly, and then we'll get the interview started.
Yeah, I'm Roberta Anding. I'm the Director of Sports Nutrition at Texas Children's, and in that role, I also take care of the Houston Astros, the Texans, the Rice Owls, and the Houston Ballet.
So one of the things I have to ask you, general question you've probably heard 1,000 times, do athletes need to supplement or not?
Well, do athletes need to supplement? The quick answer to that is no, depending on how great their diet is. The one exception I would make is oftentimes we need to supplement the injured athletes because they're a little bit different breed than the healthy, well guy walking down the street.
And you hit a second topic I love to talk about is trends. And you talked about leucine briefly.
Yeah.
Before we get into leucine, I really want to know, in your opinion, you see this on TV all the time, buy this product, no, buy this product. And would you say that the trends that you see, because they're a trend, they come and go in my opinion, would you say what percent, or just give your background or your opinion, what percent of trends actually work? Because these athletes will come to us as athletic trainers all the time, say, I saw this on TV, and my friend took this and he lost weight. My friend gained 50 pounds of muscle by taking the supplement. What is your opinion on trending? You've seen a lot of it's advertising, but could you just briefly talk about that?
I think only about 25% of the things that become trends actually have some clinical science behind them, and that's the real challenge. So, for example, people can use oxygenated water. Well, there is no such thing as oxygenated water. Oxygen's a gas. You really can't do that, and so people will buy very expensive equipment in their house, may drink more water, but the reality is it's not improving performance because it's oxygenated. So I think there's lots of things out there like that, and the science, if you look at it online, almost seems too good to be true, and that really should be a red flag for us. The stuff that does work, and I do think there's some good science behind leucine, as you mentioned. I think there's also some fabulous science behind beetroot juice, and probably a few others like watermelon juice and pomegranate concentrates are coming down the pike that actually do appear to improve athletic performance. So the hard thing for today's athlete is they have to rely on their ATC, hopefully dietitian and their strength coach to get the evidence-based stuff and stay away from the stuff that's being sold at the health food stores.
And how do you're science-based, and I now love research. I hated it when I was a clinician, but how do you tell an athletic trainer how do you help them differentiate when these kids bring this, or their parents call them and say, like you mentioned something about Ensure, but we'll get to that in a minute. But they call you and they say this. How do you handle the parents or the athletes that don't have the science background without just saying, no, that's wrong? Because you're going to I think you'll get into a head-to-head headbutting contest. Well, it is right. No, it's really not. How do you approach that?
I think that's an excellent question, because your goal is to keep that athlete and their parents in the athletic loop. You want them coming to you. So I kind of look at this and say, if it isn't going to hurt you, if there's nothing in there that I know is going to hurt you, but the science doesn't prove that it works, to me it's a wash. And if you want to spend your money on something like that, as long as you're getting a clean product, which I think is pretty important, NSF certified or Informed Choice for Sports certified, then I'm going to let it go. But the stuff that is known to cause harm, like OxyElite Pro and Jack 3D, the answer is no, and here's the reason no. Because they're dangerous, they cause liver failure, there's lots of problems with those supplements. But the ones that kind of are in that gray zone, as long as they're not going to hurt you, I'll probably let that one go.
And something else you hinted on, and I thought it was a great topic, is you have inner city kids that can't afford supplements. So what do you see? For example, you have the supplement, or you have the product, you have the actual natural product, such as milk. Do you supplement the whey protein, or do you drink milk? Do you see a difference in that? Or obviously the supplement is more concentrated, but some supplements whatever your body doesn't need, it gets rid of. So do you recommend, or is there a difference? Let's say you have athlete 1 that can afford it and you have athlete B that cannot afford it. Will you expect to see a difference in performance or healing, whatever, or do you think there really is a difference, or they just say go whatever's cheapest?
I don't think there is a difference, because if I can get someone to improve the quality of their food, and improve doesn't mean you're eating all organic and that you're steam cooking all your vegetables. It's, do you have a good sports nutrition plan as a base? Again, Stu Phillips did some really great science on whey protein, the isolate, and compared it to fat-free fluid milk, and there really was no difference. I think the synergy of real food components, so say for example you have milk and berries together, is really more beneficial to you in the long run as a human and as an athlete than getting the resveratrol from a supplement and the whey from a supplement. So being a sports dietitian, I'm a real food person first, because I think that synergy of real gorgeous food on the plate is infinitely better than potions and pills.
And I'm going to save my next question that when you said it, you're a real food person. But my first question is, can you just talk briefly about regulation of supplements?
They're not.
They're not. And so what does an athlete need to know about that?
Yeah, they're not. And so I think the world, and of course, taking care of athletes, I consider myself an advocate for them. And I'm on the NFL supplement committee. I think that the challenge is when companies lie, the athlete is held out there as a cheater if they test positive. They're sticking a needle in their behind, when most of the time, in my experience, it's not that. There's always going to be a handful of people who knowingly dope, and what can you do? You're not going to fix that. But for a lot of people who test positive, it had really nothing to do with them intending to dope. It's dietary supplements. And it is true in the NFL and the NCAA and every governing body, you and you alone are responsible for what goes in your body. But what do we do when the company lies? StarCaps is a great example of a company that lied. They put in a banned diuretic. 6 NFL players tested positive. One guy who played for the Houston Texans was cut because of his unique position, and he never played another down in the NFL. That was the end of his career. He was a great position player and ended up losing his career over a dietary supplement. So I think the challenge is with dietary supplements, because there is no oversight. And I know the manufacturers will take me to task on this, but I've just seen too many companies, too many products that are out there that cause significant harm and danger, that we need to look at that industry a little bit differently. So to me, and you can get these apps for your phone, NSF certified for sport, so it's Nancy Sam Frank, NSF certified for sport, or Informed Choice for sport. You can look up your product, and if it's not on that list, I would tell an athlete, don't take it. You're risking your career, and again, depending on where you go to college and depending on how good your teams are, you will be drug tested, and you would hate to see someone lose a scholarship because of a company that didn't tell the truth.
And you can't tell them, you can't say, well, sorry, I didn't know it was not in there.
No, you can't.
But like,
no.
Yeah, like you said, there's good and bad companies. The problem is the 1%ers or the 5%ers ruin it for everybody else.
Everybody else, absolutely.
Yeah, that's a very good point. So what do you tell, and you brought this up in your talk too, well, you mentioned it, but what do you tell the athlete that, you said, go to GNC or get something that you think might be regulators from a recommended company, and they say, well, I can get it on Amazon for half price from this company. How do you respond to them?
And you've seen the expose on Amazon in the last 72 hours where people can buy prescription drugs without a doctor's prescription on Amazon. So to me, the answer is no, unless it's an NSF certified product. And when you're a high school or collegiate athlete and you've invested all of this time, 30 hours a week, do you really want to throw it away based on one egregious error? And again, nobody cuts you any slack because of that NCAA.
Saving $10 costs you a career.
Cost you a career, absolutely.
Now, something that you hit on, you mentioned briefly, and I said it's interesting to me, is you said you're natural foods. How do you handle these athletes? And again, I think it's a trend in my opinion, but you can talk about these diet trends. I'm gluten free now.
Yeah.
How do you obviously it's a performance issue, but are diets okay, or do you when they're doing it for, and I love this, Jimmy Kimmel did a great piece on the gluten free. He asked gluten free people, what is gluten? They had no idea. Some of them, obviously, I'm sure he didn't show everybody that did know, but there was a lot of people that didn't know. And so these trends come out, and then my friends doing it, or the paleo diet, or the gluten-free, or whatever. What do you say, and which diets are okay? Which do you recommend they stay away from as a performing athlete?
Well, gluten-free, and I think you hit the nail on the head. If you have celiac disease, chances are you know it, or you got a lot of GI symptoms that would lead you to a gastroenterologist. And so the people who, and I have a distance runner who's phenomenal, who really does have celiac disease, very brilliant. She knows exactly how to manage it. She eats gluten. She'd be unbelievably ill. Then there's these people who have gluten sensitivity, where they feel sort of nauseated, sick to their stomach, some non-specific symptoms, that they go off gluten and they feel better. That doesn't mean that just because it's gluten-free, it's good for you. A gluten-free donut is still a donut, so it falls into that category of crappy food. So just because I make it gluten-free, and I think that's, to me, as you talk about diet trends and how consumers are sucked in, is they'll take a word that no one really knows. Gluten's been in food forever, and they don't really know that term. And so the minute I say gluten-free, it's something else. So if you want to be a multi-gazillionaire, take a food ingredient, label it the something-free diet, and now
I've said that very same thing.
And now you're good to go. With paleo, I think there's some differences there. And on the paleo diet, you can actually get carbohydrate from fruits and vegetables, although less. So I do think for some individuals, like I mentioned in my talk, that lineman that is 300 pounds and really is not that aerobic athlete, putting him on a lower carbohydrate diet isn't going to hurt him. If I took that same football team and put a wide receiver on that diet, the chances are he is going to run out of gas because there's not enough carbohydrate. So unfortunately, in the trendy world, carbohydrate is damned as the evil demon. And too much of anything is going to make you sick. Too much of anything can make you fat. So I think the challenge is to try and educate people. And again, to me, it's this first do no harm. If it isn't going to hurt them to do it, then I'll show them how to navigate, particularly over at the Texans and the Astros. I'll show them how to navigate our cafeteria to get that done. But if it's going to hurt them, or it's a cleanse, or something else that's basically, I don't know, something that's going to cause diarrhea.
Caloric restriction.
Caloric restriction. Then my job is to make sure that if they choose to go down that path, that they know what the consequence is. So certainly with you in the athletic training world, me in the sports nutrition world, you can't make somebody do something. But our job is to be the consummate educators and stay on top of the science and not the hype and the trends.
Now, being that you've worked high school, college, and pro, do you see, in terms of compliance, do you see athletes as being more compliant than, say, somebody that needs to go on a low cholesterol diet because they're obese or whatever? Or do you see athletes as more of I'm only here because I was told to come talk to you, but I'm going to do, are they really innately tuned into their, or is it that big a deal? And I'm sure there's variation, obviously, but what do you see, or do you see high school athletes as more compliant and pros as more? What do you see in terms of level?
I think it's a personality thing. I think the higher up the pecking order that you get, I think there's more suspicion because everybody wants something from you. So if you're that premier running back for pick your team, you've been approached by a gazillion different people. So there's a different level of cynicism. And in my response, whether it's Rice or the Astros or the Texans, I always say I work for the player, and my job is to make them better. And if they're a little suspicious of me, it's my responsibility to earn their trust in some way, shape, or form.
Become an expert.
And that's my job, whether it's doing a body comp for them or whether it's helping them when they've had a wisdom tooth pulled and they don't know anybody to go to the grocery store for them. It's my job to build that trust. And I think when the trust is there, I think athletes are much more likely to have you as their resource. So without naming names, I've done that. I've gone to the grocery store for guys that are sick and don't have any family in town. I've worked with their wives. I've worked with their girlfriends to help improve the quality of the food that they're being served at home. And I've helped players who have sick kids get resources in Houston. So it's kind of being that contact person for health and wellness in these organizations that I think ultimately gets the trust. And the climate's changed. I can say my first year at the Texans in 2002, when I took away the fried chicken and the cookies, I thought I was going to get my tires slashed. I said, don't tell anybody I drive a Tahoe. Don't let anybody know, because I didn't want anyone to know, because I was, honestly, players were pretty upset with me. Now I'm being asked for brown rice, and can we have quinoa, and what about edamame? And I'm going, the tide has turned in the last
10 years,
yeah,
but it clicked
it's all right.
finally, huh?
It's all right.
So something that, and I want to wrap this up, but something that really stuck out to me, and I thought this was funny, I laughed out loud when you said it, is you gave your son jelly beans before a race.
Mm-hmm.
Now, when I went to school, and I did the athletic training hours and the carbo classes in the mid-'90s, and we were told, don't ever give simple sugars because there will be a crash.
Yeah.
And you said you gave your son, now he's a sprinter and he's anaerobic, obviously, but what is can you talk about that just briefly about,
because I think that's an excellent
somebody's even
point.
said, don't give him Gatorade right before, because if you give him one cup, it'll burn off and then they'll crash. But
it depends on their leanness. And in my experience, if I've got someone who's, and I have a bod pod, so I only can use my bod pod numbers. If I get guys that are below 5% body fat, I actually think that's true. I think they do crash. And so I think if you're that ultra elite marathoner, I don't think you can maintain your blood sugars with a very high glycemic index carb, and that's what Gatorade or jelly beans would be. And so for those athletes, if I have someone who's freakishly lean like that, I might want to put a little whey protein in that product. So I will use a medical grade whey, dump it into the Gatorade, and that tends to prevent that blood sugar from going up and down and falling like a stone, because you clearly don't want someone half a mile into their race, shaky, weak, diaphoretic, sweating like a son of a gun, based on the fact that their blood sugar is now in the 30s because they couldn't hang on to that glucose. So a lot of it just depends on how close to the race it is and the individual athlete. So I had a girl who was a pentathlete at Rice, and we tried everything to get her something in between her events, and the only thing she could tolerate is red licorice. And so when she made the Olympic trials in the triple jump, she took a picture of her red licorice and texted it to me and said it still works, because we tried everything else and she was throwing it up. Wow. So this is where your job and my job become really fun, because we're not looking at identical twins, and it's taking the science of sports nutrition, taking all of your knowledge and trying to help that individual athlete and not cookie cuttering people. So that's a very astute question, that those freakishly lean individuals tend to not tolerate simple sugars without a crash and burn, in my experience.
Excellent. Last thing I want to bring up is a trend you mentioned, leucine.
Yeah.
What are you seeing in this? Because when I went to school, it was creatine. You got to supplement with creatine. And then there, and then that went away, and something else came along. And I'm hearing from an expert that leucine's showing
Yeah, it
showing
is.
positive results. What
It
do you
is.
see? What are you seeing in that, and what kind of athletes, and what should we know about that?
Yeah, that's a great question. And leucine falls into that category. And so here's our new diet trend, the leucine enhanced diet. It falls into a category of protein called branched chain amino acids. And there's three: isoleucine, leucine, and valine. And of those three, so a lot of athletes will use branched chain amino acids in the middle of their workout to maximize strength gains. And leucine appears to be the one that's the rock star. And the best dietary source is milk. And I don't work for the Dairy Council, but that's just the way it is. It's milk, not really yogurt, and not cheese. It is milk. And so what Stu Phillips and Luc von Loon and some other protein researchers have found is that it really appears to be the anabolic trigger. Leucine, of all the 20 amino acids, appears to be that anabolic trigger, meaning it helps promote muscle protein synthesis and probably just as much prevent muscle protein breakdown. So I think you're going to see a little bit more trend towards leucine and leucine products that are on the market. With very few exceptions, there are not NSF or Informed Choice certified leucine products. You have to get the whole enchilada. You have to get a branch chain product. But look for NSF branch chain amino acids if you're looking for a product to try. I do think, again, when everything else is great, that they're compliant with the athletic trainer, they're busting their tail in the weight room, they're working with me. If there's discretionary money, I might say this might be worth a try. For my inner city kids, I would never do that. I would use fat-free milk. They can get that in the cafeteria. I can write them a note that they need extra cartons of milk, and it becomes a very easy way. The exception is we don't really have a great solution in a school-based environment for kids that are lactose intolerant. There's not a lactose-free milk in most schools, and so I probably would give them something like Dairy Ease or one of the lactase enzymes. That's where I'd spend their money, is to get them to take that before they drink their carton of milk. But to me, it's a food-first philosophy. The challenge is people don't think branched chain amino acids come from food. They certainly don't think leucine comes from food because it's a name. It's something that they don't know. They don't know that that's a food ingredient.
Think it's a product.
Yeah, they think it's a product, not a food.
And they probably announce it as leucine, or they'll call it leucine 500 or something.
Yeah, exactly.
So you heard it from an expert here that leucine is legitimate. So thank you for your time. Do you have anything you want to add or anything like that?
No, it's just an honor to speak with you, an honor to talk to my favorite groups in the world, strength coaches and athletic trainers. So it was a great experience for me, and thanks for having me.
We're what do we call it, journeymen. We know a little about nutrition, but when we can get an expert
we're teammates. We're teammates. That's what I'm going to say. We're teammates.
But athletes come to us first. You mentioned
you got
a lot of times we're the primary care right there, but we need to be smart enough to know when we need the big guns out.
Yep.
So thank you for your time. A great talk, by the way.
A-okay?
I hope so. She did great.
I'm going to say, because I can BS with the best of them.
If you BS, you fooled me. So we got it. Good.
We're all set? Okay. Off to my day job.
We can keep you here longer if you need us to.
Off to my day job. Anytime Bob asks me to speak, he's just always so gracious. Now, as long as I don't have to listen to it.
Only if you go to sportsmedicinebroadcast.com.
No, but I may send you the link, and then you can push it out there if you want, or you can delete the email, whatever.
You guys were great. Thanks for having me.
Thank you so much.
She said the the volume was up, the recording
the
volume, and it just blurred everything.
Yeah, I mean,
Yeah. We gotta get some pictures, man.
I thought it was awesome.
well,
She
I
did
took
great.
a couple, and I just tweeted one.
Yeah, we gotta get some pictures. I want group pictures so we can put them up on the website. My website.
I tweeted.
Did you plug our website?
I tweeted. It automatically puts up that you were talking to Lo. I'm going to tweet that I just interviewed Miss Andy. So everything I tweet goes on the website.
But did you plug our, when I start off with Lo?
I mentioned what I do.
This is Dr. Josh Ellen.
Just so you know,
I just said
it's still live. So if you want to jump on there and talk about your program, talk about which mental part, it's still live.
They heard it,
Yeah.
I hate that.
And the camera's right there too.
Perfect. Hey, this is Dr. Josh Yellen again coming at you from the Memorial Hermann Sports Medicine Update, 13th annual, hosted by. Yeah, I am. Hosted by Memorial Hermann and UT physicians. Coming up next is going to be Dr. Flores. We're going to ask him a few questions. But in the meantime, let's talk to Jasmine about. We learned that Jasmine is an undergraduate student at Texas A&M. Jasmine, what are you majoring in?
I am a kinesiology major.
And what year are you?
I will be a junior in the fall.
So you've already gone through freshman and sophomore classes.
Yes, sir.
And what classes have you had already in your kinesiology major? By the way, what's the definition of kinesiology? Do you know?
You want
It's the art and science of human movement.
Mm-hmm.
Okay, so what classes have you had already? Have you had a A&P1?
Actually, I'm taking that this summer.
Okay, have you
So-
had an A&P2? No, you can't do that until you have A&P1.
Yeah.
Have you had biomechanics?
No, sir.
Probably not until you have A&P1. What about statistics?
I have not taken
How about psychology?
psychology.
Okay, so you have one of the prereqs for the University of Houston Master of Athletic Training Program.
Mhm.
What about motor learning, functional anatomy, nutrition, any of those classes?
No, but I've taken musculoskeletal anatomy.
I'm sorry?
Musculoskeletal.
So that's actually a recommended prereq, so you're right in there. What do you think about musculoskeletal anatomy? That's like a functional anatomy.
Mhm.
It's really interesting, right?
Yeah.
This is
It's
what the
really cool.
muscles do.
Mhm.
This is how they interact. This is how they work.
Yep.
Okay, and so you're thinking about applying to the University of Houston Master of Athletic Training Program.
Yes, sir.
Yeah. If you want to look at the prerequisites for what you need to do to get into the program, what you need to do is go to our website, www.hhp.uh.edu/MAT,
Mhm.
and you look under the application process. And the application process is going to show you exactly what you need and what classes you need and the grades you need and so on and so forth. You're going to need to take your GRE, and you need to do well in that GRE, and it's used as the GRE is used as a weighted scale, so we use it as a part of your evaluation process.
Okay.
All your classes, you need to have a 3.0 in your major, and you need to have a 2.6 or higher in your cumulative GPA. So like you're going to take classes that, like 13th century English literature, right?
Yes.
And so that's not something that we look at. We don't use that as a predictability standard for how well you're going to do in the program. But we use some other classes like A&P1, A&P2, psychology, statistics, exercise physiology, and biomechanics. And then some other recommended courses like your, what do you call it? It's not a functional anatomy, but it's called
Musculoskeletal.
musculoskeletal anatomy. And then we use nutrition and we use motor learning. And that whole package together, we say, hey, I think this is going to be a pretty good predictability of how well you're going to do in this program. And you take your GRE and you submit it. You also need to go through 50 hours of observation with a board-certified athletic trainer that, if you're in the state of Texas, needs to be a board-certified athletic trainer and a state-licensed athletic trainer. So those initials are going to be ATC, LAT, and then whatever other alphabet soup comes after that. And so as you're looking for the program, you need to make sure that you're getting what you need to get, for all your prerequisites, stuff like that. So why do you want to do athletic training?
I didn't do it in high school. I played sports year round.
What sports did you play?
I played volleyball, basketball, softball, some track.
Well, you really did everything.
Mhm.
What else did you do? Did you play any instruments?
Yes, I was in the band. I
And what
played
instruments
flute.
did you play? You played the flute.
Mhm.
So you played 4 or 5 sports, and you played the flute. And how well did you? Were you a good student?
Yes, sir.
What was your you straight A's?
Not straight A's, but my GPA
Pretty close,
when
A's
I
and B's.
graduated was like 4.
Well, good enough to get to A&M. That's a
Yeah.
good school,
Yes, sir, it is.
right? So if this is your 3rd year, you started A&M in 2012.
Mhm.
Is that right?
Yes, sir.
And so what was it like? Right, you're born and raised in Pasadena area,
Mhm.
and then you moved to A&M is where College Station. So you moved from Pasadena, Houston, Texas to College Station.
Yes, sir.
Tell us a little bit about that.
Well, College Station is a really small town. Most of the university takes it up.
Yeah, keep going. You can't just say College Station's a really small town and
It
stop with it.
is.
Hey, Bill.
Hey, what's up?
No, yeah, it's a small town, but what'd you learn about college? Is he coming right now? You want to sit around the table? Sit around the table. So tell us more about college. Stop laughing at me. Tell us more about college. What'd you learn?
A lot
Nobody
of stuff.
cares if you go to class, right?
Yep. Nope.
What was that like?
Kind of upset. A lot of the kids that don't show up to class make better grades.
Well, that's okay.
Sometimes.
Yeah. What sometimes. What else did you learn about college? Your first semester. Let's go back to your first semester. You know, when I was before I got to the University of Houston, I'm graduate faculty now at the University of Houston.
Mhm.
Before I got there, I taught the undergraduate athletic training program at Southeastern Louisiana University.
Okay.
And I always taught the Intro to Athletic Training course. It was ATHD 141.
Mhm.
And the first lecture was always about time management.
Oh yeah.
As a freshman, oh yeah. And so as a freshman, how many hours are in the week, do you know?
In the week?
What's 24 times 7, do you know? What's that number? You already went through college algebra, right? So this should be easy for you.
I can't
24 times, I can't do it in my head. 168 hours in the week. And so what I always talk to the students about was, hey, listen, you got 168 hours in the week, and let's start breaking that down. Let's find out where that time is being allocated to.
Mhm.
And once they realize that, hey, man, wow, I'm in class now, and I got to be able to study and do all these assignments and be able to get to class on my own and manage my own stuff. And, you know, all the way up until now, my mom's been doing my laundry and my mom's been doing all my grocery shopping. And if I miss class, nobody, you know, it's not like the school district calls my house to let my parents know that I missed class. And so,
Yeah.
you know, it's what we like to call accountability,
Mhm.
right? Freshmen need to have accountability. You got to get to class and do the work on your own. What happens if you don't get to class and do the work on your own? Look, she's avoiding the camera. What happens if you don't get to class and do the work on your own?
You do not pass.
You can't move your hair to cover your face.
You do not pass your classes.
You don't pass, you fail.
Yes.
Yeah, what happens when you fail? You know what happens when you fail your
Scholarships get taken
Yeah,
away.
that's right. Money gets taken away, right?
Yep.
Because now you're a liability to the university.
Mhm.
You did not perform the way you needed to perform, so you lost money. In the college system, you're put on probation for a semester, right?
Yes, sir.
And if you don't bring that up, what do they tell you? Get out.
Sorry.
Get out.
Yep.
That's right. And down goes the dream. You know, every time I see Jeremy Jackson or hear one of his students, you know, his students don't address him as Mr. Jackson or Mr. Jeremy. They address him as Jackson. And I think of two things in my head. I think of Action Jackson. Or I think of the song, Sorry, Miss Jackson. And so every time we do this and we're over at Pasadena High School, I'm with Jeremy Jackson. And he says, they always say, hey, what's up, Jackson? And I go, Sorry, Miss Jackson.
Ooh, I am for real.
Yeah.
Yeah, I heard that a lot growing up.
Did you? Sorry, Miss Jackson?
Yeah. Especially, you know, I have two sisters, an older sister and a younger sister, and so.
We have a student in our program, Matt Coleman, and Matt Coleman has a voice like Isaac Hayes. I cannot get that low. And so we met Matt Coleman,
Mhm.
right?
Right.
And so we're going to try to record Matt Coleman for him to say, oh, yeah.
We should get him to do some sort of like little hook, and we can just throw that in there, you know.
That's right.
'Cause I'm always looking to improve, and so you know, you have some cool little deep bass voice.
Hey, tell us
Welcome
about
to
that
the
experience.
Sports
You
and
came broadcast. You came to the University of Houston last Wednesday, and you set up shop. I understand the audio was a little bit bad that day, so we apologize for that.
Well, that was all me.
But tell us about your experience about setting up. You met some of the MAT students. You learned some things about our program.
Yeah, honestly, it was awesome to be able to go out there. And I was telling Sarah, you know, the meeting of you guys is really, I believe it's God putting you guys in my life at the right time, because I couldn't have done all this by myself. I could have set it all up, but I couldn't have listened to the interviews, brought them in here, interviewed them, started the recording, done the recordings in there. I couldn't have done it all by myself. And what I really needed was somebody who was good at interviewing, somebody who was good at talking, somebody who was what I would consider an expert in the field.
And I can talk for days.
And
I'm an expert in the field.
Exactly. And so, you know, that, like I said, that's just God putting people in my life at the right time to do things. And so, you know, we had the chance to come out there and come to your turf instead of it, you just always coming to us. We got a chance to come out to and talk with you, meet your students, and it is really sad that the recording was bad, but the live YouTube was good. It's better.
Yeah. So we were on YouTube.
Yeah, so the YouTube one is better, and my wife said it sounded kind of canned, and that's because we had the mics. We were just kind of.
What do you mean canned? It wasn't like a canned speech, but it sounded like we were speaking out of a can.
Yeah.
Yeah. Okay, I understand.
And so instead of if we're talking right here, it sounds really good. And
the acoustics in the room were bad.
Yeah, or
probably because of how big the room was.
Or just because of the mic placement or whatever. But I don't know. Anyways, so the program, I'm pretty excited that we're gonna get to talk with some of the students. I know Nicole, the first person we talked with, she seemed to be doing really well. Like she seemed to really get into it, like enjoy talking, and some of the students were a little nervous about talking. Some were just fine with it, and so it was really cool. I think they're going to really learn a lot, and I look forward to meeting a bunch of them. So.
Yeah, I think this is going to be a really unique opportunity. One of the things in athletic training that when you look at the scope of practice is organizational health and well-being.
Yes.
And
you need to go grab him and bring him here.
Dr. Flores is coming here, and so organizational health and well-being, and part of that is marketing and promoting. And so whenever students have an opportunity to market and promote athletic training,
you bringing Dr. Flores stuff in? Yeah. All right.
His backpack.
Oh.
All right.
Yeah, just leave my stuff around.
So would you mind we're just walking them over?
Oh, I thought you said you were bringing it.
Hey, can we move this like further back because it's like covering your people's faces on this right there.
It's that mic right
Yeah.
I know, but
I don't know.
I think if you move it down a little bit.
all right. So if you're watching live, the camera's gonna be really bad for a minute.
Are you having fun?
Yeah.
Stuff recording, saved them.
And I renamed them. That's better.
Yeah, it's a lot better. Maybe a little bit.
Guys, just so you know, we're getting a really good shot of your rear. So your rear end will be famous because the camera was getting a real good shot.
Awesome, thank you. Like my mom says, I have a nice tush.
It's probably better to get that than what we're saying.
That's a nice tush. And then we have Dr. Flores coming, and Dr. Flores is a Texas A&M grad. Is that Gig'em? Is that what that is? What's a Gig'em?
I know what a gig is.
Why do they say Gig'em? You go to Texas A&M and you don't know why they call it
I don't know
Gig'em?
why Gig'em. I don't know what that means.
I mean, obviously, go Cougs, that makes sense. Go Cougs, Why the mascot's name is Shasta, I don't necessarily understand. Huh?
I heard the story behind it, but I just don't remember what the
Of
story
Gig'em?
was. Gig'em.
If anybody's out there and wants to tweet Jeremy Jackson,
At PHS SportsMed, or using hashtag TheSMB, and Jasmine's watching that over there. Jasmine Dozal, and I mentioned her on Twitter, so she's an aspiring athletic trainer. She was talking to Dr. Yellen earlier. So somebody from A&M give us the history of Gig'em.
yeah, where did Gig'em come from? That's what we want to know.
You know Jolly Rancher?
No, I don't want to
Jolly
Jolly
Rancher doesn't tell us where Gig'em is from, Jasmine.
Why do they call? Tell me why they call it a Jolly Rancher. Is it really? Is it a Jolly Rancher? Is it like a rancher that's really happy? I'm I'm fat and jolly. I mean, I am fat and jolly, but is it a jolly? Hey, so let's talk about real quick while we're waiting for Dr. Flores. Tell me what you guys think about the interview, or what you guys thought about the interview with Dr. Lowe. I thought he gave us a lot of information.
Come around here.
What did you guys think about the interview with Dr. Lowe? I thought he gave us a lot of information.
Yeah, I was in and out, so I didn't catch all of it. And, I'm going to obviously listen to it later whenever I go back and edit it and put the two together. But there's a reason I would like to talk to experts in the field, and it's because they know more.
Right.
I feel like, I've said it before, I don't feel like I'm an expert in anything. I feel like I know a good bit about a good bit, and so I can do a lot of things. I can do this podcast, I can do athletic training, I can definitely take care of my family, love my wife, I can build the fire truck bed for my kids, but I don't do any of them like superbly. And so just listening to other people who are experts. Dr. Lowe is undoubtedly an expert in
Right.
orthopedics.
World famous.
Yeah, world famous. And so just listening to somebody like him talk, or Dr. Is it Dr. Anding?
Miss Andy? Yeah,
Miss
the
Andy.
dietitian?
Yeah. Miss Anding, just the knowledge of these people specifically in their subject is, for me, it's really cool. And I wish I could sit and listen more, but I kind of have to go back and forth to make sure that somebody's bringing the guests in, or that Sarah's not having any problems, or Jasmine's not having any problems. But I think it's going to be real well. So here's Dr. Flores.
Lo and behold, the man of the hour, Dr. Flores, Steve Flores. Yeah, whatever seat you want to sit at. If you want to wear these headphones, you can. If that helps you. If not, you don't have to. It just depends. If you want to put on the headphones and hear.
It helps you.
Yeah, can you? It's whatever you want to do.
As long as you talk into
How do you like that?
you don't have to.
Here, let's do that.
I think I'm fine.
You like that?
Yeah, I'm fine.
Okay.
Yeah.
That's number 3.
With us here is, you guys ready?
Should be one. No. Yeah, that should be 3. All right, so we're recording.
All right, I'm Dr. Josh Yellen, Program Director for the Master of Athletic Training Program at the University of Houston. Find us at www.hhp.uh.edu/MAT, like Master of Athletic Training Program. We're fortunate enough here to be sitting with Dr. Steve Flores. Dr. Flores, thank you very much for your time.
Thanks for having me.
Tell us a little bit about you. I was reading in your bio that you came from Texas A&M, and I believe Jasmine is a second-year student, going on a third-year student in kinesiology at A&M. We were just wondering, what does GIGM mean?
I have no idea.
But we just know it is.
But we just know what it is, and we say it, and howdy, and I think we wear boots, and drive pickup trucks.
Okay, got it. And are you from that area of Texas?
I am not. I'm from San Antonio, actually.
San Antonio, Texas. All right, so you went to Texas A&M, and then you went to the Baylor College of Medicine. Is that right?
That's correct. Yes.
And then you got out in what year?
I graduated medical school, and I always have to think about this, in 2001.
And then you went on for your orthopedic residency.
Correct, in Chicago.
In Chicago. Where did you do that?
At Northwestern, yes.
And then you did your internship and residency there?
Correct.
And then you did a fellowship where?
Back at the Baylor Sports Medicine program in 2006.
And then you got picked up with UT Physicians Ironman Sports Medicine Institute in what year?
I graduated fellowship in 2007. My first 2 years, I think I spent actually still at Baylor with Walt Lowe, and then in 2009 transitioned over to UT and Sports Medicine Institute.
Walter Lowe was just here, and he talked about some of the things that he, in his lecture, and some of the advancements of being a team physician, etc. Tell us, your real specialty is in the shoulder. Shoulder's super, super complicated, right? All these different ranges of motion, and we know that, the glenohumeral joint is like sitting, what's the analogy they give? It's like a golf ball sitting on a golf tee.
Yeah, that's usually something that people can grasp their hands around and really kind of conceptualize it a little bit better. And if that tee is really not centered correctly, well, then the ball falls off. And there's a lot of different things that have to work in play. And I say the knee's a dumb joint, no offense to Dr. Lowe. And the shoulder's a little more complicated. Takes a little more work to kind of do what we need to happen.
Yeah, right. The knee goes through flexion, extension, slight medial rotation, slight lateral rotation, slight valgus stress, and slight varus stress. And then we get in the glenohumeral joint, right? And let's break up, if I go back to my anatomy, I was always taught there's a difference between the glenohumeral joint and then the shoulder complex. And that glenohumeral joint is really the golf ball and the golf tee.
Correct.
And then the shoulder is really that scapulothoracic joint, the acromioclavicular joint, the sternoclavicular joint, and all that moves, right? So for every 2 degrees of motion at the glenohumeral joint, 1 degree at scapulothoracic. Is that right?
That's perfect. You get the test answer right.
That's it.
Yes.
That's
A plus.
I
Done.
can go be an orthopedic surgeon.
Yeah, you're ready.
Okay,
we'll
good.
give you a knife and you can go.
Oh, perfect. Good. Hey, speaking of knives, one of the affiliations I made with the program is that we have affiliated with our College of Optometry, and so we have 3 fresh cadavers in their extremities. What about you coming over one day and showing us some of your work? You think you can do that?
Figure out a time.
All right.
There we go.
So tell us a little bit more about the shoulder. How did you get interested in the shoulder, and tell us some of the advancements that you're doing over there at UT Health Center.
I think it really just kind of boils down when you talk about sports medicine. The typical injuries are going to occur in a knee and a shoulder. I do both of them, but shoulder's kind of one of those things where there's more injuries, and so therefore probably more opportunity. And it's really been something that I think I've had the opportunity to really see a lot of and treat. And again, this is not just young people. This is every people of all ages. Your mom, your dad, your grandma, your grandpa, your brother, your sister, your next door neighbor, and people have injuries, and a lot of these don't need surgery. And unfortunately, a lot of people get surgeries that they don't need to have done. And a lot of these can be treated with rehab. Probably the vast majority of them can. And there's a small subset that really need surgery, and some of the more arthroscopic or little camera with small incisions around the shoulder joint. Those are kind of been some of the benefits and advances in the surgeries, in addition to probably some of the biologic stuff that you guys talked about earlier, I'm sure, with Walt. Those are kind of some things that we're really seeing as helping people, whether or not things will change in the future. I'm sure they will. Everything always does. But I think, as we gain more knowledge in each joint, we're able to better treat people and get better function and better results.
Tell us a little bit about your philosophy of surgery, right? I was always taught that when you have an injury, let's try to use some conservative treatment, pat down those chemical mediators a little bit. And then I have a question for you about chemical mediators and some medicines and some of your experience. But let's see if we can really treat it with ice and anti-inflammatories, and then let's see if we can rehab it. If we can't rehab it, let's try to medicate it. And if we can't medicate it, let's go scope it. And if we can't scope it, let's go cut it.
Yeah,
right?
I'm a big believer in not burning bridges. And unfortunately, if you do surgery right away, well, that you're on the other side of the bridge, and the bridge is pretty much burned. So again, the vast majority of things can be treated with time. Time's a great healer. I think we've all had shoulder injuries. I woke up, my shoulder's sore. I had a heavy workout yesterday, and it's just kind of been bothering me. Well, most of the time that goes away, and if it doesn't, well, that's when you go see your doctor, and then at that point, maybe some medication, maybe some exercises, maybe not doing certain things will really help you. Then at some point, if all that fails, and you have a complaint that is consistent with your exam, which is consistent with an MRI, well, it's reasonable to think that a surgery is going to help you. Now, if those don't match up, it's a little more difficult, and it's probably not realistic to think that operating on this little tear that's on the MRI is really going to help you if they really don't have anything to do with each other. So I think most people don't want surgery. And
why do you think that is?
It's scary. Yeah, scared. I think you're gonna go to sleep. Am I gonna wake back up? Am I gonna get an infection? Am I gonna be better? Am I gonna be able to do the things that I did before? There's a big unknown, and unless you've had it before, and the people who had are usually, as long as they've had a good result, they're usually much more willing to go back again. If they had a bad result, they're not going to want to do it, or you're going to have to twist some arms. And if they've never had it done, well, there's definitely, you have to mentally grasp these things, and I think that's the hard thing for young people is, the unknown. We don't like the unknown.
So, one of the things that Dr. Lowe brought up was this mental preparedness of how to return from an ACL. Do you have a mental preparedness of how to return from a shoulder injury?
I think it's all basically the same. I think, mentally you need to, not be scared, because when you're scared and you kind of, try to limit yourself, that's typically when injuries get hurt, which is why, I think going in, you'd say, okay, mentally I'm ready for surgery, and then afterwards you have to be mentally ready to rehab. And if you're depressed and you're unhappy and the world has ended, you're not going to do what you need to do. You're not going to get off pain pills. You're not going to be able to return back to play. And once you can, then that's when you see good results. And some people, day one, they're good to go. Mm-hmm. And other people, it takes time. And not everybody's the same.
So one of the things we learned in school, I remember both in undergraduate and graduate school, I learned about this Kubler-Ross 5 stages of death as it relates to an injury, right? Anger, denial, depression, bargaining, acceptance. Is that something that you follow in your office, or do you have your own scale that you follow? Or you kind of go based off your clinical expertise?
Yeah, I think it goes based upon, just kind of getting to know somebody, and the more you know them, again, I think it's difficult to assign recipes to people, and I like to tell people, it's not you're not baking a cake. It's not the same for everybody, and you may be a little bit different than, somebody else, your brother, your sister, and so I think just kind of gauging a sense of where somebody is, and that's difficult. I wouldn't say that we're all, great at that, especially as orthopedic surgeons. It's really probably, unfortunately, something that we don't get taught. But I think, when you have that person and you have those issues, I think there's, definitely the healthcare professionals that, have an expertise in that. And sometimes you have to say, hey, this is beyond me. I need you to go see somebody to get right.
So it really sounds like you really value a relationship with your patient. You want to get to know who they are as an individual and who they are as a person, so that you guys can go through this experience together.
Yeah, I think as physicians, we all should at least. We want our patients to get better. You don't want them to come back and be unhappy, and unfortunately, that's not 100%. You can't bat 1,000, but batting, 333, you go to the Hall of Fame, but you're a bad doctor if you do that.
Right.
So, you would like for the vast majority of guys to be happy, and I think really, the more personal interaction you have with them, they're going to be happier with you because they think you care, and they have to trust you. I think there's a big trust issue here. So I always say, help me help you. I can tell you.
I've heard that line before somewhere.
Yeah,
thanks for moving.
Yeah, I can help you, but you have to want to be helped.
Yep. So going back to the shoulder, it's the topic that you were talking about. Tell us just a little bit about some of these various injuries. So let's give you a scenario. I have a patient that falls on an outstretched hand, foosh is what we call it, and there's some sort of posterior translation in the glenohumeral joint, possible posterior labrum, possible supraspinatus, that kind of stuff. Walk us through a case scenario like that and some of the steps that you would take.
So I think, when you think about, injuries, a lot of those can be based upon, age. So at what age do people get typical injuries? So young people typically don't have rotator cuff tears. Old people.
Why is that?
Because the tendon is much stronger, and it takes a lot of force to tear that.
And so that's consistent for all four rotator cuff muscles?
Pretty much, yeah. I mean, again, there's partial tears, sure. And you see them, but it's, common things being common, it's not the most common thing. And so, somebody falls on the outstretched arm, they feel their shoulders kind of shift a little bit. Obviously, be concerned about, a little labral injury, posterior labrum, which
what kind of labral injury are you going to be concerned about?
I'd be concerned about a posterior labral tear.
And is there a name for that?
Posterior labral tear, depending upon where it is. I mean, you could call it a Bankart tear, right. Depending upon where it is. A Bankart was Dr. Bankart, is somebody who got something named after them, and it just depends. It's classically more in the front part of the shoulder, although we're orthopedic surgeons, we're not really smart, so we just kind of add anterior and posterior, and keep one name associated with both of them. But you'd be concerned about a posterior labral tear, which the vast majority can be rehabbed and do well. The people who have continued issues, and that's typically, depending upon the sport, can affect them, or, in the weight room, trying to bench press, trying to lift. A lot of those guys will complain of pain in the back of their shoulder, because if you just imagine that ball kind of going back, it's going to maybe move a little extra, but maybe not have the same degree of instability as you would if you came out the front. There's a lot more muscle in the back to help keep you in place.
Right, and so talk about the instability, when that ball, that the head of the humerus slides back in that glenoid fossa. Tell us a little bit about posterior impingement, and then tell us a little bit about the, what do they call it? The sick scapula or something like that, where,
Yeah. So posterior impingement, again, typically more in overhead athletes. It's typically the kind of compression, or when the ball of the head hits the posterior superior labrum, so the part that's right behind the biceps tendon, and that kind of hits the rotator cuff. So you see this if you imagine, some of these, pitchers or tennis players who get in this real cocked position where their arms like kind of face in the wrong direction, like they've dislocated, but that's just their motion that allows them to generate joint velocity. Now, if you have, not very good muscular control or maybe some tightness in part of the shoulder joint, that ball may kind of ride up and cause that posterior impingement. Again, usually something that doesn't need surgery until you get to the point of no return when things start to tear, and then you kind of lose your window maybe to rehab these things. Sixth scapula is basically a condition where the scapula itself has non-coordinated or asynchronous motion. And so if you think of the tee again, we go back to our ball and tee concept, golf ball, golf tee concept. The tee is kind of the most lateral or outside part of the scapula, and that serves the base for the ball to sit. Now, if the muscles aren't working, they're not being coordinated, that base, that platform is not going to be in the right spot for that ball, and so that ball is going to move up, down, sideways, just not in the right direction, and you start having issues, typically with pain more than anything else. It's a non-surgical issue. Right. It's a rehab issue to get muscle strength, and very, very, very smart people have kind of looked at this, and it's very difficult probably to allow people to grasp and say, you need to get stronger. It's like, well, I am strong. I can bench press. Wrong kind of strong.
Right. Your scapula is just not moving. It's not retracting, protracting, and elevating and depressing the way it needs to. So that leads us into another question, two questions for you. Let's transition from posterior issues of the shoulder to anterior issues of the shoulder. I have a middle linebacker, goes for a tackle, outstretched arm, abducted, externally rotated, that glenohumeral joint, that head slides right through that foramen of Whitebrecht. Wow.
Sounds smart.
That's a big one. Foramen of Whitebrecht, right? So you've now dislocated your glenohumeral joint. You reduced the joint on the field. Tell us a little bit about from the time of injury to the time of return to play to the time of rehab, and how do you know when you need to do surgery and when not?
So, again, going back to our cookbook, very different for different guys, probably very different for positions. Some guys, are able to progress pretty quickly, and as a lineman, when your main job is blocking out in front of you, this may be a little bit easier than if you were the quarterback and this was your right arm and you were having to throw. And so, typically you can, obviously, number one, get pain kind of controlled, get rotator cuff, get muscles firing, at least with some basic exercises, progress motion, avoid that, provocative position, which is how they came out in the first place. And then once they're able to have, fairly good motion, good strength, you may allow them to progress back to play, and that could be, through 2, 3, 4 weeks. Oftentimes you probably put them in some sort of harness or brace to keep them from, kind of going in that extreme in range of motion. Guys who can't progress through that, or if they've had multiple injuries, you have the surgery conversation, but that's typically a off-season conversation for most people, unless there was a significant bony component, fracture, or again, one of these weird rotator cuff tears that occasionally will occur at the time of an injury.
So somebody dislocates their shoulder, the glenohumeral joint slides right through that weakness in the anterior joint. What kind of labral tear is going to be associated with that?
So that's going to be an anterior, inferior, that Bankart tear,
right,
that we usually see.
So again, we've got, for all those that are listening and learning something from Dr. Flores here, we've got two types of Bankart lesions. One is that posterior, and then the anterior inferior. And those anterior inferior dislocations are the more common than the posterior.
Correct. Yeah, probably 90% of instability episodes are anterior.
And so let's talk about that acute injury, right? There's some debate right now in the sports medicine field about, to ice, not to ice. Let's talk about the difference between some analgesics versus anti-inflammatories. Everybody seems to have a different opinion. One of the things that I was asked was, what do I think about ice? Well, if I look at it from a rehab standpoint, ice is an infrared modality. Technically, it only penetrates 1 centimeter, but it's moving at a slower wavelength, and we know that it can change that perception of pain, spasm, pain, using the gate control theory, afferent pathways, etc. And then they talk a little bit about anti-inflammatories versus analgesics. What's your standpoint from a surgeon? What is it that you want to see? Because ultimately, if there's an injury, right, you and I are going to talk to each other, and you're going to say, hey, listen, this is what I want to see, and send them back, and I'm going to contact you back and say, this is what we're seeing. So tell us a little bit about your philosophy and what it is that you think is best.
The big question on that stuff, and I don't know if there's really a right or wrong answer. If you really look at things probably from a scientific, basic science standpoint, the first phase of healing is inflammation. So you want blood drive into an area to have these new cells kind of lay down chemical neurotransmitters and whatnot. And so when you think about it, well, why would I ice and inhibit that process? Why would I take anti-inflammatories and inhibit that process? Well, I think why shouldn't I heat it and actually get more blood flow? But I think you're looking at pain here more than anything else, and really you probably want to minimize pain so you can allow progressive function. So whether or not there's a right or wrong, I think is very debatable. Analgesics, Tylenol, acetaminophen, pain pills for whatnot. I think most of us try to avoid that stuff. Most people don't need that stuff. Anti-inflammatories, Advil, ibuprofen, again, can help with pain, and again, it's torn. It's not going to heal, unfortunately, and so whether or not you're really changing anything, I think is debatable. What you're trying to decrease is the inflammatory cascade, the synovitis within the shoulder joint, and which is why sometimes these other things that we inject, whether or not it's PRP or bone marrow or some of the stuff y'all probably we talked about earlier, sometimes seem to have an effect, but we don't really know the direct pathways on why. But it seems to be beneficial for decreasing inflammation and helping healing.
Okay. So a couple more questions if you have the time.
Sure.
You got to be in the operating room today?
Got patients waiting.
Okay. So let's just wrap this up. Let's give you one more question here.
That'll work.
Bill, you got a question for Dr. Flores?
No, I'm just enjoying this conversation.
Jasmine, do you have a question for Dr. Flores? Okay, then I'll ask one last question here. Looking at going back to the difference between shoulder and knee, and looking at all the other aspects of sports medicine, if you were going to give some advice to some people that are just getting into that sports medicine field, right? You've been around for a while. Bill's been around for a while. I've been around for a while. What's some of your advice? Why did you choose sports medicine over some other areas of orthopedics, and why did you choose orthopedics over some other areas in medicine?
I think the benefit of orthopedics is I think you get the opportunity to fix things. Somebody asked me the other day about taking anti-inflammatory. Isn't that like putting a Band-Aid on it? And I was like, well, kind of everything is like putting a Band-Aid on it. Taking blood pressure pills, you're just putting a Band-Aid on it until you take your next pill. Orthopedics gives us the opportunity to really kind of fix something and address a problem, and sports medicine, in particular, everybody thinks, oh, I'm not an athlete, I'm 40 or I'm 50 or I'm 60, you can't see me. That's not true. I mean, I think there's lots of people who have injuries, or not every injuries, but conditions that involve these joints, and you treat people the same way. Just because you're high school doesn't mean you're treated any different than the college, or any different than the pro athlete, or any different than the weekend warrior or a 50, 60, 70-year-old. And there are plenty of 70-year-olds out there right now who tear ACLs and tear rotator cuffs and have issues that decreases their quality of life. Lots of people can live with stuff, but some people don't want to. And if they want to be active and they want to get it fixed, it's very rewarding for us to be able to fix that person and give them the opportunity to go back to active, pain-free, or minimal pain lifestyle.
Well, Dr. Flores, I want to thank you very much for your time.
And the surgery is really cool.
And surgery is
really cool.
Surgery is really cool. Always going to the operating room is cool.
Yes.
Dr. Flores is with Dr. Lowe in the UT Department of Orthopedics, and they are officially partnered with our Master of Athletic Training program that you can access at www.hhp.uh.edu/MAT. Go into partnerships and look up the link to the UT Department of Orthopedics, and you'll be able to look up Dr. Flores. And he's also with the Ironman Sports Medicine Institute, which we've also been able to partner with. We're very, very fortunate with that. Dr. Flores, thank you very much for your time. If somebody's got questions for you, can they email you?
Or probably the easiest way is contacting my office.
And how do they contact your office?
It's probably on the website. Would probably be the easiest way. Yeah.
So go through that link. Yeah, just the way. All right, Dr. Flores, thank you very much for your time. We really appreciate it. I know you got to get back and see patients.
All right, appreciate
Everybody's
it.
Waiting for
Thanks
you.
for having me.
All right.
All right. Thank you.
I just enjoyed listening.
Switch up with the next speaker. So next is shoulder. I'll take, I'll take paragraph, I'll take concussion, I'll take lean athlete, I'll take athlete session. He's going to read that.
Who's up next?
It's Mihal's.
Oh, he's doing the hip.
He's doing hip now. Core stability.
How's school? Good. Good. I just sit here and I feel like an imbecile next to Dr. Dillon. And it's intelligent. But that's what he does.
He's got to deal with me. Hey, listen, we're a four program. Chaz may like set you up for the home run. How did it sound? It's good. Does it sound like I'm stuttering?
Did you rename the one on the device?
Yes.
Alright, so this one's already saved. Save the file save. Yeah. Save there. So then you can do file, close. Project as. Go up so that it's in the music. This is a parent folder. New. And then this one is actually the next. They skip Ryan. Vishal. Shaw. So then I just save it as that. Then you go inside that folder. Save it there. Save. And then now it's ready. So as soon as you start recording, and then you stop it and save it, saves it as that. Okay. Then I have chargers if these needed. This is plugged in. That's plugged in. This one, if you want, you can tweet as me from this, or you can just keep tweeting as you. But I would throw some in there for me. Have you been able to see them up here?
Yeah.
I should have. Sarah told me I should have had a graphic. Be back in a minute or something to put up there, but. Where is that? Interviewing right now.
Who's gonna interview the next person?
I don't know. Let me go check.
Mark doesn't want me to. Mark doesn't want me to do anything. He said we're taking everything else. Gotcha.
All right, Jasmine, jump back on.
Jasmine, you're up.
Hello, hello, hello.
This seat is a little.
Squeaky?
No, I'm gonna change it. I was sitting and then it popped up. I almost fell out.
Solid enough.
I think that's a sign that I may be too fat.
You said
me. I didn't want to say anything. But they said I had to be in shape. I told them I thought round was a shape. All right, who's coming up next? So, Jasmine.
He actually switched Ryan Collins and Vishal Shaw because Ryan had a problem. So
who's coming up next? You said.
Vishal Shah.
Yeah, Dr. Shaw's next.
Yeah, he's got
All right, so he's doing hip.
Yep.
Yeah. Hang on. Let's find.
Yeah, I don't know if he had anything in there.
Let's find. So, Jasmine, as I'm looking for some stuff here, can you please tell us more about you and your experience? And when you speak, you have to speak in the microphone, please. Go ahead. Tell us about your education over there at A&M. Tell us why you chose to. Why'd you choose to go to A&M?
I chose to go to the Texas A&M University.
The Texas A&M University. What does A&M stand for?
Agricultural Mechanical.
Mm-hmm.
I actually got a lot of scholarships to go there.
Really? What kind of scholarships did you get?
I got a Regent scholarship,
What's a Regent
which is for first generation college students.
Nice.
Yes, sir.
Okay, so you're you're a first generation. So your parents didn't go to college.
No.
Where are your parents from? Houston originally?
They're originally from Mexico, but
And so when
they
did
moved
come,
here when they were young.
When did they come to the United States?
When they were young. They were like,
When they were young. So they
yeah,
came here,
about 12.
and they must be extremely proud of you. Do you have brothers and sisters?
I have one younger brother.
And so he sees you go to college, and what does he say?
He's actually going to A&M in the fall,
He's
too.
going to go to A&M. Hey, did you guys hear this? Jazz, what's your brother's name?
Luis.
Jasmine, what's your last name?
Dozal.
Say it again.
Dozal.
Dozal?
Mm-hmm.
Jasmine and her brother Luis Dozal will both be at Texas A&M at the same time. And the reason why your younger brother is going to Texas A&M is because you got accepted to college.
Yes.
And you showed that it was possible. So he said, if my sister can do it, then I can do it. What kind of, you took the SAT or the ACT?
SAT.
How'd you do?
I don't really remember.
Good enough to get Texas A&M.
I guess so.
Yeah, I got it. I don't care. Yeah. Well, I can't find a lecture for Dr. Shaw. Yeah, look at that. Yeah, that's Jeremy pulling it up. Nothing I like more than listening to my nasally voice. So your brother's gonna go. What does he want to major in?
History. He wants to.
He wants to be a lawyer.
No, he wants to be an archaeologist.
Oh, like Indiana Jones.
Kinda.
That's gonna be awesome. Dr. Jones. Yeah. Let's do what? Yeah, let's pull the legendary. I don't think Dr. Shaw's.
This is him. I guess you saw that.
Yeah, Dr. Shaw. So we're going to ask him some questions about the hip, and I'm going to learn something because that's going to be part of my class this semester. Yeah. Ladies, drum roll, please. Here it comes. Whoa! Hope you guys all saw that on camera. So, Jasmine, thank you very much for all that great information.
Yep, you're welcome.
About you going to Texas A&M, and Jasmine, majoring in kinesiology, is thinking about applying to the Master of Athletic Training program at the University of Houston, and she knows to access all that information at www.hhv.uh.edu/MAT. To my right is the legendary Bob.
That means old, right?
Marley.
Not
Yeah.
when you're as good as you are.
And right across from me is Mark Knobloch. Mark Knobloch is Mark Knobloch is the clinical coordinator for our athletic training program. Bob, thanks for joining us, and thanks for putting this whole thing on. Can you tell us a little bit about yourself? Where'd you go to undergrad? Where'd you get your master's? How'd you get into athletic training? How'd you end up here?
Well, like a lot of athletic trainers, you start off as an athlete who maybe doesn't have quite the skills or quite the speed that you would like to have. And all of a sudden, one of my coaches suggested, hey, why don't you become a student trainer? And so.
And where are you going to school at this time?
This is in high school in Creston, Iowa. And for some reason, the more I found out about it, the more I got into it, the more I liked it. And then I was fortunate enough to go, actually went to a junior college on a basketball scholarship. And I already decided that's kind of what I wanted to do, so I started helping. It's kind of, they didn't have a trainer. My head athletic trainer.
How about that?
He groomed me and taught me how to be an athletic trainer and how to have compassion.
And this was where?
This is Northwest Missouri State University.
And Sandy Miller's now at Stephen F. Austin.
Right.
So now you and Sandy end up in the same state, in the same district. And Mark, you also had some experiences with Sandy Miller.
I did. Sandy, he put me at ease one day. I was having a bad day. He came to visit when I was at Lamar.
Now, Mark, you were the head athletic trainer at Lamar for what years?
1999 to 06, I believe. And I was just frustrated, and Sandy comes in, and Sandy's just a good guy to talk to. And I was mad at the basketball coaches were on me because somebody wasn't ready. And I did my best. You did everything you could, and the guy couldn't play. And Sandy was in the shoot around and kind of plopped down next to him, and I said, he's like, how's everything going? And I said, I'm so tired of the coaches always being mad. Whenever you approach them, they're always being mad. So how do you handle it? You've been doing this, I don't remember how many years at the time, 30 years probably ago. This is probably 10 years ago. And he said, Mark, there's something you got to remember. We're not getting them hurt. They are not getting hurt in our drills. And it just, I said this to Dr. Yellen before, it just like a wave came over me. And I said, it's exactly right. And also I just remember leaning back and I said, you know what? He's right. I didn't coach him into getting hurt. I took what I was delivering. And so Sandy is just, he's a great guy too, but it's just, always remember that about him. And I probably told the story 5 times now in the last month, and he doesn't know I'm talking about him this much, but he's just such a good guy.
So you're at Northwest Missouri State.
Right.
Northwest Missouri State.
In Maryville, Missouri.
Playing basketball, and you're acting as a student trainer, and you're working with Sandy Miller. And
fell in love with athletic training. For the same reasons y'all are doing what you're doing. And I like the cross between the coaching and the medical field. It just seemed a perfect fit. And so Sandy took me on as an student athletic trainer, and worked with a lot of guys that I had a lot of respect for, and knew I wasn't ready to go off on my own because everybody else had been student trainers in high school and things like that, and had a lot more experience. So I went to Michigan State University as a graduate assistant.
So you graduate from Northwest Missouri State in what degree?
Back then it was a Bachelor of Science in Secondary Education in physical education.
Okay. And this is back in the days when athletic training was the internship route.
Yes.
Right.
There were 3, 4. I think Indiana State had one. Arizona
accredited programs.
Had accredited programs.
Through KHEP at that time. Right.
Correct. Exactly.
Right.
And knew I wasn't going to be able to go that route, so I just went on to graduate school and worked for Clint Thompson.
Sure.
And there was a lady there named Kathy Heck.
Yep.
Who taught me. I learned everything I know from there, from Kathy Heck and Gail Robbie Robinson. I don't know if he's an old timer, but he in the Hall of Fame and everything.
And Michigan State has a pretty robust athletic training program.
They do now. Back then it was just getting started, and they were.
What year was this?
This was 80 through 82, and they were devising the program they now have. And we got to do rotations in the pharmacy, rotations in radiology, rotations with the orthopedic surgeon, with the team physician. There was someplace else, but you did 6 months that way.
Yeah.
And that's also where they let us go in with the medical students, and we had our own cadaver.
Yeah.
And so we spent a full calendar year, 3 days a week minimum, with our cadaver, and the instructors had played in Major League Baseball, and now were physicians, and they were teaching, and so they knew what we were.
A lot of arm and shoulder dissections, I bet then.
And they said, and they'd say, okay, find me this, and we'd find it and tag it, and they'd come in the next day and say, no, you were wrong, and here it is.
Yeah.
But that cadaver lab was the most entertaining, most educational thing I've ever done in my life.
Right. So every time we talk about cadaver anatomy, that's one of the things that I think we're beneficial to have in our program, is that we have a cadaver dissection lab that we're going to be working with.
Yeah,
and cadaver anatomy is an amazing opportunity.
Until you've done it, you really don't have a full.
It's not as pretty as what the books show, is it?
No,
it's just not all beautiful red and then a blue vein
yeah.
and a red artery.
It takes some time. I haven't done cadaver dissection in 10 years, so I'm a little worried. I'm a little rusty on my skills, but I'm going to be the one bringing them in the lab. And
it'll come right back to you.
I hope so, or else I'm going to look like a real idiot.
It's not that you know what you're doing, it's that you act like you know what you're doing.
Yeah.
Let's just hope that when I'm talking about the foot, I'm actually working on the foot. So then you graduate Michigan State in 82. So you come out of undergrad in 1980.
Right.
Right. So going back, you start undergrad in 76.
75.
75.
Took me 5 years because I was going to be a coach.
Uh-huh.
And God, I'm too nice a guy. Too nice a guy to do that, and so that's why the athletic training kind of fit in.
Compassion was fit a little better with athletic training than coaching, huh?
Right. And so it took me 5 years to get, because I'd gone to a junior college where I was. That's when I was going to be a coach, and I was playing, and then got to the real world.
And
it was a little different.
So you come out of Michigan State in 82, and then from there you go where?
I come to Houston Baptist University.
In HBU.
Yes, I had 2 choices. I could go to HBU as a full-time head athletic trainer for $18,500, or I could go to Northwestern as a head football trainer
in Chicago.
For $11,000 a year.
Mm-hmm.
Well, weather, Northwestern, Chicago versus Houston.
Mm-hmm.
$6,000 back then, $6,000 or $7,000 was a huge difference. So
It's a huge difference now.
And my fiance at the time was living and teaching at Galena Park.
Uh-huh.
It seemed like a no-brainer. So
So you make it down to Houston.
was at HBU for those 5 or 7 years.
As head athletic trainer at HBU.
Right. Well,
And then,
we only had one athletic trainer. The others were students.
boy, that sounds familiar, doesn't it, Mark?
Mhm.
One head athletic trainer.
Been there. But we didn't have football, so it's hard for me to complain when a lot of people, it was like in high school, there's one athletic trainer and 300 athletes plus football. But I saw an interesting fact. You turned in your keys somewhere last week, right?
Yes. After 25 years of part-time contract work in Needville, they've hired a full-time athletic trainer, Lauren Gonkoff, who is here today. She's been at Texas City for 5 or 6 years as full-time as the head athletic trainer, and so she's recently moved to Richmond, which is 12 miles from Needville. So Needville's really they're getting a big step up.
That's great.
It's hard to follow a legend, so she's probably shaking in her boots.
Because she'll be there full-time. She'll take it.
She'll get that comment of, well, when Bob was here, he did this.
Yeah.
Well, but it doesn't matter who you're following. That always happens.
Like me when I first got to Houston, is she going to have your cell phone number and call you every day? Bob, 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 I got a question, Bob, Bob, I got a question.
So what do you see? You've done, excuse me, such a wide setting. What do you see in those small schools that you don't see in the big schools, or vice versa? What do you see in the big schools that you don't have to? I agree 100%.
Yeah, those small schools, the family, the kids, the parents, the coaches, they're grateful for everything you do for them. They're honest, they're open. I get graduation cards from kids that I saw maybe once at and that's what we all got like training for, was the interpersonal skills, value. And I don't, the Texans, some of those guys are nice. They give you a birthday card or they give you something, but at those 2A, 1A schools, it's totally different. 5A school, there's some that are like that, but across the board, it's totally different in a small school.
I did some contract work at private schools, and that was the first thing I told somebody. I said, you would not believe the difference in attitudes of the kids and the coaches. And not that there's anything against 5A, but I didn't get near as many thank yous or yes, sir, or whatever. And I remember walking up to a coach. He's like, what do you need? Does he need to sit out? It blew my mind. And I almost felt bad telling him, I'll try at halftime, because I felt just this connection is so much more. I wanted this kid to play because of how they treated you. Just, it was so much more appreciative, and I think that's. But I think too is that they're so used to not having anybody there. We're at a 5A school, 4A they probably do, and so it's just part of the staff. Where when I showed up on Friday nights, it's like, this is awesome. Somebody else can take care of injuries, but even the kids, just the professionalism and everything was outstanding.
So I want to go back to, you are at HBU from what years?
82 to 89.
And then in 1989, you do what?
Well, 89, the school decides they're not going to do Division I athletics anymore. So they do away with basketball. They do away with everything except some small. I can't remember what sport they kept. But they were going to come back as NAIA 2 years later.
Mm-hmm.
At the time, my team physician was David Calvo, and he says, "Hey, come." Bruce McCurry, who some people may know, was there, and he was leaving to go to Midland.
Mm-hmm.
And so he was running the clinic for him, and he said, "Hey, come do this." Well, I was starting my family.
Mm-hmm.
I had a 2-year-old and a newborn, and my wife was saying, "I need you at home. I need you at home." So I'm thinking, okay, this will be an 8 to 6 job.
Uh-huh.
Pay was a lot better. It almost doubled my salary, and so it worked out really well that way. But I was not happy, and that's when I started at Needville, because I still needed that.
1998.
95, 96, yeah.
Okay, and then what happens after that? Because right now I'm tracking, right? You've been back before we had all the accreditation, right, and all the standards in athletic training education. You could really go through the internship program, and back then there was only really maybe 5 or 6 different KHEP accredited schools, and then from there you go to Michigan State, where everybody, anybody that understands anything about athletic training, Michigan State is, one of the leaders. And then from there you go down to Houston, Texas, and you're at HBU. So you've been a student trainer, you've been a graduate assistant athletic trainer, you were a head trainer, at HBU Division I school. You're a physician extender, essentially, before we even knew it as a physician extender, right? And then so after that, you go where?
Then I go to, well, then the doctors, Dr. Calvo sells, it's called Sports Lab. He sells that to a hospital organization. They didn't know what the hell to do with an athletic trainer who, because they didn't have many.
They don't know what an athletic trainer is.
Says, Bob, what do you want to do? Well, the last couple of years at Sports Lab, we'd started doing some outreach stuff. We were going to some of the smaller schools and kind of doing what we're doing now. We were just doing it on Tuesday and Thursday when the schedule was a little lighter. And I said, well, I'd like to do this full time. And so we started
the outreach side.
The outreach. And started visiting schools, and they said, yeah, we'd love for you to come. We'd love for you to come. Well, it was a plus because the schools got athletic training visits that they didn't ever have before. And the hospital all of a sudden was getting all this marketing, all this notoriety for doing this.
And what hospital was it?
Back then it was called Columbia HCA Fort Bend Medical Center.
Okay.
It's no longer there. It's morphed into Memorial Hermann Sugarland Hospital. Rod Brace was the boss. He had the vision. He said, that sounds great. Let's try that. And from there it just blossomed.
And then, so tell us how. Right. So let's backtrack again. Right. Student athletic trainer, graduate assistant, head athletic trainer, physician extender, and now you're into outreach athletic training.
Right.
Okay. So and then you've changed some organizations. So you go from that hospital, Columbia, Fort Bend, that morphs into Memorial Hermann, and then from Memorial Hermann, I'm assuming you get into the position and the role that you're in now.
Well, actually, when HCA, after doing that for HCA, Columbia, Fort Bend, whatever, for a couple of years, Walter Lowe came to me and said, hey, look, I'd like for you to come work for me. Doing what you're doing, but just come work for me. And back then, he was at Baylor College of Medicine. And I said, well, everybody knew who Dr. Lowe was because he had just started taking over U of H. He had just started working with the Oilers, and I'd known his reputation. So I said, sure, I'll buy in. And so we went to work for, at the time, Tier. I got a paycheck from Tier, but I worked for Dr. Lowe, who was at Baylor. After a couple of years of that, then he swallowed me up into just Baylor, so now I'm in his hip pocket and just kind of followed him around from Baylor to UT Health Science Center.
So really, I mean, if we look at where athletic training is today and all the opportunities that we have, it sounds like you've done the majority of those settings. You haven't done military, right? Have you done industrial, occupational? No. Okay, but everything else we look at of really where athletic training is moving to, you've done it. So you're a huge resource, and that's one of the reasons why, Bob, you are one of our preceptors. And thanks to Bob, we have had an incredible amount of success in articulating and affiliating with Memorial Hermann Medical Group, Memorial Hermann Sports Medicine Rehab, Ironman Sports Medicine Institute, and UT Department of Orthopedics. And you can find that on our partnership link. And you can go to our program at www.hhp.uh.edu/MAT. Coming up now, Bob, thank you very much for your time. We really appreciate it. Hey, we're going to come back and talk to you some more.
No, I didn't get to sit here, Dr. Shaw.
Yeah. With us now is Dr. Shaw. Dr. Shaw, thank you very much. How are you?
How's it going? Great.
Great.
Thank you.
Nice to meet you. We're here with Dr. Shaw. I am Dr. Josh Yellen, Program Director for the Master of Athletic Training Program at the University of Houston. Across from me is Dr. Mark Knobloch, Clinical Coordinator for the Master of Athletic Training Program at the University of Houston. And to our respective left and rights is Dr. Vahal Shaw?
Vishal.
Yeah, Vishal. Shaw. And Dr. Shaw, tell us a little bit about you.
I am a orthopedic surgeon practicing here in Sugar Land at Richmond Bone and Joint Clinic, which is now part of UT Physicians, specializing in sports medicine. Really like sports and enjoy watching, as well as now can treat people who are involved in athletics. And it's been I'm in the 6th year now of actual practice, so
tell us a little bit about, where did you go to undergraduate, where did you go to medical school, where did you do your internship, residency, and then your fellowship?
Sure, I did my I grew up in Sugar Land area in Houston, so went to UT Austin for my undergrad. I actually majored in business and did my pre-med courses at that time. Then went to medical school at UT Southwestern in Dallas. And then I came back to Houston to do my residency in the medical center at UT Houston.
Okay.
And after 5 years there, did my fellowship in Birmingham, Alabama, and then back to Sugar Land. for practice.
Birmingham, was that-
We have to ask Birmingham anytime
Yeah.
you hear that name.
Is that with
Dr.
Andrews?
Yeah, so there's a big institute called the American Sports Medicine Institute, and Dr. Andrews, as well as Dr. Lemack, and several other doctors are part of that fellowship. So
Right.
it was a very great experience for 1 year.
Tell us about that experience, all right? So you're an orthopedic surgeon, you want to go into sports medicine. There are a few places that you can do a fellowship. One is the West Coast where Dr. Lowe did it. One is actually now with Dr. Lowe here in Houston.
Absolutely.
One's over at the Cleveland Clinic. One is at the Houston Clinic, right? And one is with Andrews. So tell us a little bit about that experience.
It was a great experience. Nowadays there are actually probably, I would guess, 100 accredited sports medicine fellowship programs in the country. So there are
Really?
tons, and they're various sizes. Some have 1 to 2 to 3 spots, and some have 12 to 15 spots. The bigger programs that you mentioned are definitely higher volume programs. So that's kind of the type of program that the Birmingham program is, and it's a truly eye-opening experience. You really practice hands-on sports medicine, which means being at the events on the field, and seeing the evolution of the injuries from when they first happened to the recovery phase, and the thing you really get there, which you don't get in, I would say, programs where you're not as hands-on, is really how to manage these events. I won't even call them injuries, because it's more than an injury. It's an event. It changes it changes the potentially the career of an athlete. It changes the outlook for a season, for a team. It changes what a coach has to do to prepare for the rest of that game or the next game. It affects the families of the players and athletes, and the people around them. So I think that's where you take it from just the mechanical parts of the injury and the anatomical parts of the injury to really what the injury means on a broader scale.
You get to see the athletic training side of the injury.
Absolutely.
So tell us a little bit about that transition, right? You're a business major in undergrad. You take your pre-med courses. So you really have no exposure to athletic training probably until you get to your sports medicine fellowship.
True.
Is that right?
Yes, that's very true.
Okay, so tell us about some of the interactions with the athletic trainers and how you tell us some of the things that you've learned along the way about the profession.
Well, the athletic trainers are they obviously have the finger on the pulse of the athletes and the team, and they're essentially 24/7 in a lot of these cases. So it's very important to learn how to work with your athletic trainer, and you can't do that without the actual hands-on experience. And,
right.
And so that's what I found is really to trust and be able to communicate and work well with your athletic trainer. That was probably the most important kind of nugget of information that you take out of a fellowship, besides the obvious, the technical aspect of it.
And so when you're doing your fellowship over in Alabama, what kind of schools, I'm assuming you did high school, you did outreach.
Sure, you did a little bit of everything. Tons of high schools. Alabama is very similar, and maybe more so than Texas. Football is key there. So there's tons of high schools you do work with those athletic trainers very closely. Personally, I was on the field with the Auburn Tigers. They weren't having one of their better years, so but it was still an amazing experience. And so you see that level of it. I worked with Alabama State University as well, and occasionally we would travel to the Redskins games and the things of those nature as well.
So let's get into a little bit about, you did a lecture on hip, correct?
Correct.
And hip is really kind of a unique joint. It's a little bit like the shoulder, and it's a little bit about this. And I call the shoulder not a true ball and socket joint, right?
That's absolutely right.
And so, but the hip is a real true ball and socket joint.
True.
And so, tell us a little bit about, from the anatomical standpoint, how you got interested in the hip, and what are some of the more unique injuries that we're going to see?
Yeah, the hip is definitely a joint that, in orthopedics in general, it probably was relatively ignored for a long time. Basically, in the hip, you had fractures, which were fairly obvious, and you had arthritis, which was also fairly obvious on an X-ray. And there you would either fix a fracture or replace the hip, and everything in between was kind of chalked up into bursitis and tendonitis, and kind of that unknown realm where we didn't really have an answer for it, so we didn't really know what to call it or how to treat it. Over the last probably 10 years really, but even slightly before that, arthroscopy of the hip has become a possibility due to technical advancements and better cameras and a little better knowledge of the anatomy of the hip, and that's really opened the door to identifying a lot more pathology that was probably chalked up to, you know, aches and pains and arthritis, but was much more focal than that. And now that we've got the ability to use a scope and treat a lot of these injuries, it's really opened up a whole new world of orthopedic surgery and which is arthroscopy of the hip, and specifically dealing with this hip impingement phenomenon. Also, we've been able to differentiate between hip impingements and sports hernias or abdominal hernias, these injuries have also become something that in the past were far undertreated because we didn't have the information about it.
You should know what they were.
Didn't know what they were.
Right,
Yeah.
so you're making the assumption that it's one thing, and in fact it's another.
Sure. So,
And so tell us a little bit about, you know, if I look at the glenohumeral joint as opposed to the hip joint, it goes through some similar motions, right? External rotation, internal rotation.
right.
And the external rotators, right, there are 6 external rotators of that hip. So tell us a little bit about your experience in treating external rotation issues in the hip and why that's so important as opposed to some of the internal, because those internal rotators are big, right? Those adductors are big.
They're big. You generally have a greater range of external rotation than internal rotation, so you kind of have a more functionally, the external rotators are more important in a way on a daily activity basis. You can actually get away functionally with less internal rotation than you can if you lose external rotation. The typical external rotation type injuries we would see are going to be things associated with your piriformis, and a lot of times that can also injure or aggravate your sciatic nerve. Most of the treatments for those types of injuries are going to be primarily rehab associated and functional and core strengthening. We do occasionally see acute external rotator tears. Even those usually are treated.
From what? What do you see the acute external rotator tears from?
You're going to see them usually in, it's not an extremely common injury, but you would see it in a torquing type injury, like a lot of times in soccer or hockey, where there's a significant torque or rotational moment on a planted hip.
And I'm sure you're probably going to take a little bit of piece of the labrum. And,
absolutely. So the soft tissue envelope has to be, when you have a damage to the soft tissue envelope and the hip is moved torqued in an abnormal manner, that's when you see the intra-articular injuries as well, such as labrum injury.
You brought up an interesting term, the soft tissue envelope. Can you describe? Some of our listeners are listening to this; they're getting some CUs off of this. Can you describe what is the soft tissue envelope?
So soft tissue envelope starts with so that you have the joint, the ball and socket, but everything around that is what I refer to as soft tissue envelope. The first layer would basically be your capsule of the joint, and that's composed of various thickenings, which are the ligaments of the hip. The strongest ligaments in your body are in the anterior portion of the hip, the ilioischial and iliofemoral ligaments, and then the posterior hip capsule is less of a named structure, but a very thick structure on its own. Outside of the capsule, you're going to start to have your deep muscle layers, the external rotators, the piriformis, the gemelli, and the obturator muscles posteriorly, and then in the anterior portion of the hip, you don't have as many smaller muscles. You start to get into the rectus muscle and your sartorius, and those are kind of that would be what I would consider the second layer of the hip, and then you've got your fat tissue and your skin. So that's kind of the entirety of the soft tissue envelope.
Let's go back to those external rotators real quick. You really brought up piriformis, but we know that there are 5 other external rotators, and so functionally, you brought up a really good term. Functionally, what does this do? We have more external rotation functionally than we do internal rotation. But if you really look at the anatomy, those adductors and internal rotators are enormous and big and strong.
Yes.
But those external rotators, functionally, we need them more. But they're so small. We see that a lot in the shoulder. We see that. Obviously, if I make the comparison of pectoralis major versus all the posterior musculature in the shoulder. So tell us a little bit more about functionally. What do the gemelli do? What is The Gemellis brothers, besides being, they sound like they're part of the mafia,
Yes,
right?
they sound like they're part of the mafia.
It's okay to say, you know what? Hey, listen, I'm asked this question a lot. What do they do? And then the right answer is, I don't know.
You know, I don't think, I personally don't know, and I don't know if we have all the electromyographic information to know. It may be out there. I certainly don't know on an individual level how those muscles differentiate themselves from each other.
So it sounds like if there's an anatomist that is out there listening that can do some sort of testing to let us know exactly how this works functionally, please call in. So let's expand out a little bit and talk about, further out. Let's talk about the gluteus minimus versus the gluteus medius, and then obviously, the big daddy, the gluteus maximus. So tell us a little bit more about hip movement and how the minimus, medius, and maximus work.
The medius and minimus work primarily as hip abductors, abductors, and they're very important. They're basically what we consider the rotator cuff of the hip. Just like the supraspinatus of the rotator cuff is your primary abductor, if you will, or forward flexor, as well as your shoulder. Those are the primary, the gluteus medius and minimus are the primary abductors of your hip. They can actually get injured or torn similar to a rotator cuff. We're seeing that injury more, and again,
how would that happen?
A lot of times it's similar to a rotator cuff injury in an older patient, and when I say older, probably even in as early as your 5th, 6th, 7th decade, just from chronic overuse, or not even overuse, but chronic use. Sure. It's an area that has a less than optimal blood supply as time progresses, and you can end up with a tendinosis situation that ends up resulting in a kind of a attritional tear. So that's the most common way we see these abductor injuries. Sometimes it's from an acute on a chronic situation where they might have some hip tendinosis and then fall on
the noise you hear in back of you is a little branding that we're happening right now.
So,
congratulations. There you go.
All right.
I have a question for you.
Sure.
So kind of one of the terms I've really heard come up in the last 7-8 years is this term sports hernia. And I think there's a lot of misconception about what it is versus a hernia. Could you just briefly talk a little bit about sports hernias and what you see, what the prognosis is, and maybe their mechanism of action of how it happens as well, and what we need to know as athletic trainers in terms of treating them?
Sure. So a typical hernia, we'll start with that you would see, is not always an athletic injury. It can just be a condition that patients can present with. It's truly a hole in the abdominal wall where a part of the intestine can actually herniate or push through. Even without the actual pushing through of part of the intestine, you can have that defect, and that's what a typical hernia would be. They can be in the abdominal wall or down in the inguinal region, lower in your groin. A sports hernia is more of a injury of the abdominal muscle attachments to the pelvic girdle, and there can also be a defect in the abdominal wall, but there's not usually it's not related to the GI system or to the intestines. It can cause pain in a similar area. Typically, the pain is more on the pubic symphysis or deep in the groin. The classic presentation of a sports hernia would be pain with a resisted crunch activity, or pain with resisted adduction of the hip, and that pain is going to be not in the muscle itself, but more on the attachment or near the attachment of those muscles to the pubic bone, the pubic symphysis. And the treatment is, or how you can get this is usually the most classic is going to be positions where you have to externally rotate your hip and extend your hip repeatedly. A lot of times we see that in soccer. We can see that in the football players who are backpedaling a lot or backtracking, typically in a secondary type position, or cornerbacks and safeties probably have the highest incidence of this, although you do see it in other position groups. Treatment is initially, of course, conservative, and you focus on core strengthening and rehabilitating and decreasing the pain first, and then rehabilitating the core and functional core strength. And if it's not successful, then they actually can do surgeries where you depending on even sports hernia is a broad term. There's various different types and specific breakdowns within that. You can reattach the abdominal muscles to the pubic symphysis. Sometimes you augment that with different types of mesh if there's a weakness in the abdominal wall behind that muscle.
So you go back to conservative treatment of the sports hernia, right? And one of the things that pops up to me is that iliopsoas group. And I know that anybody that knows anything about anatomy, right, that iliopsoas has some stuff to do with hip flexion and some other things. Can you start to differentiate? How do you tell the difference between sports hernia, hip flexor, iliopsoas? Tell us some of the clinical diagnostic tests that you do to differentiate this with excluding MRI.
Sure. I mean, it can be very difficult. Clinically, well, first is listening to your patient and listening to the athlete and trying to see exactly what motions cause the pain. That's going to be a big part of it. Is it going to be, and usually it's going to be certain things like kicking or even though the pain may not be from the hip flexor, it's going to be hip flexion activities that cause the pain, because part of hip flexion you usually are contracting your abdominal muscles as well and flexing in that area. But physical exam is very important here, where if you have a patient lie flat on an examining table, first palpating where it hurts.
Prone or supine?
I usually start this with a supine examination, and you're going to palpate the area of tenderness. A hip flexor pain is usually going to be difficult to palpate on a bone, because the bony attachment of the hip flexor is kind of the iliacus bone or the lumbar spine. You can't really palpate that muscle origin very effectively. So their pain is going to be more with activity, but you can't put your finger on it. With a sports hernia, it's typically more symphyseal pain, pubic symphyseal pain, so you can palpate it a little bit more precisely, typically. The other thing I'll have them do is then as far as examination goes, in the supine position, just have them do a straight leg raise. Typically, if they're doing that with their hip flexor alone, that doesn't usually incite as much pain. Or it can incite pain, but it's not going to be as specific or as reproducible as if you have them do a resisted crunch. I find that to be probably one of the most differentiating exam techniques is having them do a resisted crunch, and that while you're palpating the symphysis.
And so resisted crunch, palpating symphysis is differential diagnosis for all those that are listening between trying to rule out iliopsoas, trying to rule out sports hernia. Right, so
exactly.
They do a resistive crunch. You're trying to palpate pain. If you can put your finger right on, we know that it's probably not iliopsoas.
That's right. That's correct.
If it's one of those diffuse pain, situations, we're probably going to rule out sports hernia. Probably going to rule out hip flexor. I'm going to go towards iliopsoas. And so, as you're looking at it as a physician, you're looking towards treatment. Tell us a little bit about that course of treatment.
For sports hernia?
Yeah, for sports hernia, for iliopsoas, for hip flexor.
So
what's kind of your mindset?
The mindset is typically, it depends partially on, of course, the first thing you want to know is what have they already done with the treatment, with respect to treatment. What have they already been through? Did they go through a kind of a home program of this is what I thought it was and this is what I got Googled and tried to do on my own, or did they have a supervised Google knows all. Did they have a supervised rehab program and were they consistent with that? So that's the first step, of course. Then depending on where they are in season and in their activity and in their career, quite frankly, that also influences how you treat these patients with respect to how much time do they have to try various things. But in general, you always approach things conservatively and see what you can do. You want to try to do the least invasive or dramatic thing to improve their symptoms. So you can start with equipment and activity modifications if that's feasible, resting from just to let the acuity of the injury decrease, using your regular icing and anti-inflammatories as needed, just to get the resting pain under control. Once you've got that under control, then you start to work on rehabilitation, which can mean a lot of things. depending on the exact diagnosis. But I think in general, building core and hip and functional core strength is going to be key to both of those problems, really, the hip and the sports hernia. And then slowly trying to reintroduce their functional activities and seeing if you can have them compensate for this type of injury. Usually you don't truly heal a sports hernia. If it's a hip flexor tendonitis, that can calm down and heal, but a sports hernia typically doesn't heal. The question is, can you work around it or not?
So it sounds like, we've always learned about this kinetic chain, right? And it's that old song, the hip bone's connected to the whatever bone. And, but it really sounds like that hip joint is really based off, the success of that joint is really going to be based off, you brought this term up a few times, core strength. And being able to be, have your core strong. And for all those that are just learning about core, whether you're at the undergraduate level or maybe you're at the high school level listening to this, or you're just getting into your athletic training or physical therapy, core, we've always been taught, is that area between, the base of your neck and your pelvis and everywhere in between, right? That's that core of your body, and everything else is really an extremity.
Yeah, that sounds appropriate.
Yeah, that's good. Okay. Any other questions for Dr. Shaw?
I do. I'm kind of curious. I did my postdoc down at Baylor, and it was a high genetic amount of work. And obviously the majority of what you do is orthopedics. Are you seeing any trends from a non-orthopedic side, more of a genetic therapy or anything like that going on in your area? Or is it pretty much, would you say it's really manual therapy, surgery, whatever? Are you seeing any interesting things coming out of stem cell therapy, that kind of stuff? Or what's going on in the hip area or whatever?
Yeah, it's a good question. I think, I guess a bottom line statement would probably be the future, for sure, is going to be to figure out how to fix a lot of these things using stem cell therapy and genetic therapy. At this point in time, it's still not refined or close to refined as much as it needs to be, and people are doing these treatments, and you see a lot of almost misinformation or exaggeration of the treatments that are available in the media, and quite frankly, overseas there's not as regimented of a FDA regulation and so forth, and so even we see professional athletes in the news are going overseas to have quote unquote stem cell treatments.
And I don't mean to interrupt, but how do you handle that when you have an athlete or you have an individual come to you and say, or you hear about this in the media, they'll say, well, they let you do this in France, but the government doesn't want this to happen. They want us to go get. How do you handle that as a physician to a patient saying, it's not, we want you healed, and yes, you're going to hear this anecdotal evidence, well, the government knows there's a cure for your condition, but they just want you on medications. How do you approach the patient from that without, getting a head-to-head battle going on?
It's a difficult question, because a lot of times, patients want the quick fix, and shoot, if there's something available that is a quick fix, then you would demand it. Even personally, you would want that. But I think you have to explain, and what I do is explain, the reasoning. A lot of these things, in this country we see, we can't watch TV late at night without seeing a hip implant that's been recalled, or a lawsuit that's from some pelvic mesh or something that was used. And I try to explain to the patients that's the reason the FDA is so restrictive here on what you can and can't do, because you don't want to just have proof that it works in the short term. You really want to have that safety net that we've seen and observed the results of this type of procedure or implant or what have you for many years, and we know that later on there's not going to be unforeseen adverse effects, and usually when you paint that picture to a patient and kind of put it in that perspective, they understand, and there's pros and cons. I think with a lot of the things you see being used overseas, they're in vogue for a while and then they fall out of vogue, or if they are proven to work, then eventually, the proof is there, and we see those treatments evolve over here. I think with stem cell therapy, though, we're still a long ways off. Even what they're getting across the pond, if you will, I tell patients as well that they haven't cured arthritis using stem cells. They haven't been able to cure these injuries or conditions that we're still treating over here. There are treatments that may help you in the short term, but there's equivalent treatments available here for most of those things with no added long-term difference. So at this point, it's not as difficult a conversation to have with a patient because I don't believe that the cure is out there at all. If it was out there and not available here, that's a different
There's a reason. There's a
then
reason
I might
for
tell
it.
them to buy a plane ticket. But at this point, I can confidently tell them that you're not missing out on anything right now.
That's outstanding. Any other questions for Dr. Shaw? Jasmine? Jasmine she's going to be a junior at Texas A&M.
Great.
And in kinesiology, she's thinking about applying to our University of Houston Master of Athletic Training program that we just started up. I have a not so smart question for her, not like Dr. Knobloch. I was really lucky to find this guy. But I just something that's been sitting in my mind now for probably 20 years. How do you differentiate between adductor brevis and pectineus?
Adductor brevis and pectineus.
Yeah, because that pectineus is just that small little adductor, right?
Yeah.
Adductor brevis is
My
there,
question to that question would be, practically, does it matter? But I mean, it's a good question. But when you're when you're
why are you
patient,
asking me a
I think it's your
question?
pectineus and not your.
Did you see his facial look? It was like, why are you asking me this stupid
No,
question?
no.
This makes no sense at all. No, I'm just joking with you. Listen, Dr. Shaw, we want to thank you very much. I'm sure you got to get back to the clinic and see a bunch of patients. They're all probably waiting for you. And you said that you were over at Richmond Bone and Joint. That's been picked up by Memorial Hermann Sports Medicine. You're working with UT physicians, right?
Exactly.
And so you're in Dr. Lowe's group.
That's right.
That's right. And Dr. Lowe has become a partner with us for our University of Houston Master of Athletic Training program. And if you go to our website, www.hhp.uh.edu/MAT, click on the link that says partnerships, scroll on down, and you're going to see that we've affiliated with UT Health Science Center and their Department of Orthopedics. Click on that link, and I'm sure you'll be able to find Dr. Shaw through one of those links. If somebody's got a question for you regarding hip, how would they be able to contact you? Can they email you? Is there a website they can go to?
Absolutely. They should have on the website you mentioned, actually, UT Physicians, there should be contact information that can get to me. I'm also on Twitter at SportsDocShaw.
SportsDocShaw. At
Yeah,
SportsDocShaw.
SportsDocShaw, just SportsDocShah.
Yeah, great.
And I have a website, sportsdocshaw.com, and there's plenty of ways to get a hold of me.
So you have Twitter at SportsDocShaw, and then you have a website called sportsdocshaw.com.
Correct.
Great.
Yeah. Try to put some useful information on there, frequently asked questions, those kind of things.
Well, that's
blog
the wave of
posts.
the future.
Yeah, it's nice to interact with patients that way. It's funny once you start having that exposure, you almost get a different type of patient sometimes that finds you just from those avenues that may not have found you from the conventional ones. So
it's all about marketing and promotion.
And that's where the business background may come in.
That's right. That's exactly right. Well, Dr. Shaw, thank you very much for myself and Dr. Mark Knobloch, Dr. Shaw. I'm Dr. Josh Yellen, and thank you very much for your time.
Oh, my pleasure. Thank you.
Thanks.
All right. No problem. I met you before, right? I met you somewhere.
I know. I wasn't going to say anything because I'm like, no. Trying to think. We've been in Houston.
Have you been in the office?
Where generally Richmond Bone and Joint. Not Richmond.
You all know each other?
I know him, but I'm not going to say it because I would know. I should know. Unless you've been at Baylor. You haven't been at Baylor.
Did you do anything with the Skeeters?
No, we went and visited. Penny Wilson was a dietitian with Skeeters. I wouldn't have known her, but I know I met you. I followed this happen. I was zoning out. Live in Westbury. So
you about the same age group? How old?
You were never talking about Beaumont, did you? This was 10 years ago.
Just leave that one. Because I'm not sure. Because the next one.
No, I'm not. But I'm just saying, it's funny you say that.
Breakout sessions.
Yeah, like I said,
So we may get people in here, or we may just let it run while
because I didn't want to say anything and be like, no, you're bringing me out here and you think you know. Yeah, I'm glad you said that because of course that's going to drive me nuts. I never figured it out.
Well, listen, we're probably going to be sending our students through the military too, so you'll definitely see more of us. You're over at the, where's your clinic?
It's good. Like sluts.
We didn't do anything with St. John.
More.
Who's our next guy? Ryan Collins, but he's got breakout sessions.
Yeah.
So breakout sessions are next, which is actually should have happened like 30 minutes ago. So.
Trends are and what happened to trends.
Is that good?
It's a live web podcast, and you're on, folks have told you you're on YouTube.
Live, so
And they
don't-
recorded it, and they recorded your talk, they're going to post that, and record the conversation, they're going to post that.
So how's it look? All right, so if you're watching live, which who knows who that is, but it was down and to the side. Okay.
This is our first year. We started up this graduate program in athletic training. We have our first class of 14, myself, superstar Hermann. We're trying to change the world. Awesome. All right. Thank you very much.
All right, so I'm right here. I'm talking. I'm on the mic. Good? Sure. I'm sitting there.
Does it look better?
Yes, definitely with your hair in front of your eye, it looks better. Jasmine, we sit right here?
This picture?
Yeah. All right. So, Jasmine, I'm going to ask you a couple questions.
Okay.
All right, Jasmine. Since you are a college student.
Yes.
I can't hear you.
Yeah.
There you go. All right. So, yeah, you got to make sure you're talking to the mic there, Jasmine. So, a lot of this is actually over my head.
Mm-hmm.
So, that's a good thing about having it recorded, so I can go back and say it again. So, what are your thoughts? I mean, you're sitting here and, you're just barely getting into the athletic training. What are your thoughts on this stuff?
I understand bits and pieces of what they're talking about. Not really sure. Whenever they start talking about like the surgery and orthopedic stuff like that, I'm not too sure what that means. That's why I don't want to ask any questions. I'm not really sure what they're talking about, but I do understand some parts. It's just interesting getting in all this information. People coming from different backgrounds.
All right. So, are you getting a chance to meet them at all? Like, are you getting a chance to shake their hand, talk to them, anything like that?
I've been talking to Dr. Yellen.
Yeah, Dr. Yellen.
Yeah, but he's the only one I kind of talked to and shook hands with.
So when the next guest comes in,
Mhm.
that's something you probably need to make sure you do, because 3-4 years from now they're like, oh yeah, Jasmine, I remember you from that workshop, right? Like yeah. Are you like, oh yeah, Dr. Shaw, I remember interviewing you at the sports medicine conference. He's like, oh yeah, I remember that. That was pretty cool, or something like that. And so just make sure that that's the reason I brought you here, is so that you would have an opportunity to engage with these professionals that you're planning to be working with.
Mhm.
So make sure you take that opportunity.
I will.
All right. So, Mark, you think of anybody that we can bring in for? I was thinking during the breakout sessions, we could either
I was thinking that too.
we can either leave it running, and then we can bring in people to do the story time.
I think we ought to interview you for this, because that way all the other athletic trainers can be out there, that can know about it. But we need to probably do some more with Bob,
Mm-hmm.
and then maybe Bubba Wilson, kind of the memorial people themselves.
Yeah, I know Bubba's doing a breakout session, so
He is? Okay.
yeah, I mean he'd be a great if we were doing just a story
I think we should get you on there, kind of what you want to do. I asked you those questions in
Yeah.
your email. How far do you want to go? Why did you do it?
Yeah.
I think that'd be good, so that they can understand. And then talk about the schedule. If there's anybody else out there that wants to do it, we can do that now if you want. But I think that's a key interview, is just getting you on there as well. So.
I know I talked with or tweeted with Mark Weber. I think he's written a book called AT History, or at least on Twitter he's AT History. And so I'm interested. I'll get him in. Whenever we do the thing in July, when we start doing it in July, I'll get him and talk to him. And
Now, is he an athletic trainer, or is he just the history?
that I'm not sure.
because I saw an interaction you had, but I
Yeah.
only got your interactions, and it'd be blank, and then you'd reply that.
Yeah.
I didn't get what you were saying to him, but I know it's you in that
Hey,
conversation.
Jeremy, right now are the breakout sessions.
Right. And so we
We're
can
not recording it at that.
No, but we can pull people in.
Yeah, this is the time to bring others in. I'd like
Yeah.
to interview Jeremy about his program, about this, so that we can, he can get out there what he's doing, but also kind of let everyone else know about, they can call him and schedule it, so whenever you want to do that.
Why don't you guys do it? I want to go see how Dr. Shaw does the evaluation.
I'll run it, I'll do it, if you want, unless you want to sit in.
No, I want to see how he does it. That way I can take what he does and apply it to my class.
Okay.
Yeah.
You want to go now, or you want to do something else? It's up to you.
We can do whatever. Is there anybody else thinking about
Unless
that?
Bob Marley wants to finish, is Bob out there?
We can see.
I just saw him 30 seconds ago.
Yeah, Bob says he's busy with things there. So.
Okay. And I don't have anybody else. I was thinking, I definitely wanted to do Bob Marley, but it's you unless you can think of anything.
I mean, really, if there's like anybody that you know here, or somebody that may be interested in doing it, just pull them in and let them sit and join the conversation. And because the more people that we include, the more so that's pretty cool about doing it here. Everybody can see it.
Busted his leg, and he's like bored. They put a band-aid on it because he was crying. He wants to go to the hospital.
All right, we can say this one as me, and then one of you can sit over here. And
So
this
you're up? You do yours?
Yeah, we'll do it.
Let's do that. Can I take a seat?
Yep. You got you. You say that. You can say that Jackson. Hmm? It's recording. Do you record on start on the? You started on the device. Yes, we're good. I had written down some things whenever we first mentioned some measurable objectives, and I've never done it before, so I just wrote down some things that I would like to see happen. So I figured I'd pull those up and it maybe help us in the conversation. So
sweet. So we're good.
Yep.
So I'll kind of give you a background. I'm Mark Knobloch. I'm with the University of Houston Master of Athletic Training program, and with me, as you all probably know, is Jeremy Jackson. And it's kind of like we have a role reversal here, but I'll give the background of why we're doing it this way. Is Jeremy invited us down, myself and Dr. Josh Yellen, who's our program director, invited us down to talk about athletic training education and our program as well. And as we talked, I just thought that the opportunity is tremendous with this setup he's got here. And I think he's probably not very good on self-promotion without a little push. And so what I thought is we could actually talk to him about his program, about how it came to be, and probably more importantly, where he wants to take it. I asked him to talk a little about, for those in the GHATS area as well as those listening maybe nationally, kind of what his goal was, how it came about, like I said, but also what he wants to do for athletic trainers. We get CEUs out of this, and finally, and I'll try and kind of coax him along or guide him, but just kind of what you want to get out of this. And I know it's not, you really don't get anything personally out of it, other than you do it for the profession. It's not financial for you.
Right.
So why are you doing it, and where do you want to take it? Would you say just maybe kind of start off kind of how it came about?
All right. So you can see sitting over here is Sarah Avina. She's actually one of my students. She's a junior, or she will be a senior next year at Pasadena High School. And Sarah and Jasmine, thanks for coming. Neither of them are getting anything, but they are student athletic trainers, and they're getting to be here. And so for me, like that, I guess that would completely sum up why I'm doing the podcast, is because I'm bringing two students that desire to be athletic trainers to a sports medicine conference that I was telling Jasmine earlier I feel is sometimes over my head. So these students are getting exposed to things that professionals are still learning about, and they're getting to meet and interact with these professionals that could be their boss one day. And really that's why I'm doing this. Most of the time when we do this, it's with my Sports Medicine 1 kids. It's an introduction course, and we're working on improving that towards only athletic training students. But I want them to see the options that are out there for sports medicine. So if they take the sports medicine course and decide they want to be a registered dietitian, well, we've talked to Dr. Penny Wilson and Brett Singer. If they would decide they want to be a physical therapist, well, we're going to talk to Ryan Collins here in a minute. They want to be an orthopedic surgeon, well, we just talked to Dr. Lowe or Dr. Shaw, and they're getting to see all this stuff, and that's really why I continue to do it, is for the students. And then as I've gone about it, and especially after meeting you guys, like my wife is really good about encouraging me and saying good job, and she's listening live, and so I thank her for all the support that she's given. But with you guys being like, hey Jerry, this thing is really awesome, and
I think I've told you that about 100 times. How awesome this is really neat.
And so with that, and you're like, well, here, look, we can help you move it forward. And I've always wanted to do that. I want it to be bigger. I want it to reach more people. Everybody wants to do something great, but this is just something that I started, and I'm learning as I'm going. I'm not in any way an expert, but it's
actually that was my next question. I don't mean to cut you off, but I want to make sure we get that. You are not a media person. You actually started this, and make sure we hit on that, because I want everybody out there to know that they can do these kind of things as well. But go ahead, continue.
Well, nobody else can do this.
They can't do it. They can't take over sports medicine, but yeah, you didn't get your degree in audio science or anything like that. But go ahead and finish your thought, and then we'll kind of get into that a little bit.
All right. I'm not quite sure where I was.
You were talking about how you just did start. Your wife was giving you feedback, but
Gotcha.
It was still at this level. But it's for the students, and that's one of the things I want to make sure. I keep telling you how awesome it is. I want to make sure that this does not get out of their hands, because this is designed for them. You developed it for them, but it goes back to the students have a chance to learn from experts that come and visit them in their school, in their athletic training area, and that's the goal. That's your mission, you might say, is it still go towards the student.
Yeah, and so, since you asked me those questions, what would you like it to be? Where would you like to see it? And, what's the main focus? And I absolutely have to include the students, because it's something I do with my class. But I'm in no way, I guess, disagreeable. I would be completely for if we made the content to where it was slightly over their head, just so that it applies to all athletic trainers, because really the people downloading it are going to be athletic trainers. And why limit the students? Why dumb it down for them? Right. And so if I can raise the bar for the content, even if they don't understand it, Jasmine was sitting here telling me that she didn't understand some of it, but she may remember it when she goes to take anatomy class this summer. She's like, oh yeah, I remember Dr. Shaw talking about this. I remember Dr. Lowe talking about this. And then now she's connecting that, and she's already met a professional. And so I'm really excited about the opportunity to get with you guys and to work through some of these plans and goals and objectives and improve the level of content so that it naturally becomes more popular.
But I think it's important too when you mentioned about not dumbing it down to the students, but I think your guests need to understand that they need to be able to relate whatever their knowledge is about a subject. They need to relate it to individuals that aren't as educated. High school students or parents. Parents may be blue collar workers. They're not going to understand shoulder impingement syndrome or nutrition facts. And I think that they may be used to talking to each other all day, but they also need to relate it to a level of individual that doesn't have the background in education. I think that's important when they come on your show. You really highlight that. You make them talk to the students, but yet the information is still progressed so the athletic trainer learns something as well. So I think that's a neat part of your show. But I wanted to hit on this, but talk about how you developed this, because you literally just came up with it. You mentioned you went to a conference. So talk about how this all came. I mean, when I look at it, I can wire a stereo system. I can buy a stereo and hook it up and get music. But when I look at this, is like, how in the world does all make this make sense? And you came from that same kind of area where you didn't have this audio. I know you mentioned you did it at church a little bit, but this is really, something you developed from scratch, right?
Pretty much. Well, honestly, it all started kind of at the same time. I wanted to do podcasts because I'd heard about it and I didn't know what it was. And so I wanted to record my episodes with my students, my lessons with my students, and then post it online so that if they were absent, if they needed a review, then I could do that. And that's originally how it started when I was teaching biology. And then right about the time that I was starting to give up on that, we switched to being not science and math teachers, Bill and I, but we were only sports medicine teachers. And then I was like, well, now I got a lot more time. And then, so I wrote some grants, I got some equipment, and so then I started just doing, what the students did was take pictures and then do a photo story of how to tape a thumb. And then I'd post it to YouTube. Well, that's not really a podcast, right? And so then I went to this conference at TCEA, Texas Computer Educators Association, and Mark Cockrell was doing podcasting live. So what they actually did was a presentation where they were podcasting it live, and then, they told us how to do it, what they do, and then they did like a 15-minute episode. And so then I'm like, oh, I see how it works now. It's a talk show kind of thing. And so that's where I came from. But at the same time, the guy that ran the sound at the church, like, I was friends with him, so I'd go and sit up in the balcony with him and learn about what he was doing. And then he went to a different church because that's where his girlfriend was going. And so just because I was the only one that had any idea, I was now the person running the sound at church. So then I just learned by doing, and I think that's one thing that I've mentioned before is I'm not really afraid to fail. I just go for it, and if I fail, it happens.
So no formal education in audio.
None.
It's just you just picked it up along the way.
Right.
Yeah. And it's turned into this, and we hope to turn it into something big. So something else that was interesting to me is you can get actual CEUs for this as an athletic trainer. Can you just briefly talk about that little process?
All right, so I'm actually the webmaster for GHATS, the Greater Houston Athletic Trainer Society, so ghats.org, and that's who sponsors the CEU opportunity. I was friends with Bob, and I've talked with him before, and so he is one of the GHATS people that issues CEUs, or is kind of in control of that. And I was like, hey, do you think we could do this? And he was like, yeah, sure, that's fine. That'd be awesome. And so, I began posting the stuff on my website, and then the course evaluation is on ghats.org in the members area. And so if you're members of GHATS, which is $20 for a year, then you can do all the course evaluations. And so, as we develop this, we're going to create a better system for getting certificates out and those kind of things, and creating quizzes. But being a member of GHATS, it benefits them because could be people from all over the country or the world becoming members, and increasing the revenue for GHATS, and that's my local organization. And then at the same time, they're getting these CEUs while, like you said, that while they're sitting on the back porch, while they're driving to work, while they're working out. I mean, I listen to Dave Ramsey all the time when I'm working out, and that kind of thing. So I listen to a lot of podcasts when I'm working out, and people could be doing the same thing, but getting the credit for professional development. And so that's another reason is I want to improve the level of the content so that it is a go-to source for CEUs rather than just I'm in a pinch, I got to find something. This is $20.
Just do a quick eval.
Right.
Now, something I liked about your setup is you don't necessarily invite people, but you also advertise that you will take speakers. So anybody out there that wants to talk about a topic, you will have on the show if they want, correct?
Pretty much, as long as it pertains to sports medicine.
Yeah, sports medicine. So if anybody's out there you went to a conference and you really think this is a neat concept, or you've read about this, you just want to discuss. And I think you had an interesting one. I listened to part of it. Was individuals that don't believe in ice. You had them on. You had a debate about the pro and con kind of thing. And I mean, that's where I think that I would like to see this. We could make, go through the BOC to get the CEUs, but make a quiz out of it, and make, and not just, listen to it, get the CEUs. It challenges you, and maybe get, some higher ups on the CEUs. We look at PTA and, keep sports medicine. But I think that's awesome. I mean, so anybody out there that has an idea or a concept that they want to cover. I mean, we literally, it's funny how it came about with us is Penny Wilson was on there, and she had been on TV a couple times, and she would always tell me, he's like, hey, I'll be on this and this and this. And at the time I was doing my postdocs, I wasn't sure I was getting back in the profession, and I kind of put it off in the back of my mind. I listened to her and everything, and about 3 or 4 months ago, I talked to Dr. Yellen, and I said, hey, you know what, this is something I want you to look at. We could really get on this, and this would be really neat. And so we came up with the idea that we could talk about graduate education, or we wanted to discuss our program, but mostly the entry-level masters for those, especially in Texas, who don't have their BOC certification. We want to talk about a program, and it turned into this, wow, this is just an asset to I think what you're doing for the profession is one thing. You mentioned, you're helping your association, and you are, because you're giving them a CEU opportunity, but you're also putting knowledge out there.
Right.
I mean, there's a lot of things. Yeah, I can serve on a committee, and I can be, be an officer or something. That's one thing. You're serving your profession, but you're actually putting knowledge out there for everybody, and you're coordinating these group of experts. So can you just briefly tell me kind of some of the areas that, for those that are listening that may have an idea, who have you had on, recently, or what areas have they focused on to maybe spur some ideas out there?
All right, so I will go ahead and say we do have a BOC number, a BOC provider number. So you can get BOC CEUs for this, and so anybody listening anywhere that's a certified athletic trainer can get the continuation credits. It's not just like a state or a local number or something like that. So it is BOC, but if you go to sportsmedicinebroadcast.com, we actually have 86 episodes, I think, up to date, 85, 86. And, we've had a sports psychologist. We've had Dr. Summer Ott.
Who will be on shortly.
Who will be on shortly. She's a world-class neuropsychologist, concussion expert. We had Dr. Penny Wilson come on twice. She recommended Brett Singer. She recommended Dr. Knobloch and Yellen, who have been on there 4 or 5, and then after all this, they've been on there about 40 times.
Oh yeah, 4 listeners.
And so we've had Roland Ramirez from the Houston Texans. We've had Josh Stone and Steve Kennelly. Steve Kennelly is an athletic trainer for the New York Giants, and Josh Stone is an editor for Human Kinetics. And they were going back and forth about whether or not to ice, and it was Steve was saying you should use ice. But just know why, and Josh was saying, don't use ice at all, and that kind of thing. And so I don't feel that I'm an expert, and so I talk to experts. I talk to people that know more than me, so that I can learn too. And so bringing in the person for the students, but also somebody that's going to appeal to me, because I am an athlete. I learned actually what an entry-level master's is when you guys came, because to me I thought it meant you come in as a freshman in college and then do a dual kind of thing. And so just talking to you guys, I'm like, oh, well, that makes sense now, and I understand why people want to do that. They want to create that, and it should create higher quality results in the end. And so, I don't know how many other. I can't think of all the other. We've had plenty of athletic trainers come on. We had Will Carroll. If you're on Twitter, he's injury expert. So he's not even an athletic trainer, but he writes for Bleacher Report, and he's one of those people that's always in the know with professional sports injuries, and has always got a opinion on professional sports injuries and that kind of thing. And Jeff Stotts writes for RotoWire, which you may know from Yahoo Fantasy Sports. They're the ones that publish the injury reports on Yahoo Fantasy Sports. So he came on. We had him there. It was via Skype. So we can really talk to anybody in the world. I have my friend who lives in a different country. He had to wake up at like 11 o'clock at night or whatever it was so that he could be on with us at like 8 in the morning. And he's a former athletic trainer. And with that one, we just told stories of how me and him did dumb stuff when we were student athletic trainers in high school. And, it's things that, hey, you can just get a laugh at, or you can figure out, hey, I want to make sure my students don't do this because I didn't know that they were doing it behind my back. And so...
You didn't record that one, right?
Oh, yeah, that was posted. That was posted. I gave a warning at the beginning. Hey, you might want to let your students listen or see this.
So, from a student aspect, what is Sarah, right?
Yes, sir.
So from you've had many experts come on. What do you see the experts bringing? Obviously, you hear about stuff. Does it hit home, or is it to give you the opportunity to see different areas that you may want to match yourself up with? What's the biggest benefit that you see from a student aspect?
I think it's getting to meet all of the people that come in and getting to hear their experiences and learning new things from them, things that Jackson doesn't know, and we both learn at the same time. So it benefits all of us.
And you guys are involved in the show as well, right? You're not just
Yes,
sitting
sir.
there listening. What do you guys? What is your responsibilities as a student group? I know you have individual ones. Just tell what is your.
Well, Sarah was actually two years ago. She had it as a freshman, and so she could probably talk to what it looked like. Tell us what it looked like, or what it was like whenever you were in the sports medicine class. Do you remember?
Whenever, I think we had just barely started inviting people, didn't we? I think we barely started inviting people, so we were kind of new, and we would just work the recording, and we were learning how to use the microphones, and we were just learning as we go, and it was kind of hard at first, and then we had to edit everything, take out the parts that we would mess up, or we would practice and we would have to edit those. But it was a lot of practice, and then on Wednesdays we would have our podcast. So.
Did you have a favorite topic?
I don't know, really.
No?
I don't think so.
Nothing stuck out, so everything was interesting, probably.
Yes, sir.
I mean, I'm sure there was some that were boring because it just didn't. But I mean, I think that's in the whole profession. There's things I'm interested in that, I'm just not a fan of doing other things that aren't as fun. That's natural.
I think I enjoyed the most is rehab. I like learning rehab. But I didn't like the one where they asked us about our work because I felt like Jackson was watching us.
Oh, yeah?
Like, do you like working? Do you like moving all the ice? No.
Well, you just give the generic, yes, it's the best thing that's my favorite job. Yes, that's my favorite job.
Of course.
So what have you learned from this, either from a broadcasting side or from a student athletic training side? Can you think you've really learned something out of this other than individual topics, but how to coordinate or?
I think I learned how to communicate better with people that I don't really know. I've learned to talk to people that know more than me. I think I've experienced a lot more than I thought I ever would.
Probably not as afraid to ask questions when you don't understand something.
Yes,
I learned. Because you see this expert, and it's like, I don't want to ask them, it'll sound stupid, but that's the thing you learn. There's no stupid questions. If you don't understand something, you don't understand it. So you have to ask a question when you're in class. The same thing. Dr. Yellen kind of got onto his class the other day. Is if you don't say something, I don't know that you're not learning and it's not clicking. So you have to tell me, and that's important whenever they're an expert. And that's why they're there. That's how they became experts. They learned, and that they hopefully will want to pass that on to individuals as well.
That's one thing Jackson's always told us, is not to be afraid to ask questions. So I think I've learned more how to ask questions and figure something out. Or if I don't want to ask a question, I'll try to remember something. A lot of times I don't ask questions, but I don't know.
Because you're that smart. You don't need to know. Ask questions, right?
No, that's not it.
So, questions I had for you back, I mentioned that is, obviously you want to keep this from a student focus. But how far do you want to? Are you? We talked about you have the equipment you need to function. There's always room for better equipment.
Right.
And at the same time we don't. But at the same time we don't want to turn into something and just buy things because we want them. But what do you look at for, say, in 5 years? Where would you like to be? Would you like to have a national show? A national tune-in show? Would you like to keep it at the podcast level? Do you have any ideas of? Because I think it's growing. I mean, it has grown obviously for you in a couple of years. But how far do you want it to grow? Do you want to keep it at the local level? What are your thoughts, or have you thought about that? Because you're now this instant celebrity almost. You're getting all these tweets and retweets.
Yeah, right. I don't know about instant celebrity, but I have thought about, and I mean, honestly, I would like to take it as big as it would go. I'm not sure that I would want to have like a national call-in show, but with the podcast, I can have somebody call in. I can have Skype or Google Plus, or even with the other cool tools on Google, I can have somebody phone in and then be part of the conversation. And so, what I really want, and I feel is lacking now, is the live interaction. Because Jasmine, look down on the right-hand side of the screen. How many people are? It says one viewer. Yeah. So, as of right now, there's only one person viewing this live. It'll be loaded onto YouTube, the whole 8 hours, because we're doing one stream per day. So I would like for that number to be, 5, 10, 200, 500, 1,000.
I think it's really cool. You have Twitter open while you're doing this, so people can actually tweet questions. And
right.
I think that's happened before with a couple people that listen faithfully. Is they'll ask you a question real quick, and you can shoot that out to the expert or whatever, and that's really neat. And you mentioned we talked individually. You could use some equipment, so maybe we can work on some grants to get this to a bigger. But not necessarily a call-in show. But I think you have such a target audience. You have athletic trainers, and you have this expert panel that you can bring in, and I think that's huge. And I think the profession needs to know about that more.
And Dr. Yellen I didn't know how many, but he said there's 41,000 athletic trainers, and I mean,
certified athletic, plus Texas LATs as well. Yeah.
Yeah, and so if you had 41,000 people listening every week, I mean that would be pretty phenomenal. And I'm not trying to appeal to people that have in no way aren't sports medicine people at all. And it would be cool if it's relevant to anybody, but sports medicine people are our audience. And then also there's all the people that are like me that teach. And next year I'll have 15 students in my sports medicine 1 class. So anybody like that's a teacher, they can put this on live, and their students can interact.
That's what I want to do. Is you mentioned we have 41,000. We have probably a few hundred, maybe 1,000 athletic trainers in Texas. We have PTAs, we have PTs, and that's a tremendous pool that we could have an audience that's just for the sports medicine topic. We're not talking about regulation issues in physical therapy. We will talk about governmental or regulatory issues in athletic training. And you mentioned something interesting is just bring students in to learn about the sports medicine profession. So I think that's where, when I first visited you, I was so blown away, and I told you 1,000 times that this is such an asset. But you don't want us to come in and you want to keep this at a student level. But if you do, I think we need to think things like writing grants to the NATA, technological grants, or looking at Memorial Hermann Sports Medicine Group, and how can we get them involved and get them out there as well. But I just think that it's like I said once, it's a powder keg we're sitting on, but yet we don't want to take away from your focus and your mission, which is to keep the students involved.
Right.
But yet at the same time, you have a tremendous educational opportunity that athletic trainers can sit there on the football field while they're walking around with a little microphone in their ear, put their smartphone on, and listen to a podcast and get CEUs.
Correct.
And so as long as we keep it so that it's allowed for CEUs, which is a challenging curriculum kind of thing, and really talk about focused issues, even though if you put it down to a student's level, I think that's a tremendous asset. So I think this is just huge. And now here you are at a conference pulling in speakers after they've talked to get a one-on-one. And I think people listening, or when they download the podcast, they can get so much information out of that. And it's so much different than reading a journal article.
Right.
But I think advertising, we need to get in the NATA news and maybe TSATA, have Bob Marley do a couple e-blasts again and just say, this is, we're trying to expand this and we need individuals involved. But I really think it's cool that you invite people to talk. So anybody out there is eligible. They don't have to be invited. They don't have to sell themselves to you. And I think that's just, maybe someday we'll have to invite, because we get so many requests that we have to pick out the hot topic or whatever.
Right.
But it's huge. And so I guess I've kind of got what I wanted out of it. So did you have anything you wanted to add, or?
Yeah, I mean, like I said before, I'm excited, and I would like to make it larger. You know, there's obviously, I would want to improve the quality of the video stream, and I would want to improve the quality of the audio. And you know, sometimes my studio is split into one. There's one large room that's split by some metal shelves that I put up, and so in the other side there's football watching film. So you may hear the coaches yelling at the kids or telling them good job or cussing whatever during the middle of one of the shows on some Wednesday. So you know, obviously I'd like to have that moved, but I don't think it's diminished anything. I think it really is, like you said, it's just inviting people. There's been a really good response to that, and then you know, you get amazing people like Dr. Penny Wilson that invited Brett Singer. Hey, you really need to go on this thing, you know, and it was cool. I'm glad we got to talk to Brett, and I'm sure I'll talk to him again. I've interacted with him a couple of different times after that, asking questions, and then just telling you guys to be on here.
I think that's kind of a tribute back to you because it's well run. It's not, you know, you get up there and you know everything was lined up, it was ready to go, the students were interactive. And you were I mean, you dictated stuff very well. It's like, okay, you talk about this, and I think that was a big part of why she invited people. It's because it was a well-run program, and so I don't see that suffering. Obviously, if we go to a bigger level, but I mean, that's a tribute back to you, like I said.
So I mean, I'm excited and I look forward, and you know, as we continue to talk about this, I know I made some notes here about stuff that we would like to do. Let me look and see if there's anything really important. Jasmine's tweeting pictures of me over there.
She's paying you back.
You know, and you had said something about, you know, I'm not getting any money, and you know, if there was an opportunity to have a corporate sponsorship, I would do that, but it would be to put back into the program. It's not like to pay me.
Right, to reinvest in your program. Yeah.
So if, say, the NATA or Memorial Hermann, if you're looking behind me, you know, they're allowing us to do this. If they were to invest a bunch of money, it would improve the equipment, or maybe make it so that the students all had a polo that said Memorial Hermann, so that whenever they're on the podcast, you know, Memorial Hermann's getting branded. Those things that'll improve the profession, and you know, maybe allow for us to do more mobile stuff where we go out to more conferences and, you know, improve the quality that way. But you know, at this time, I'm not really seeking anything. There's, like, if you're watching the broadcast when I'm at the school, I have a banner behind me that's fund for teachers, because athletic trainers, I don't know what the numbers are, but a lot of them work in high schools with students. And so when I talked to Stephanie Asherle from Fund for Teachers, you can write a grant to go to the Summer Olympics. They'll pay up to $5,000 for you to travel to the Summer Olympics so that you can meet and interact and learn from the sports medicine professionals. Or, like, I'm planning to write one to go get certified with the FMS and FMA, and it just happens to be one in, like, Australia or you know, different places like that over the summer. You know, there's some other
just happened to be
in Vancouver or Australia. And so those kind of things, you know, I want to continue to promote those things that I have experience with, but it's not about making money in any way. It's really about
improvement the delivery.
Improving the profession. Because I do learn a lot. I listen to Family Life Today podcast, and it's about family life. It's about how to model my family after Christ, and I learn a lot by listening to that. And so that's what I would want for this podcast, is athletic trainers to learn a lot. You know, obviously it's not the same as going to a class and putting your hands on a knee and feeling what the Lockman is or the anterior drawer.
I think when you bring in experts, one of my things is, what's the current trend? What is out there that we need to know about? Because we don't read orthopedic journal. I mean, we might, but I don't read the ADA's journal, and that's where the most recent literature is at. So what can they bring? And just tell us, you know, what is going on that's new, that maybe the current trend or the focus. Because there's many people that were taught something many years ago, and that's what they still do.
Yep.
Maybe that's been shown that it doesn't work anymore. And so that's what I think this live broadcast. You bring in an expert that knows the literature, and they're gonna tell the audience, this is something you need to think about, or start reading up on this, because it's true, and at the same time, this is what's crap in the literature or crap in the advertising you see on TV.
Right.
I asked the dietitian this morning, I said, how do you differentiate between what's on TV for supplements and what really works? And she said, that's a great question, because that's her job. She's the filter for people to go to. Don't go to Google and get the advertisements and say, this will work for you for $199.99 plus shipping and handling.
Right.
You know, go to the experts and ask them. And I think that's a big delivery tool that this allows, is just exactly what you're saying. It's geared, it's focused, and brings in the expert to give that current knowledge that's out there and it saves the athletic trainer time. So I mean, it's just it's almost cliche now. It's a huge asset to the profession. I just can't talk enough about it just from just learning about it myself. So.
I don't know that I have necessarily anything else.
Sarah,
do you have any other thoughts? Now I will say that when Sarah did it, we weren't doing it every Wednesday. We were doing it when we could get it done. We weren't doing it during football season, so we didn't do it during fall football or spring football because we were busy setting stuff up, and I didn't want to deal with the guys being in there. But I was like, look, this is one of the best ways to connect with people is having regular content. So I was like, I'm not doing anything over the summer. So for the past 3 years, I wasn't doing any podcasts over the summer. Well, I always come to this workshop, and I was like, we got experts, I got content, and then, like I said, God just placed you guys in my life at the right time to where you guys handle most of the interviews. You guys are experts, talking to experts. I mean, it doesn't get much better than that. And so I'll be able to, edit, produce these, and post them over the summer. And I've already got some of the interviews that we did with you guys scheduled to release like through June 20th. So I'm going to have something released every Friday for the summer, and then, through August or whatever until we can get everything rolling again with the students. Then I've already got stuff being released, so there's a continual stream.
There's no dead time in the football season, right?
And so, I mean, we'll last year we actually did it all year long, and I think there was 30 episodes that we did, and then so it'll be probably 50 or 60, and as long as we keep Dr. Yellen off the mic, it'll only be around one per week. But if we allow him to give
2 hours if Dr. Yellen's on the mic, and I think that's important because you have the opportunity for all these shows. You need experts to fill them. So anybody out there that has a topic they want to cover, that is an expert that can give true opinions on the topic. And I really thought that was a cool idea you did with the ice, was you did a pro con or a debate, and you had two experts that were staunch in their own opinions right there. And I think that was just awesome because what's really neat about that to me is you're not just getting the same information over. You're getting somebody that says this is the best, and somebody says no, I disagree because this. So that makes the first person be an expert. The first person will challenge the second. So it really makes sure that when you get those kind of things, the amount of information that comes out of those is astounding because you have two completely different opinions with expert information and science behind each. I think I only listened to half of it. But it was fun to listen to. And I think those are really neat to have on there because of the amount of information that comes out. So. Yeah,
I was really impressed with that one. I mean, for me, like talking to somebody from the New York Giants, Steve Kennelly, you kind of get a little starstruck. You're like, oh well, that's athletic trainer for the Giants. Yeah. And I mean, he was just as cordial as could be, and he was like, hey, this is really cool. Thanks for having me on here, and and so he is an expert in this field, and Josh Stone is an expert and does a lot of research and does a lot of reading, and so I really respect both of those guys. I like reading what they post, and so for me, it was really cool to put them together. And like you said, there was about 30 minutes where I think when I edited it was 30 minutes that I didn't say anything. I just said, this is who it is. This is what we're doing. He said go, and then they just back and forth, and it was awesome.
And they kept it cordial. I mean, it wasn't it was a professional argument. Right. It was just bringing the facts and bringing why I think, and they were very cordial, like you said. It was like, I think he's very smart. He makes some great points.
Right.
This is why, and I think that's where that's something our profession needs is we have to know. And it's funny in a way because that's what Dr. Yellen and I run into is we have this Master of Athletic Training program now. But we're in Texas. Texas is LAT.
Right.
And we've run into that to some level. At a very cordial level as well. That's why I'm never leaving Texas. So I don't need ATC. So you guys you're not serving this really much. You're in the wrong place. But we've also had people we've explained is people get married, people lose their jobs, they have to move.
Other opportunities come up.
Yeah, other opportunities, and so you don't want to be stuck here. And that's not why we're doing this because we want to be in Texas. We're doing it to provide a service, but there's individuals too that may go to college for a few years and decide that hey, I want to be an athletic trainer, but I haven't been a student athletic trainer in college, so I'll go and get my master's degree. We get a master's degree, get my ability to pass my certification test or get qualification for it, and there we are. So on the same level, I mean, you can have an argument it's not an argument like you think of traditionally. It's a professional argument. You're just making points, and you're supporting your stance on something. I think that was really neat about that pro con. I'd love to hear more of those. I mean, that was really fun to listen to for me as well.
So Twitter is at PHS Sports Med. You can tweet me, or email is jhjackson@PasadenaSDA.org. But all of that can be found on sportsmedicinebroadcast.com. And then, if you have an idea, a topic that you want to talk about, you want to hear about, then either send me your name and then we'll get you on, or the topic, and then we'll find experts that in that field. So I mean that's the one thing that I feel is really lacking, because I mean I got the website, I got the pretty good sound quality, pretty good video, and I feel like I'm getting experts, but I just don't feel like I have a whole lot of interaction. And I just looked at the thing last night, and I've only been using the Blueberry statistics since October, but have over 10,000 downloads since October. And so I'm like, if there's that many people listening, downloading, then why isn't anybody interacting? I know Mike Hopper does. He interacts quite a bit.
He's done a lot, yeah.
And so, Mike, I really appreciate you interacting, and, good luck on finding a job down here in Texas. But I want more people to interact, to ask questions.
Yeah, you want the live interaction, absolutely. And I'm gonna after this is over, I'm gonna talk to you about maybe just a simple email to the NATA News and see what it takes to get it. A blurb in there that this is going on live at Wednesdays at 10 o'clock. Join in live for the feeds, and then as well the downloads. So we'll see what we can do on our side as well. But the benefit is there. We just need to get it out there.
And then in a lot of shows I talk about, it's on iTunes. It's on most of the places you get your podcast. So if you rate it in iTunes, you don't have to write a review. If you write a review, it's better. But if you just rate it, then it allows other people to find it. So the more ratings it has, then obviously it's more popular for iTunes directory, so it's easier for someone to type that in and find it, or it pops up at the top of the list instead of at the bottom of the list when you type in sports medicine. And so if you're listening, if you download this, then you just go rate it in iTunes or in wherever you get those from. And so that'll help us get the word out as well and help people find it. Anything else?
All right. I think we've talked enough, so I just wanted to. It's funny, Jeremy wasn't really keen on this interview. I think he was kind of likes to stay behind the scenes, but I really thought it would be important for people that listen to know how this came to be and where it's going to go and everything. But it also gives him a chance to kind of talk about these ideas that he just had started as a biology podcast, and it turned into what is just this great opportunity for continuing ed for our profession. So if anybody out there wants to join in, please. Email him. You can find that at the sportsmedicinebroadcast.com, and get on the show and get your ideas out there, and keep listening and spread the news. So,
well, this is how I normally end it. So for Jeremy,
Sarah,
Jasmine,
and Mark Knobloch,
that's a wrap. So that's how we normally end it, but we don't have to end it that way this time. So
end it, but we're going to keep going.
Like you said, I'm not real keen on being interviewed. Like. It has completely changed, like Sarah said, the way that I communicate, because I have a lot more confidence, and so I'm not afraid to talk to interviews. I feel like the conversation flowed pretty well, and I don't feel like I'm somebody that talks all like Bubba talks all the time, Josh talks all the time.
You're good at prompting.
Yeah.
Say X, or what is your opinion? But you're probably not good on expanding, so because you're just not used to.
Yeah, and so that's just one of those things. The more we do it, the better I get. The more I want to learn. Take some sort of broadcasting type course so that I can develop better questions.
You make a restroom.
Right.
Should be about done with the breakout. No, it's only 12. Probably lunchtime.
This guy here.
Hey, Jeremy, it's lunchtime.
All right. Are they eating right now? So, what do you think you guys are going so far? All right, so we're going to leave the live stream going during lunch. Who knows who's going to come in? Somebody may come in and bust out something. I don't know. But come back and watch us later. Or watch Jasmine kick over Cokes sitting on the floor. So again, sportsmedicinebroadcast.com. And thanks to MH Sports Med on Twitter for allowing us to be out here. I'm going to lunch.
You can just hear Bubba talk there. Where'd Mark go? That guy is like a ninja. You turn around, he's there. You turn back around, he's gone. So we have a couple choices. Oh, I need you to tell Bob your website and then your Twitter. All right. Hey, Bob.
So if they want to get on.
Yeah. Is it another sports medicine?
No, it's just business. Yeah, I'm only live broadcasting the interview, not the session. Well, the lecture, no, I'm recording it audio, but it doesn't come off that day. They will all be on there. Probably.
So they can see the interviews before you show here.
Yeah.
Or ask them. Now, Bob, we need to do part two to it.
The legends born.
I'm just so pissed off at all that. It's just, and he said, you know, how, he's like, you wouldn't believe all the stuff he had come after and stuff. He just kind of went on and he's very, composition. And I said, he's supposed to speak here tomorrow. So it'll be very interesting. Yeah. But yeah, I know it's very, yeah. That's what, so you guys not got the barometric respirator coming up. But it's awesome. Might as well, yeah. He was quite good.
Ryan.
Right here, Ryan.
Here,
Ryan Collins, right? Have a seat.
You gonna put me on the spot?
I am.
Good.
Hey, welcome back, everybody. This is Dr. Josh Yellen, Program Director for the Master of Athletic Training Program at the University of Houston. You can find us on the website, www.hhp.uh.edu/MAT. Sitting here with Ryan Collins, who is a physical therapist and a certified strength conditioning specialist. Ryan, thank you very much for being with us.
Appreciate the offer.
Tell us a little bit about you. Where did you go to undergrad? Where did you go to PT school? Tell us a little bit about how you got here.
Played baseball through high school and knew I wanted to do something with athletics. When I got to college, I went to Sam Houston. Thought I would walk on. Ended up blowing my arm out. And so decided, well, I guess I can't play baseball. Let me do something along those lines. And didn't actually go to rehab, which is probably something I regretted, considering that I'm in the field now and know that there's a good bounce back. But got back into rehab, got into the athletic training side of things, got some kinesiology, graduated with a degree in kinesiology. I thought I wanted to be a coach. Realized it didn't fit too well with my personality. And so,
like Bob Marley, you were too nice?
Absolutely too nice. No, the little kids, you can't tell them what to do. Anyway, but so decided I go, get a summer job at a PT clinic, and ended up really liking the guy who I worked with, and he talked me into going to try out PT school. I went to UTMB in Galveston. Had a great time, learned a whole lot, and kind of led me to where I was, where I am today.
And what year did you come out of PT school?
2008.
2008.
2008.
Did you come out with an MPT or did you come out with a DPT?
I have a master's. Actually, my class was the first year to be offered the transition to a DPT, and I thought, well, the offer's nice. The opportunity to go get your doctorate in physical therapy didn't really pertain to me, only because you don't get an increase in salary coming out. You can read an X-ray and you can have another class on differential diagnosis, but I feel like the experience I was going to get for the year and a half in a PT clinic was going to be more valuable for me than an extra year and a half and the money lost being in school. So
now at some point, I think the APTA is going to say everybody's got to go through that transition. If you're a BPT, I remember back in the day they were a registered physical therapist and they moved to licenses. And so if you were a bachelor's in physical therapy, you took a transitional DPT and master's, they're going to do the same thing.
I would assume so. It's going to be a lot of people having to do that, though.
There's
still a lot of BPTs and NPTs practicing, so
that's right.
You're going to have a lot of people probably fighting that. But hey, if they want it to happen, I'm sure they're going to make it happen.
Yeah, that's right. It's a clinical doctorate. Okay, so from that point on, you go on and you get your CSCS.
Yes, sir. I've always been I've enjoyed exercise. I've never been great at it. I'm a hard gainer.
I see your guns, man. I mean,
yeah, well, I'm a hard gainer. That's been about 6 years in the work. But no, I'm a skinny kid. I can run real fast and look like a cancer patient real fast.
Oh, really?
Yeah. So I have high metabolism. So for me,
lucky.
I know being in the exercise field. What I felt like is, if I'm going to have an athlete come in who can obviously lift more than me, I need to look like it, but also be able to demonstrate these exercises. You come in and you see somebody who's out of shape who can't do a sit-up, you're going to lose that patient real quick. So part of it was the buy-in, being able to have somebody come in and be able to talk to them about exercise. If they have a problem squatting, at least I can say that I know how to squat and I've squatted before. Show them the proper demonstration, and then you challenge them. If you can do something that they can't do, that obviously challenges an individual, especially athletics and competition.
Right.
So the CSCS was right up my alley.
And at a PT school, did you take any specific courses in sports?
Specific courses as far as like continuing education?
Certifications for...
No.
I know in physical therapy now they've got these sports medicine residency programs.
There's a residency program that was offered at my company, but about 2 years after I started, and didn't think I could stop getting a salary to go get residency and fellows. The CSCS was right up my alley. The APTA offers the SCS,
right,
which is the certified or the sports certification specialist. And I plan on doing that this coming year. So taking the test in 2015.
Time and money.
Absolutely, it's time and money, and my company's nice enough to pay the test if I pass it.
And so I see on your shirt here, your Memorial Hermann Sports Medicine Rehabilitation.
Yes, sir.
That's your company.
That's right.
And I'm happy to say that the Master of Athletic Training program has affiliated successfully with Memorial Hermann Sports Medicine Rehab. So you're probably going to see some of our Master of Athletic Training students coming through.
Cool.
We also
Excellent.
affiliated with Ironman Sports Medicine Institute, Memorial Hermann Medical Group, and UT Physicians Department of Orthopedics. So these guys are going to have a real well-rounded education. As a matter of fact, we work pretty closely with Brian Duncan and a couple of his
Absolutely.
residents. I helped Brian build that program from academic assessment, and he and I have worked pretty well. He just went through an accreditation process,
Right.
and I think was pretty successful. So let's go into your topic. You talked about core stability,
Yes, sir.
right? And when I was in school, I learned about this theory called ontogeny recapitulating phylogeny, and that if you understand all really the stages of what we call evolution as the human being goes from a quadrupedal mammal to a bipedal mammal, that we understand core stability and how physics works on the spine. And if we really look at the core from, say, the sternoclavicular joint and go down to the pubic symphysis, that's really what we're talking about, right? We're really talking about the core.
Well, what is the core? I guess that's the big question. I think everybody has their own definition of
So
it.
why don't you define what the core is?
Well, I don't really know. I'm going to tell you, I don't know exactly what the core is. I can just probably tell you what I feel like the core should do.
Okay.
And that would be to, limit excessive motion through your lumbar spine. If the lumbar spine is built for stability, then it needs to be stabilized. And if you have joints above and below that can go through the mobility, you train the mobility at the hips and the thoracic spine. And then whatever core muscles you want to talk about, if it's the TA, if it's the lats, if it's the obliques, whatever they need to do.
For those that are listening and are having trouble keeping up with your abbreviations.
Transverse abdominis.
Yeah, there you go.
Latissimus dorsi. Sorry about that.
Yeah.
But in general, on my presentation, I talked about there's 29 different muscles that can be considered part of the abdominal wall.
Quadratus, lumborum, and multifidus are two that pop up causing problems in that core.
Absolutely. Those are the deep system, and then you have the superficial layer that everybody works on for your killer six pack.
Yeah.
That people say, oh, I'm gonna have a great core if I can do 100 sit-ups and 100 crunches in a row.
Yeah. What do you say to those people?
I say you're going to have a great six pack, but let me ask you to stand up and then not let your back arch as you start to do a squat.
Uh-huh.
You don't see the carryover with that type of exercise. They don't have the control. Stability is trunk stability. Sometimes I go back and forth between core and trunk stability because that's really what it is. The core, whatever it is ideally stabilizing the trunk during motion. So you want your legs and your arms to be strong and have your core be that energy transfer, so that you can transfer your strength from your legs through your core, through your trunk, up into your arms, into a bar, into a baseball bat, into another defender. Or
So
whatever.
let's talk about the muscles of the core. Let's go back to that, right? And let's start deep and let's go superficial. So the deepest is what you think, the iliopsoas group?
Yeah, the rectus spinae group, the transverse abdominis. Sits there right along the spine as well.
Kind of your internal weight belt. How do you activate that transversus abdominis?
That's a good question. There used to be a big theory out there called abdominal hollowing.
Uh-huh.
And that abdominal hollowing basically said if you can activate your transverse abdominis, that's going to increase your ability to stabilize your spine.
Mm-hmm.
And that came from researchers finding that the transverse abdominis would shut off and have a latency whenever your back was painful. So people who reported pain, the transverse abdominis was one of the muscles that turned on late. So it's like, well, if we can just isolate it and turn it on and practice turning it on, it would just magically turn on when everything else would.
And how did you turn it on? I remember they would tell you, suck in your belly button.
Absolutely, suck in your belly button. You're supposed to put your hands right above your ASIS, and you feel this muscle just kind of pop up. That's what I spent my time doing it. I honestly learned it in school, and I did it probably the first few years in PT. You just have them sit there, and they're squeezing. We don't know what they're squeezing.
And you learn to suck in your belly button and hold that and be able to say your ABCs without
and breathing. And which then you have them stand up, and then you tell them to suck in their belly button when they stand up, which is obviously non-functional. So I think right there in the carryover wasn't adequate, especially when you start dealing with sports. You're going to tell somebody to run a 40 and then a lateral shuffle while tightening their transverse abdominis so that they have the proper stability in the trunk. It didn't make a lot of sense.
So you're really talking about the difference between what we like to call gross anatomy and functional anatomy.
Right.
And then so there's some of the deep muscles. Let's go maybe the middle layer.
Okay.
What are those?
Well, what do you consider the middle layer? I'm not sure.
Well, I mean, you've got.
You're talking about.
You talked about transversus abdominis.
Okay, so that's
you
deep.
Talked about right. You talked about the. We brought up the quadratus lumborum and the multifidus, and I go anteriorly out from the transversus abdominis. Now I've got rectus abdominis. I've got internal and external obliques. Yeah.
Yeah.
So those are considered what, middle or superficial?
I consider them superficial only because you would see them, right? You can work on your obliques, you can work on your rectus abdominis and see the results of that if you're going to do an isolated type exercise or an isotonic exercise.
Yeah, and then if I go posteriorly, I'm going to work back on the rectus spinae.
Rectus spinae.
Right.
And then, like I brought up in my talk, the lats. The lats attach all the way down to your iliac crest, and they go all the way down, but they go all the way up to your T7 as well.
Yeah.
So I mean, you can consider that muscle group kind of stabilizer as well for the posterior core.
And so let's go into some exercises that you think are the most important in stabilizing the core, right? Because you have some people that are listening and they're going, well, I can sit on a physio ball. I think that's core stability.
Right.
And I can get on and I can do whatever you want to call it, the quadrupedal stance or some people call them Supermans or prairie dogs or whatever you want to call them.
I think, well, it's a loaded question only because you have people who are at different levels. If you have your typical low back pain, non-active type person who comes in with a poor posture, you need to be able to control that posture. Not necessarily have them be able to cut and run, but just to be able to stand and pick up an ice chest in the garage and not have pain, or even be able to stand at the kitchen sink and do dishes for more than 15 minutes. But if they're sitting in this anterior pelvic tilt and their lumbar spine is compressing, how do you improve that? I mean, that's functional, right? So it's a lot about control. That's just basic control. So if you can activate your anterior core, your rectus, at the same time as getting your glutes to fire, you have this posterior tilt of the pelvis, which then would keep it in neutral alignment. It takes the load off of your lumbar spine, but it also, has a balance effect where you have you lose that tightness in your low back that you feel when you try and bend over. You get rid of those chronic hip flexor tightnesses where you can't extend fully, so then you're constantly in this forward bent position, and that just has a slippery slope as we get older and less functional. So I'd say exercises that involve, the anterior core is huge because that's what's going to keep you out of these postures, and these postures in daily living or these postures in sports. If you have compensations that start, you don't want to build strength on compensation.
Right.
So if you can address neutral alignment first and then build on top of that.
Yeah, the human body is structured fairly uniquely, right? That we have physics 9.8 meters per second squared, constantly going down, and everything that we look at on the body is anterior in nature.
Right.
Right. So you have the spine and this spinal column, right? This kind of erector set needs to be as strong as it can, and all those tiny little muscles are constantly working overtime against these big bad boys like the pectoralis, major, and as your arms, flex forward and all these other things. So let's go back to something you brought up about functional movement. What do you think about the functional movement screen?
Absolutely love it, and I'm hoping to get certified in that as soon as I possibly can. There's actually a test in Dallas in December.
FMS screen.
FMS screen, going through those motions, finding asymmetries. The rebuttal against it is that asymmetries are common, especially in athletes who do the same thing repetitively over and over again. You're going to have some asymmetries develop. But as just a basic screen, I think it's an excellent idea.
Right.
Whether or not it's the golden rule and
Well, I think it's a tool in the toolbox, right?
Absolutely, and I think it's a great toolbox, especially if you have somebody come in who doesn't have injury but just doesn't. You want to pre-assess. If you can assess for a potential injury, that's better than having to rehab after injury.
Yeah, that's right. It's going to be part of your prehab.
Absolutely.
Right. You do an FMS and you find some weaknesses and you try to shore up, close the gap on some of those weaknesses, and then FMS again.
Yeah.
And see where we are and score them on that.
Right. If it's something as simple as poor ankle mobility, that has a great carryover, because if they do have that poor ankle mobility, and then you have them go through a strength and conditioning program, and that limited mobility creates an internal rotation of the tibia and the femur, which then locks the hips, which then creates that lumbar flexion. You got a back squat that's going to have lumbar flexion loaded rather than that slide arch and lumbar extension. So it's a distal to proximal sequencing that you can fix if it's just a matter of...
If you understand the kinetic chain and how things move and how things load.
Right.
So let's go back to, did you hear early this morning, Dr. Lowe was up there and he's talking about this new modality, essentially it's a modality of dry needling. What's your take on dry needling?
I don't do it. I've read about it, and my only assessment would be if it works, do it. I don't do the necessary research to truly understand the chemical side of trigger points. But the anecdotal side is whenever I do soft tissue work in the clinic on these trigger points and I get the release that these patients look for, it's immediate. They can tell if I've worked on their trigger point and I've done a sufficient job because their pain is reduced.
So what are some techniques that you use for trigger point? You know, when I was going through school, it was like, you know, if we're going to work on a trigger point, we have a couple different options. We can do the combo, right, ultrasound, and so what are some of the techniques that you use?
I'm a hands-on guy personally. I have not gotten into the instrument-assisted soft tissue work, but it's something I've looked into, and I think something that is becoming more and more popular.
Why do you think it's becoming more popular?
Once again, results. When you see people have good results with something, you know, people want to continue to do it, and then the word spreads. Even if it's sticking needles in your arm or if it's rubbing a piece of metal on your shoulder, whatever works.
Right.
But
you're talking, of course, the dry needles.
Dry needles, yeah, of course, right. Of course. Right. Well, yeah. Anyway, but yeah, I mean, there's a fascial layer that we probably don't have a great understanding over. Is that, you know, we're all connected by this fascia, and if you can somehow realign this fascia to not be all twisted and whatnot, you have these crazy theories out there that you can unwind this fascia, and it may not be crazy. But if you don't have an understanding of it, then it kind of sounds crazy. If you unwind this fascia, you can have this person kind of twist and contort, and all of a sudden they're pain-free. But yeah, there's this fascial layer that obviously can benefit from some type of therapies, and that deep pressure, that deep stimulation is kind of like an autogenic inhibition, where if you can decrease its ability to contract, put it some sort of a relaxed state, you can get the other muscles to then increase their activation. So if you have a muscle that's overactive and constantly active, typically there's going to be a muscle on the opposite side of the body, or on the like the upper cross syndrome, before you have upper traps that are constantly turned on, right, and then you have pecs that internally rotate you. You're going to have poor deep neck flexor activation and poor scapular retraction.
And that poor pectoralis minor is constantly on fire. Right. We see that a lot in swimmers, don't we?
Swimmers, and you see in teenagers who text 45 minutes, sit down 45 minutes and sit in class and text and write. So I mean, a lot of the young kids are coming in with this thoracic kyphosis, upper cross syndrome. They can't sit straight.
It's kyphotic posture,
Absolutely.
Upper cross syndrome. Yeah, it gives a whole new meaning to gamekeeper's thumb.
Yeah, it used to just be the thumb. Well, and then you got textured thumb now too.
Yeah, textured thumb, right?
Yeah.
Are they coming out with some de Quervain's diseases, or?
Yeah, I don't know.
Who knows?
Who knows? What's all going to be?
That's our next research study.
Okay, go ahead.
Yeah, go ahead. That'll be it. Okay, everybody, start texting. Hey, Jasmine, since you've been talking so much, how often do you text? And is your nail polish different than it was this morning? Okay.
It's not different.
It's not different. How often do you text?
A
lot.
Probably a lot, I guess.
A lot.
Are you including like Twitter, Facebook, all that stuff? Because then you're typing in text as well.
Well, and if I was going to go off of Twitter, tell us the Twitter for the sports medicine broadcast again, Jeremy, please.
PHS Sports Med.
Is it PHS Sports Med?
Yeah.
Mm-hmm.
And then we also have at the sports medicine broadcast.com.
No.
What is it?
The hashtag.
Hashtag
Twitter.
The SMB, yeah. And we're trying to link in with our Twitter account. We're at U of HMAT. And you can catch us on our webpage, www.hhp.uh.edu/MAT, where we're learning that, talking with Ryan Collins, PT-CSCS, that Ryan and the Memorial Hermann Sports Medicine Rehab have been partners with us. And we're really, really grateful and really looking forward to that relationship. So tell us a little bit more about why you focus on the core.
Well,
you in particular.
Why I do it myself?
Yeah, what led you to, hey, listen, because, there are a lot of people that, I remember back in the day, like, they kind of circled around the core. They talked about, hip external rotators. They talked about the gluteus medius. They talked about, it's got to be coming from your tibialis anterior and tibialis posterior. And all of a sudden, somebody broke through and said, it has nothing to do with that. It's all coming from this concept of what we call the core. And you brought up something really interesting, that there is no true definition of the core. Everybody's got their own interpretation. So what led you down this path for you, Ryan Collins in particular, to focus on the core?
Well, I'll give you a little bit of a personal story. School, I was in marching band. and play the trumpet. So our job was to elevate our horn above neutral, above horizontal. So I was in a lumbar extended position for 2 hours at a time during a march, but then 8 hours a day when practice. One day I had a picture. I was at a beach, and somebody took a picture of me, and I saw this. I had this huge swayback.
For people that don't understand swayback, that's hyperlordotic.
So they understand hyperlordotic, but not swayback.
Yeah, swayback's a little more understandable.
Sorry, doctors who don't understand swayback. But and I also had low back pain, and I thought, well, I'm 17, and why am I having low back pain? I always just attributed to standing on my feet all day, playing baseball, and then being in the band. But just seeing that picture, just seeing that gross posture that I had, really got me interested in, well, how can I reduce low back pain? And I never really dealt with it then, but coming through physical therapy, going to school, and learning these core exercises, realized that I can address it, because it's a postural adaptation.
Mm-hmm.
And so being able to go through these exercises, and then the good part about any exercise is that if you see results, it makes you want to do more. And so I noticed my hyperlordotic curve reduce.
Mm-hmm.
I had much less low back pain if I went to an amusement park and stood for 3 hours. I could do it.
Mm-hmm.
And it's funny how whenever you activate muscles, when you just tighten up your core the appropriate way, and I say core, well, you tighten up your anterior muscles,
Mm-hmm.
you feel a reduction in low back pain because you've just now reneutralized your pelvis. You've activated the proper muscles that get out of that anterior pelvic tilt. So that and how I kind of got more into it with my therapy and my programs is just seeing how many guys came in who couldn't do a basic plank.
Mm-hmm.
They relied on their hip flexors. They relied on their T-spine. They had a whole lot of hip flexion. All right, these athletes, these fullback, I had a professional fullback who had trouble maintaining a front plank.
Mm-hmm.
For 10 seconds.
Mm-hmm.
I think Stu McGill, on his research, he ideally for about 8 seconds is how you want to hold that, and then you do repetition over and over
Mm-hmm.
again. And this guy couldn't hold it for that long, and he's a professional athlete.
Right.
They do crunches out the wazoo. They do Superman's back extensions. They hold plates and they just repetitively extend their back over and over again. And so my question always to them was, you're a fullback, or you're a swimmer. When do you ever repetitively bend your back to its fullest extent during your sport?
Right.
And so, the SAID principle is something therapists learn about at athletic trainers, but for students and athletes,
go back. You brought up a really interesting principle, right? The SAID principle.
So, go ahead.
Specific adaptation to impose demands.
Absolutely.
Tell us what that means.
So basically, how does that carry over? Right, to what you do. You want to see, if you're exercise, if you're going to train yourself, you want to make sure that you're training your body to produce and perform at exactly what you're going to be doing for your sport. So if it's sprinting, if it's jumping, why sit on a leg press with your back on a bench whenever you should be vertical against gravity, working on your landing mechanics, working on your explosion. When you're running, there's no sense in being on a treadmill if that treadmill is creating that posterior pull on your hips rather than your glutes doing it when you're on dry land. So the SAID principle is basically to train your body to perform the way you want it to when you're in competition.
Mm-hmm.
And so, how I got kind of more into this more core stability versus just the crunches and the rotational twist, the Russian twist, the things that I learned in high school and junior high, which is obviously what the rest of the coaches are teaching, because strength and conditioning.
That's what they learn.
Absolutely, the strength and conditioning world for some reason just passes it on. I don't know why. I've been out of the game long enough to know that there's not been a whole lot of change. Strength coaches learn from other strength coaches, and those strength coaches learn from their previous strength coach.
Mm-hmm.
And anecdotally, that's fine, but that's the whole reason behind evidence-based medicine.
Right.
And research is to see that there are ways to improve your output, to improve your performance. And so having these guys go through these basic stability exercises, even though they can do 100 crunches and they can lay on a bench and lift 300 pounds 15 times, put them in a prone position, have them do a push-up, and then take away one of their hands. So now they have to control their body's tendency to want to fall and derotate.
Mm-hmm.
They can't do it.
Right. So you bring up this concept, right? You keep on coming back to this concept of, anatomical motion versus functional. Right. Whereas anatomical, we can look and we say, okay, we know that this muscle is supposed to do this. Right. But when you put it all together, you talk about the functional movement screen, as we brought up before.
Right. It goes back to isolation versus integration.
Yeah.
If you can isolate a muscle, you can do a bicep curl with a weight, but then whenever you try and move your body appropriately, what's the job of the biceps? I think that's a big question. Really, you ask any lifter in the gym, they're going to tell you it's to flex your elbow when it's actually primarily
to be huge, man.
That's right. It's to give you your pythons. But it's actually a supinator, and it's an anterior stabilizer of the shoulder. So whenever you're doing pull-ups or when you're doing chin-ups, that's when your biceps can actually really kick in because it's doing its job both ways. Same with the core. If you do crunches repetitively, you're going through repetitive lumbar flexion, which if you ask a McKinsey therapist, that's a potential for a disc herniation.
Right.
If you're on the field and you're running and you need your rectus abdominis to kick in, does that mean you're going to run like Quasimodo with your trunk tilted forward because you want to have a tight rectus because you have eight muscles poking out? So I think the carryover, the exercises, you train you do your exercise, you perform your gym routine so that your performance in competition is optimal. So you may not be able to jump and run and tackle somebody in the gym, but if you can prepare your body optimally for that type of action,
all those forces,
right, to control those forces, then the output potentially could be improved.
You brought,
All right, so Ryan, I remember way back at the Saturday clinic where I met you and I talked to you about the biofeedback units.
Yes.
Actually, we received that grant, so we received $5,000. So
that's tough. Good job.
Yep. So each school will be getting, each of our 5 high schools will be getting 2 of the CARE EMG biofeedback units. So I'm going to have you coming in at some point, at least to our school, to kind of show us how we can use it and some of the best ways we can teach the students with it. But
excellent.
A big part of that actually was you volunteering to come up there, and that being an expense, at your cost. So that was a donation. And so I just, again, I thank you for having the interview here, but you're also getting us that equipment just because you're willing to donate your time and teach us there. So.
Well, he really brought up an interesting fact. I'm sorry to interrupt you, but he brought an interesting fact about biofeedback. I'm glad you brought it up because that was another question I was going to say. He looked at the picture of himself in high school and saw that he had a hyperlordotic curve, which obviously not many people know. It's called swayback.
Yeah.
Everybody knows
it's a new term.
So at least that's how it works in my world. And so, he used that picture as a form of visual biofeedback.
Sure.
Correct. Right? And he said, hey, listen, I got to be able to change this. And so go back to biofeedback. Talk about the biofeedback that Jeremy's talking about. Talk about some of the biofeedback principles that you use. Use visual, use audio. What do you use?
Well, the first and foremost is I think a lot of people are visual, right? If they can see something, it's easier to replicate that. So for one thing, as a therapist, I try and make sure that every exercise I prescribe, I can perform. I think that's huge. I think that's key. Obviously, there's not going to always happen. There might be a guy who can do a power clean, and I have no Olympic lifting training, so I'm not going to try and demonstrate that. But if I can show them what to do, some people are just absolutely like, okay, I see it, I can do it. Others are feel. So you got an internal feedback. All right. So if you put them on their back and you put your hand underneath their back and say, all right, I need you to posterior pelvic tilt, but they've never heard of a posterior pelvic tilt, so you tell them, all right, I want you to flatten your back against my hand, and they just naturally tend to activate their anterior core, and they basically tighten up the front, which then will posterior rotate their spine or flatten their back. That's the tactile. That's that internal awareness, that internal feedback. And then you also have touch. Obviously, if you have them in a front plank position for core stability, and you basically just slap them on the anterior core and in their butt and say, tighten up these muscles, just the feel of what muscle to do, so that when they do activate it, you can, as a therapist, you can feel that the muscle's activated. But also they will be able to help engage those muscles just by whenever you kind of slap on it, which kind of goes back to the biofeedback. Now that's a visual, the little device is kind of a visual. We use it a whole lot for our quad recruitment, post-op ACL.
Sure.
It's huge. You get the TENS unit, which does the work for you, and then you tell them, all right, I want you to squeeze with the machine. But typically right after post-op surgery, you're not going to have a good internal feel of what a quad set is anymore.
Right.
You have the inhibition, you have the swelling, the pain. So all those things are limiting your ability to feel that. So with the biofeedback, you have no choice but to see that quad activate. So if you can tighten it up and that number increases on the machine, they can tell, all right, I'm getting better at that. So whatever I'm doing now, I need to continue to do exactly that.
Right.
So it's a feel. It kind of goes in hand. If you see something improve and you feel it, it's all going to kind of come together towards the end.
It all goes back. I remember learning about biofeedback in school. It went back to, my professor stood up and said, remember the Pavlovian dog? That's essentially what this is. That we're going to train you to do something repetitively, and you're going to get a reward for it.
That's essentially how it works. Now, you brought up a really interesting story about the TENS, or concept of TENS unit, transcutaneous electrical nerve stimulation. When you're doing rehab, let's ask you a couple of settings that you like to use in terms of E-stim, right? A lot of people love pre-mod because it's already pre-modulated. Some people like to use Russian, but that seems to be pretty painful. Some people like to use interferential. Do you have one particular setting, like, for instance, ACL? Will you ever use a Russian, although that's going to be pretty painful, or do you just pretty much stick to, you have a set protocol you like to stick to?
Well, for ACLs, they're in pain. So any type of just, superficial TENS to kind of reduce that to the gate theory, which is basically, if you, in layman's terms, you're closing the gate to your brain, so telling your brain there's no pain. It's kind of like a painkiller.
Jasmine, have you learned about afferent, efferent pathways yet?
No, I haven't.
Okay, that's an afferent pathway. Okay, go ahead. Sorry.
So that's something that we will use, and it's for people who don't tolerate pain well. I don't typically like to do a whole lot of modalities, only because it increases reliance on me. So if I can utilize, cold modalities, heat, but stay away from machines that they don't have available to them, then they don't think they have to see me in order to reduce their pain. But if I can control it and it helps, absolutely I'll use it. So go ahead.
So I'm sorry, there's a debate you brought up about cold, a debate going around right now versus ice versus heat. And I was asked a question about this, and I said, ice, yeah, it's an infrared modality, just like heat. Technically penetrates 1 centimeter, but it operates at a longer wavelength, so it's able to penetrate a little bit more. But really, what that ice is doing is it's working off the gate control theory, limiting the amount of pain, less spasm, less swelling.
Sure.
What's your take on ice versus heat?
My basic story I tell my patients is, this is my, I guess, theory, if you want to call it, could be wrong. Just based off of the body's response to ice and heat, if you want to increase blood flow, which would then increase your lubrication, you would want to go through heat. The vasodilation that occurs from increased heat in the body is going to help something increase its fluid uptake. Okay, so a stiff knee or a stiff shoulder post-op, and you want to get them moving, you can't do that if you don't have the proper heat. Now, the story I give them is a blacksmith. Blacksmith with a big piece of steel. You're not going to be able to mold that steel until you put it in the fire and heat it up.
That is an absolute great analogy. I'm going to steal that from you.
Do it. Copyright.
Copyright.
Anyway.
So when I say it, I have to say, listen, there's a blacksmith, and we need to heat it up so we can mold it. Yeah. And then I'm going to say Ryan Collins, 2014.
Yeah. Thank you. Appreciate that.
Props to Ryan Collins.
And so, but then the opposite. So you would want to use that heat, and that doesn't have to be from a heat pack. That can be from any type of, if you want to put them on a UBE or a recumbent bike or an upright bike, just increasing the repetitive motion, increasing the blood flow, increasing the lubrication to those joints.
Like a warm-up, right?
Right, the
active
warmth.
Warm-up versus a passive warm-up.
Right, so you're active or passive. But either way, you're trying to increase the body's temperature. Exercise increases your body temperature, which then allows that's the vasoconstriction, for that blood to be transferred amongst the body. In other words, the opposite, if you're sore and you have pain, that cold, that vasoconstriction that occurs whenever you reduce the temperature, or when you put that application of cold on there, is going to help reduce the ability for those pain enzymes to be sent into that area to decrease the swelling, along with elevation and the whole Rice principle as well.
Yeah.
But that's kind of, whether or not that's absolutely true, and I think there's research out there that says cold doesn't do anything and heat doesn't do anything, and vice versa. You can decrease pain with heat. Ask your 60-year-old grandma or aunt, what do they like to do when their back's sore? They like to lay on a hot pack.
Yeah, that's right.
But then you ask them 10 minutes later, is it feeling better? And they usually say no.
Right.
But you put it on an ice pack, they don't particularly care for it then, but the lasting effect, kind of like when you have the super high frequency TENS versus the low frequency TENS.
Right.
You have that increased duration of pain relief from the dilation for the pain that's going.
Speaking of heat, how often do you use, have you done any, I don't know, I guess it would be empirical evidence on shortwave diathermy versus ultrasound? Do you work with diathermy and ultrasound?
Never got into the diathermy thing. I think that was old school by the time I got into PT school. Saw pictures of it. It's about
the microwave diathermy was old school, but shortwave diathermy. I'm a fan of it. That's the reason why I said shortwave.
Laser was the big thing coming out. The laser. But anyway, ultrasound, As a means of pain relief.
I'm asking you as a clinician, not your personal opinion about. I'm asking you as a clinician what you've seen.
What I've seen, I've seen both. I've seen patients enjoy it, and I've seen patients who don't get any response to it. Now, ultrasound versus phonophoresis, there's a difference. I agree that phonophoresis has its benefits, but just doing ultrasound, I'm not sold on. It could be placebo effect. It could be that there's something really going on. I guess I don't do it enough, and I don't see the benefits enough to truly continue to do it.
Yeah.
And I don't think it gets covered, which is not very good for therapy.
Yeah.
So.
Yeah. It's not reimbursable.
Right. So
anymore.
Got to be protected whenever you're.
I saw a lot of the ultrasound units now come off, and before when we were going through school, they were set at 5 minutes, and now they're set at 7. But if you read the research, you can't really get a good heating until 10 or 12.
Yeah.
And nobody's going to sit there for 10 or 12 minutes, with an ultrasound head, and try to measure the effective radiating area, and figure all this out.
Yeah. So
going back to some of your classes, this is bringing up bad memories for you.
Well, yeah, I was just thinking about that. The teacher who was teaching us this, she was telling us how to do this ultrasound, and she kept on saying you place the head perpendicular to the body, and we kept on looking at her like, what are you talking about?
Yeah.
Obviously the head wasn't. You put it perpendicular to skin, the head's not even facing the skin. So it's obviously something that's still taught,
right?
But I don't think it's utilized all that much.
Yeah.
It's just kind of I think it's old hat.
Yeah, I think it goes back to this cosine law and the law of Grothus and Draper and all those other things. All right, well, we're sitting here with Ryan Collins, and Ryan Collins is a PT and strength conditioning coach, and he works over at the Memorial Hermann Sports Medicine Rehab. As we wrap this up, I'm going to go around the table. Jasmine, Bill, you have anything for Ryan Collins? He's a wealth of core knowledge, and I'm really looking forward that our students are going to be able to rotate with him again. We're fortunate enough that we're able to affiliate with Memorial Hermann Sports Medicine Rehab. If you go to our website, www.hhp.uh.edu/MET, look up on our website. Over to the left, you're going to see a link called Partnerships. Click on that. You're going to see Memorial Hermann Sports Medicine Rehab. And hopefully down the line we can make Ryan one of our preceptors. We're going to sign off here. So I'm Dr. Josh Yellen for the Sports Medicine broadcast, for Jasmine and for Bill and Ryan. Thank you very much.
Appreciate it.
Talk to you soon. Thanks.
Bye.
Thanks.
I can't wait for you to come over. Show some of the vibe.
And I got you talking a lot.
That's good. So what do y'all do? Is it constant? Is there a live feed, or do they have to go?
They can log on to Sports Medicine Market, but right now I think it's live on YouTube.
Who logs into it? Who do you directly see?
Actually, this is the brainchild of Jeremy Jackson, and you know Jeremy. And so really how Mark and I got into it was, I think Mark brought it up and said, hey, do you know about this podcast? So we shot an email out to Jeremy and just said, hey, look, we're starting up this new, entry-level master's degree in athlete training. We'd love to be on your show and, talk about the program and talk about athletic training, where it is, what's going on, all this stuff. So we went down and we sat there and we listened and, we talked, and then we came back for a second time, and then
We thought we'd come back in a year, and the next week they're like, hey, can you come back?
Come on back, and then I think the next time Jeremy came to us, and then here we are again, and it's like, so I'm ready to go.
This is actually a podcast put on by a local high school. Okay. It's for sports medicine only. What they do, it's live on YouTube. We have a camera right there. But what also I'm sorry.
In front of the sign. Yeah. Can you send me the link?
I will.
If you don't mind, that'd be cool.
Actually, I can tell you, it's going to be a recorded. It's going to be a recorded podcast at sportsmedicinebroadcast.com, which I'll send you.
Nice.
It's also being streamed live as we talk. I think we're on right now. Is that right? So,
okay.
I'll just ask you a couple questions while
Yeah.
you talk.
Let me give.
People that will be listening won't have gone to your talk.
Do you have the card? Oh, good. Thanks. Oh, great. Thanks.
And so
Thanks,
I'll
Mark.
just ask you to give a brief introduction.
Sure.
And then you want to get out of here. And then
Yeah.
I'll kind of hit a couple points and hot topics. And then
Yeah.
Just signaling me like I got to go get my patients. Or
Sure.
whatever. So,
Yeah.
like, I'll get winded because this is an exciting topic for me.
Get a picture for G-Heads? Sure. Oh, yeah. Can I get you to, let me see if you don't mind to get a, yeah, totally forgot about that. That's a great idea. Do you mind getting one picture? Yeah, with doing the podcast with Mark here. One, if you can get one horizontal, one vertical, that'd be cool. Thank you very much. I appreciate it.
And then one more
Okay.
here for GHATS.
Okay.
GHATS is our local Greater Houston Athletic Trainer site.
Oh, nice.
Joe
Sabatini.
Nice to meet you.
Yeah, I do the Twitter.
Oh, great.
Yeah,
Yeah, there's
one of
my
the,
card.
I need to favorite you because we just started at U of H.
What's your name?
Mark Knobloch.
Okay.
Jeremy's got he needs to get to his patients, so I want to make
Okay,
sure.
yeah.
I'll talk to you afterwards.
Okay. Yeah. Do I need headphones or not?
No, he's in a hurry.
Okay.
Ready? Okay, this is Dr. Mark Knobloch. I'm here with Dr. John Higgins. John Higgins just gave a talk to our on the Sports Medicine Update about sudden cardiac death or sudden death in athletics. And Dr. Higgins, could you just give us a brief background about where you're from and what kind of brought you into that area?
Sure. Well, my area is sports cardiology. I'm a UT sports cardiologist, also with Memorial Hermann and Harris Health. And when I had previously lived in Boston, and when I moved down to Houston, I noticed that there was quite a number of athletes who were having sudden cardiac death, and we would notice that in the media. And in fact,
always.
Yeah. So it kind of got me interested in my. My division chair was kind of interested in getting us involved in some more projects, and he thought this would be a great idea to start with. So we first of all looked at what was going on in Houston, and also we noticed in other areas of the country, in fact all over the world, this is an issue. So we got kind of excited about that, and then what we did is we kind of drilled down and looked into what were the commonest causes of these events. And what we found were, first of all, most of the time, the individuals and even their physicians, a lot of these kids had been seeing their family practitioners and had seen other people. Also, a lot of them had like histories and physicals prior to exercise, but yet no one detected any of these.
And their physicals were fine.
Yeah, they passed. And so then we kind of asked, well, is there another way we can detect them? If the histories and physicals are currently missing them, what can we add to try to pick up these problems? And we noted that the problems were divided up into generally problems with the muscle of the heart, with the arteries of the heart, with the main artery of the heart, the aorta, and then finally with the electrical system of the heart. So the first three, most of the time, and some of the time, they will have some abnormalities on echo, cardiogram, or ultrasound. Right. And the last one, the electrical problems, obviously we would detect that on the ECG. Now there was a little bit of overlap, but certainly doing one or other of the strategy, you could miss some of these conditions. So we came up with our program, which basically had 4 components: the history, the physical, because again we wanted to show that they were still not adequate, and then we added the ECG and then the brief 5-minute echocardiogram to that, and we, like others now, have found that it does seem to detect more of these people who are at risk with these occult cardiovascular conditions.
I'm gonna throw a name out there.
Yeah.
Barry Marone.
Yes.
He's good at, and Dominic Corrado, the anti-Marone.
Yes.
So I'm curious, and I'll just, the history for our listeners. There's Italy. There's the what region of Italy is it? I can't remember.
Cordova. Is it? Sorry.
What's the kind of blind? It's the kind of blind.
Venetian, yes.
Area of Italy.
Yeah.
They do it, and they have very good statistics. I think they dropped it by 90%.
Yes.
Sudden cardiac death.
Yeah.
And so their argument is you need to do all these tests before athletic participation.
Yeah.
Dr. Marone at Minneapolis and many other, in fact, in athletic training, we have this attitude of you don't need to do it. It's just not effective, cost effective.
Right.
What is your opinion? I mean, obviously you have this new system. I know what your opinion is, but could you just kind of give us a brief, how you developed this program to kind of go against what a lot of American doctors believe, and why is it effective?
Well, I think that whenever you want to make a change to an established kind of workup or an established way of doing something, many times you have to have what we call a disruptive innovation. And what a disruptive innovation is for the listeners is basically something that comes along that generally is sort of not welcomed, but it seems to be able to do something that the older way of doing it wasn't able to achieve. And also the really good disruptive innovations tend to be a little bit cheaper. So what we did with our program is our disruptive innovation, as it were, was that, okay, can we do an ECG and can we do an echo fast and cheap? Instead of doing the full echocardiogram, which typically takes an hour, what we did is we asked ourselves, what are the key views that we need, what is the minimum number of views and the minimum time we can spend on doing this echocardiogram to detect these conditions in these young athletes that are going to cause them to die. And so we reduced it down from the cardiogram, which has about 400 or 450 different parts, scans to it. We reduced it down to 20 scans, which we could do once we trained our techs and told them what we wanted them to do, we were able to do in 5 minutes at a fraction of the cost. And likewise with the EKG, what we were going after was, we knew what we were going after, and we were purely looking for those particular conditions on the ECG. So we were able to...
very directed focus just
right. Yeah, exactly. So I think in answer to your question, Mark, I believe we do need a disruptive innovation to really make a change, and I think that I'm encouraged in that the disruptive innovation, I believe, is going to be these handheld devices. Now, we already have, in fact, I was talking to a friend of mine a few months ago. They have an app now for the iPhone and the other devices for an ECG. So, and he actually showed it to me and did an ECG on me while we were having lunch. And the other disruptive innovation is they now have an echocardiogram device, which is about a little bit bigger than an iPod or an iPhone. It's thicker. It's about closer to an inch thick, but that can also do an echocardiogram. So what I think we need to do is the two major issues that people have brought up that are against this are, number one, the cost, and then number two is, okay, you're going to pick up a lot of kids that don't have problems, and you're going to bench them.
Sensitivity and specificity,
right.
Absolutely.
Exactly. And so my answer to them is, number one, there is a way to reduce the cost. And for me, that way is use this cheaper technology, standardize and minimize the time you're doing these screens, and actually teach people who are not MDs, someone who is a trained, for example, an echo tech or a technologist, in how to use these technologies and to identify if it's normal or it's a normal variant, and if it's not, then to send those few cases to the doctor. So I think we can do that, and we've done that in our study at a reasonably cost-effective manner with both the EKG and the echo. The second issue is the issue of the sensitivity specificity or the false positives. That is, you're picking up some kid who's just got an athlete's heart and they're going to have an abnormal EKG, and you're saying, hey, wow, we got a problem here.
You're never playing sports again, by the way.
Yeah, exactly.
And they're wrong.
Yes, exactly. and I think with that, what we need to do is, once we do get this disruptive innovation technology out there, what we need to do is build a large database. And that database has to have a lot more people in it than what we have right now. I believe we have to have a world database that includes people, because every country now, with the world becoming a smaller place, we have people from all over the world in every country of the world. So we need to have a large database, and we need to decide and figure out, okay, what do we call a normal variation, which the commonest one that we see is the athlete's heart, and what do we call something that is purely is really abnormal. For the really abnormal ones, that is, they are at the highest risk of sudden cardiac death, I think we need to have those people benched for the moment until they have further testing. And then the further testing has to clearly decide, can they go back to sport? And sometimes they can. It may not be that they can go back to, for example, playing a sport where there's burst activity like basketball or sprinting, but they may be able to go back to another sport that is not as demanding on them and will not increase the risk of sudden cardiac death. And then secondly, we need to have I think a universal guideline. Now, I'm encouraged that is starting to happen in some sports. So, for example, FIFA, the Fédération Internationale for the soccer, they have actually just come out with a guideline where they actually specifically go through what they recommend for screening, which includes EKG, echo, history, and physical. And it's on their website. It's most of the countries that are part of FIFA, they have signed onto it. And I think that's the start of something. At least it's throughout the world, and they're taking a look at how can we reduce the rate, because soccer is just one of the sports. Right. So I think we need to do that on a worldwide basis and cover all sports and have a very large registry and figure out, what we can do, what's abnormal, what's not abnormal, and then maybe for the cases where we can't tell, maybe we just have to explain to the person, well, these are the risks and benefits, and let them decide, well, do I want to, if it's someone, for example, that's never had any problems and they've played sport all their life, maybe they may decide, well, I want to continue sport. But I think if it's one of the black or white ones, then we as society, if we want to reduce the rate of sudden cardiac death, we have to say, okay, we know this condition is, we don't know when it's going to happen, but very likely it will cause you to go down and you may not get up, and we have to, as a society, say, okay, that's unacceptable.
Because absolutely, like hypertrophic cardiomyopathy, they can have that condition and never have a symptom their whole life. Until the first symptom, I think, as Marone might have put it, is death.
Exactly.
The first time you find out is they're dead.
And the other important thing too, Mark, is that a lot of these conditions are actually hereditary. So I think the other opportunity we have here is not only with, once we detect someone in a family, don't stop there. Get the other family members in. There may be younger siblings or older siblings, and we might be able to pick someone up there that didn't know they had a problem. But also, there's a couple of people in Houston here who are really interested in the genetic testing of individuals. It might be in the future that when we get this down, we may be able to tell if someone has the genetic predisposition.
Absolutely.
And then kind of pay closer attention to screening them as well. So there's a lot. It's a really moving. It's a moving
very
target.
hot topic, and I mean it's tremendous. I mean, because you're just stopping death. Is what can we do to? You always want to improve medicine, and one of the side effects of this is death. And the kid's just playing a sport, and he's never had a symptom, or she's never. It's 9-to-1. Hypertrophic cardiomyopathy is 9-to-1 in men, so I use the term he a lot. But how do you stop that? Because the kid's been perfectly healthy, and then people are going to say he died. How did you not see that?
Right.
We didn't. He passed all of our screening. What could we do? And the question is there something out there that we can do to improve this and stop sudden death? And so.
And the other thing, Mark, is that we on the one hand, as society, we have all of these programs now that are starting up and are already in place that we're trying to get fitter. As a nation, and there's, Michelle Obama has her program for the kids, and that I think it's unacceptable that on the one hand we have these programs and they're being, very well funded.
Concussions in football,
exactly,
American football.
Right, and then on the other hand, we're telling them, okay, it's really important for you to exercise, but what happens if those kids are out exercising and one of them drops dead?
Very good point.
That's going to, have a lifelong effect on those other kids, and also I think that's a bit of a disconnect, because we're saying, okay, this is good for you, and then the parents are gonna come back and say, hey, you told them to do this, you said that was good for them, but then they they had a sudden cardiac death. So I think more is needed on this. We can't. What I think we all agree with is that the current situation is unacceptable, and we just disagree on what to do next. And I think we can say pretty with a fair bit of certainty that ECG is definitely part of it, and already people are showing that it can be done cost effectively. So I think for now, for the listeners out there, I think that you should consider getting an ECG, a screening ECG, which is easy to do. Most physicians' offices, primary care doctors who are involved in screening kids, they can do an ECG fairly easily. So I would recommend that right now. What to do after that, if it's good, if it's all normal, then probably they'll be okay for a year or two. The other thing is, as you mentioned, Mark, quite correctly, is these things, they may have the condition and it hasn't expressed itself. Genetically, they may have it, but they don't have the phenotype yet. And we know that as kids are exercising more and developing and growing, sometimes these conditions can show up later.
They manifest late. Yeah.
So that's another thing that we still don't know about is, once we've passed them, how long does the pass last for? Now, in our program, we follow what the International Olympic Committee and the European group recommend, and that is they recommend in people who are really athletic and very active and still growing, that they recommend every 1 to 2 years. So we would recommend that also if the kids are, for example, teens through to their 30s, that they be rechecked because one check may not pick up something that is not there.
Well, I know you got to get back to your patients. I really appreciate it. Dominic Corrado is going to be very thrilled to hear that you're recommending ECGs for.
Yes.
He's like, Americans are finally coming to our way of thinking. But
Yes.
I really appreciate it.
Well, thanks,
I
Mark.
would like to speak with you briefly afterwards about something. But I'd like to thank Jeremy Jackson. He's the guy that set this all up.
Oh, wonderful. Yes. Thank you.
This will be, like I said, a podcast out to anybody that wants to download it. I think you said 10,000 downloads you saw. Total, yeah. But we're trying to bring in some experts here to give a little opinion because the athletic trainers saw your talk. We want to come in and let the world know what you talked about and get the conversation started.
And just as a final thing, just to say that without the athletic trainers and all of those support people that are working with the teams, we can't do our job. So it's and you guys are on the front line too.
Mm-hmm.
So you are the ones that I think need to be aware of these problems, and if you have any questions or if you think there's something not quite right, be sure to bring it up and have that athlete evaluated a bit more, so you might, as the phrase said, save a life.
Save a life someday. Yeah.
Yeah.
Well, Dr. John Higgins, we thank you for your time, and we'll let you get back to work.
Great. Thanks again, Mark. I appreciate it. And if you guys could shoot me in
I'll
the link once you're on, that'd be
Jeremy, do you have a card on you? Probably not. Something I wanted to ask you to step back because we're live. Something I want to ask you is, apologize if it's not a question, but what's really starting the database for that? So, I know there isn't one. What would it take to really become Houston or UH as the some kind of athletes database or center?
I actually think that's a great idea. What I think we could do it now. I spoke a little bit a while ago to what's his name? The guy with the coronary anomalies at I'm pulling blank. Anyway, he and also there's a doctor who was in the Austin group. The Austin screening thing. Yeah, they're all in the medical center. I mean, she's a Methodist. I think I've got their emails, so I can shoot you their emails. But they're in Houston. Myself and several others. We're at UT. They're at UT. They're at St. Luke's is the guy, and then the girls at Methodist. I mean, you've got a whole group. We actually talked before about having actually a symposium in Houston, and in terms of how do we get it done? Well, I think if we could get a company interested in it now, Medtronic, they have expressed interest in the past with me, and they kind of helped us out. For example, if our kids needed an ICD, they actually said they would give it to us for free. So, and that's a $30,000 price. So that they're interested in that, and obviously because if we do detect a kid with hypertrophic, they're going to need a watch. So obviously that's a good win-win for them. I think what we need to do is do what they did with heart attacks. So what they realized is, and again, this was funded by the companies that make the thrombolytics and these stents. They realized that there was a lack of information on heart attacks. This was about 15 years ago, I think, and everyone was doing different things all over the place. So they actually set up a registry. It's called NMRI, National Registry of Myocardial Infarction. And they set that up, and it was actually funded by those companies that are involved in the actual treatments for the condition, whether it be the thrombolytic drug companies and or the boxes, the pacemakers, ICDs. And now I believe that's run by, I think it's run by Medtronic, and that is a nationwide registry for heart attack. So every patient that comes into any hospital, clinic, or whatever that is having a heart attack, it's mandatory that the government made it mandatory that all of their data gets captured by the hospital. In fact, it's part of the hospital scorecard. If they don't do it, they can get flunked and they can pull away their Medicare and Medicaid coverage and everything. So everyone does it. I mean, it's one of the things, like if you go to any hospital, they all do it. And now all of the data collection, database and all that, it's all paid for by this private company. And of course, they share the data with the government, but they also use the data too to promote, okay, this is what's happening, this is what you should do. So I think what would be a great idea down the line is and we talked about this last time I met with, sorry, I'm blank on his name. But anyway, I met with the Saluk guy and the girl from Methodist, and we discussed this. This was about a year or two ago. About what if we actually had a symposium here, and why not Houston? I mean, right? I mean, the Med Center. Because what's happening is it's fairly fragmented right now all over the place. There's no standards. There's no there's no certainly there's no registry. A lot of people have suggested it, including myself and others, but we don't have something. So I think what would be great is if we could have actually a meeting and get together, a meeting of minds. Get together with the different people who are interested in this topic in Houston. And there's a couple of others like there's a guy up at Klein and a couple of others who are doing some ECG screening.
Yeah, probably Robert and Scott.
Yeah.
Yeah, get
get
an association started.
Yeah, and I think, and we, call it Houston something, and I think we should look into the feasibility of getting a Medtronic or a drug company. I think Medtronic would be my first choice because, like I said, they stepped up to the plate with us with our screening. So I think see if they will agree to set up a database, and then of course we have to find out how that would work in terms of, because it's it'll be, even for Houston, it'll be a pretty large database, but we'd have to figure out how to do that. But there is a way, obviously, because they're already doing it for heart attacks. So figure out and then start a database of kids who are having subcardiac death and or potentially down the line we could start with that, and then we could go to the screenings. Get all of the screening ECGs in our database as well.
That's what I was thinking. Is there something that we're not seeing? Is there something to tweak to do it? If you found something, you have to fit off some control study right there. Let's try this. Is that right? I just think it's
do it as a unified group.
Yeah, do it in this concussion database.
Yeah.
North Carolina.
Right.
That's great. I just think I was just curious, and I'd love to be involved in that. Right down the website. I want to stay in contact. I used to be doing what they're doing. They work on academics now, so I have free time.
And I think we could definitely have the meeting in Houston. I mean, most of the key players in the medical center. So, and like I said, I'll send you those. If you can shoot me an email, I'll send you
tomorrow.
Yeah, I'll send you the name and the email for those other two folks. I'm sorry, I just.
And I'd be happy. I don't want to jump on your toes. If you want me to email a group.
Yeah, I think that'd be great. Actually, I think if you. Yeah.
All right, so.
Jeremy's gonna take everything and cut it up. It's a live stream.
Oh, I already posted it.
Oh, you did?
Yeah.
Like all the time.
Could he send me the link too, just in case?
I will do it. I'll probably.
Good.
Yeah, that's better. If
Better?
you sit up, you won't block yourself.
Well, like if I'm talking on the mic, but so like this.
Scoot it back a little bit more. Yeah, because you're cutting off the M and the H.
So I mean, if we just pull it up, it won't be a problem.
Yeah.
But come over here. Let's just see if this will work. Take the whole thing off. Grab up here at this. So.
I'll be the facilitator for that.
I don't think it'll stay like that.
We screen rice, for example.
Right away to pin it, that would work, and it would stay.
Where's that data?
Because you were saying the black looks better.
Yeah.
We'll just pull it up.
Yeah.
Yes, exactly. Yes. That's right. That's why I should.
Don't lie to our guests.
And I'm glad that you agreed to be a part of our program. Thank you for giving us a question.
Oh, yeah, okay. And the check in the mail?
That's right.
The check's in the mail as much as
What size shirt do you wear? That's how we can pay you.
Oh, okay. Well, it's going to be a really good shirt.
Yeah. Thanks, bye.
Summer's up. I'd like to sit in if you want to connect.
Yeah, I want to do so.
Oh, what did you find out? I apologize. You just said yes.
All right, so we are still live, right? Right, Jasmine? All right, so does it say how long the broadcast has been going? Does it say like a timer somewhere? We've been going since roughly 8:30 this morning. So how long is that? Do the math real quick. All right, so we're going marathon here, 6 hours. So we're going more like Ironman triathlon more than a marathon. Those are like 6 or 8 hours.
We have 2 viewers now.
2 viewers?
Yeah.
Uh-oh, watch out, watch out. There you go. All right, so if you're listening live, then go ahead and send us a comment there on Twitter, hashtag the SMB, so Jasmine can see that. Jasmine, we got any action on Twitter there? I know there's some tweets, retweets, some favorites. Go ahead and mention those people.
Well, no, he said I know that you.
And so while you're doing that, while she's scanning through there, obviously sportsmedicinebroadcast.com. That's where I'll post all these interviews. So what I'll do is I'll take the session where the doctor's actually doing their interview, and then I'll come back in here and take this interview, and then I'll put those two together. And obviously there is some lack or loss because you're not seeing the PowerPoint presentations. I may be able to get those so that I can have those posted there too, but I'm not sure about that. And so, again, sportsmedicinebroadcast.com, and I'll have all these episodes posted where you can get continuing education units through ghats.org. All that information, again, is on the Sports Medicine Broadcast website. And I know Dr. Yellen's sitting right here. He's, again, bowing to the Facebook gods. But I just want to say thanks to them and their program there at U of H, the U of H Masters of Athletic Training program. And I think that their willingness to participate here is what's made the difference for the show today, because they are experts in the field and they're the ones doing the interviews. And so it's experts talking to experts, and I think it just improves the quality so much. So I want to thank them. So check them out. Their Twitter is at U of H MAT, and then they have links. And so I know Dr. Yellen's mentioned it about 40 different times, the link to the website. So if you're listening to all 8 hours of this, then you will hear it plenty. All right, Jasmine, what do you got on Twitter?
At FABUAT, which is Chris Saddock. He said, at PH Sportsmed, you can't find any tape for that banner in a place full of ATs. A picture of Dr. Higgins.
And I do have the GHATS Twitter on my computer, so it's not just me favoriting my own tweets because I can do the GHATS Twitter, but it's actually Joe Sabatini. He's in there tweeting. He's the tweet master for GHATS, so he ate lunch with us, but very cool. I know he's enjoying being here.
We also got a favorite from Foster Sports Med.
Foster?
Sports Medicine.
Is that what it is? FHS? Foster? So I think that may be Kevin Roberts, or he may be at Terry. I don't know who's at Foster. So whoever FHS Sports Med is, thanks for listening live. I'll have to look it up later and find out who that is, but you can tweet us at using hashtag TheSMB.
And Mr. Mike Hopper also favorited our tweet of Ryan Collins.
All right, so again, it was really cool to talk to Ryan. I know he was a little bit nervous about like, oh, what are we going to talk about? But I think he did just fine. He didn't seem to have any problem talking, did he, Jasmine?
No, he seemed fine.
So I'm in and out a lot. I have to check on both sites and make sure everything, I talk to the guests and get them to come over. But this has been a really cool experience, and I'm pretty excited. And then tomorrow, Jasmine will be able to run it without me. Sarah will be able to run it without me. So I'm just going to drop them off in the morning and then pick them up at the afternoon. Sound good?
Sure. Perfect. Then you're going to miss out on all of the information.
No, see, but then when I go back, because I have to listen to it to edit it, so I have to, edit out like the times where they sneeze into the microphone or something. I have to take those out, or I try to take those out. No guarantees, but because this is a lot of editing. Maybe I'll make you come over and learn how to edit too.
All right, that'll be useful. I can use that.
Then you're hearing all this stuff again, and then you can put your name in the credits. Edited by Jasmine Dozal.
Who are we going to interview next?
So coming up next should be Dr. Samarat, a pretty famous concussion specialist. And then I think it's actually Dr. Yellen's going to tag team Dr. Bajani and Dr. Ott at the same interview so that they can go on. So Dr. Bajani will have to go give a talk in a minute, but Dr. Ott is giving hers right now. And then they'll talk to Brett Singer after that. So, and then I think we have 1 or 2 or 3 more after that. We'll have to see what all we can get in.
Yeah.
Because my beautiful wife has been listening most of the day. Sarah, thank you for listening on and off. But I know she has vacation Bible school tonight. and so she's gonna have to head out there early for that. So hopefully, my boys, I left pretty early this morning, so hopefully my boys got to listen and see me at some point. So if not, then I guess they would have seen somebody else talking. But I've checked it on my phone a couple of times. The stream looks and sounds good. So those of you that are listening live, and yes, especially you, Chris, for commenting about the tape. Thanks for listening live or checking it out. So I would say I'm really glad that I had Chris Shattuck on the podcast not too long ago, because when I talked to him, he was talking about the way you dress at SWATA. So at the conference last summer, he was talking about how the way you dress and the way you're perceived in the community. And so that's why right now I'm wearing khaki pants and a polo, because that looks professional, it looks nice. And I have to catch myself and not like judge other people because they're wearing shorts or sweatpants or t-shirts. I mean, yes, we are professionals, so we kind of want to look the part. And, this will be noticed whenever people look back at me. But like, I was mad at Chris. I told him, I was like, Chris is dumb. He doesn't know what he's talking about. But as I started to think about it, I was like, you know what? He really does know what he's talking about. He's doing some really cool things. And so I think we've grown the relationship just since I had him on there, just because of the respect that I have for him and what he's doing there and doing for the profession. So it's been pretty cool. And also, his kids play laser tag at the school like twice a year. He said that they bought laser tag guns. And so they'll just play like inside the school.
Yeah.
He's like, you can use them if you want. You can borrow them if you want. Oh, he said rent them. So we may end up renting laser tag guns from Chris Shattuck over at Pearland Dawson. So if you're interested in playing laser tag with your student athletic trainers and you're in the area, in the Houston area, you may contact Chris Shattuck. He's at FABU_AT.
Yeah.
At FABU_AT. And he may rent them out to you. I'm not sure. But again, the things that they're doing. Do what?
For a small fee.
For a small fee. Or maybe not small, I don't know. we hadn't discussed the prices yet, but it was pretty cool. I think that'll be a lot of fun for the kids. So again, that's why we do what we do. So what else you got, Jasmine? Should we turn the camera around so it faces you?
No.
No? You sure?
I'm good. That's mysterious.
Mysterious?
Yeah. So tell me about your background. Once you graduated school, where did you?
High school or college?
College.
All right, so I graduated from Dobie High School in '99. Then I went to Houston Baptist University in '99 through 2004. That's where I passed my licensure exam, and then I got a job. I went through ATC Houston, which is alternative teacher certification. So ATC Houston, so I could get my teacher certification. And then I got a job in Fort Bend teaching sports medicine. And I was there in Fort Bend Bush for 3 years. For 2 of those years, I was by myself. Man, my nose itches, and I know that camera's right there in front of me. So then I worked at Fort Bend Bush. I think I learned a good bit, but I really could have used a mentor for those first 3 years. I had one for one, but we good?
Summer's about ready. She just closed up shop, so we should be ready to go.
All right, well, summer is coming in. So anyways, I worked in Fort Bend Bush for about 3 years, and then moved on from there to Pasadena. Just so happened that we bought a house in Pasadena. My wife got a job in Pasadena, and the job at Pasadena High School opened up. It was just meant to be. So we bought a house that's 4 miles from my work, which is good because Sarah is now stay at home. So she was driving, 20 minutes to get to work and back. But since she stays at home now, it's very convenient that I can ride my bike to work. Yeah, buddy.
I just drove to a place yesterday. Went to my daughter's second birthday. We had at Kima Boardwalk. So we took to 25.
225.
I said, that's why I did the little radio show. She's like, what radio show? She emailed me 3 times.
You missed it. We got another viewer.
What's that?
We got another viewer.
Sweet.
We're up to 2 now. Yep.
So Chris Shattuck.
Talking then.
I know, right?
Every 2 days, like, you got to hear this guy talk about his bike to school.
Chris Shattuck from Pearland Dawson. Have you met him?
I emailed Chris. I've never met him.
Yeah, so he was commenting because Jasmine and I were adjusting the sign here. Because when you were sitting here, you were blocking like that half.
My head's enormous.
Well, mine's not any smaller, so.
It's not just that I was sitting there. I'm the bad measuring tool.
So he was telling us we were poor athletic trainers because we couldn't find any tape with all these athletic trainers here. We're not very resourceful. I blame it on Jasmine.
It's not my fault. I'm just helping.
I'm just a student. So really, I'm just sitting, filling in time. So.
Person will stand up, just talk to the mic. Hey, 158 trainers walk into a room. We do need to get a group picture because I don't know if I mentioned this. I want to send an email to NATA News and tell them about this, if that's okay with you.
Absolutely.
And we would like to probably take a group picture of everybody involved, so maybe the preceptors, but you and Bill, myself, Josh, and just say, hey, this is going on. And then I'm going to take whatever I hear from them, I'm then going to take to the VOC and say, this is going on. We'd like to expand it into where we could bring in an expert and then have somebody generate a quiz. And after listening to the lecture, they take a quiz on the topic and something like that. So the first thing I'd like to do is just send it to into the NHA News as a collaboration between UH Sports Medicine and, of course, you've developed this, and just say, this is available. You can listen to these sports medicine podcasts. And if it happens, I'm going to let you know because I want to see what the podcast downloads are like the day before total versus afterwards to see if it really did any good in terms of advertising. So, but yeah, we need to get a group picture. Oh, that's
sprinkler. It looks like it might rain though.
But yeah, it brightened up. I went outdoors earlier and it was kind of nice out. So you're doing this tomorrow too?
Mm-hmm. Yeah.
We've got class all morning. Josh mentioned we're missing a speaker, and so Josh may come in and fill in, but we've got class in the morning, so I can get a student to get going on it, get to do the interviews.
Uh-oh, it's going to make it a lot more difficult.
I could come down, no, I wouldn't be able to come down until after 2. Josh could come down after 11. He'll probably get out about 11. And then we could bring a student too. No, we couldn't be in my class. But I got class. 11 to 2, 11:30 to 2.
We have to put Bill to work tomorrow.
Yeah,
He didn't have to do anything today.
He's seen it from us, so he can't say he doesn't know what he's doing.
Wish we could always get Bubba in here.
Yeah. Get Bubba and Josh together. That'd be an interesting interview.
I know. See, I was hoping during the breakout session we could get Bubba and Josh and you, and you're just kind of talking, telling stories. But I know Bubba was doing his thing.
Plus, he's got to prep for his talk. Talking about case studies.
Yeah, he's talking today, like last talk today or something like that.
So, if you hadn't done the U of H, would you have had that volume issue here? If you had
Probably, yeah. Well, yeah, for sure. I mean, I was planning on having the laptop, just having the same setups. I would have been able to see it because, when it's the computer, I can see the wavelengths, but because it was only into that, I couldn't tell the levels.
So it would just been maxed out?
Yeah,
okay.
yeah.
Dr. Higgins was a good interview. He was really engaged. Actually, both of them are the nutritionist this morning and Dr.
Yeah, Bob was saying Roberta said she was thankful for doing the interview. So the only thing is, I mean, I'm going to get to listen to all this stuff later, but I feel like I haven't caught much today because I've been going here to there to here to there.
Are you running the show in there too?
No, I'm not. I'm just recording it, so I'm not running anything in there. I was helping out for a minute while somebody had to step away, but.
I thought you were doing like audio, video in there, and then trying to run this too. I just expect you to be able to do much.
There's thunder. So if we lose power, then the laptop's will still be going, but the soundboard won't. So then we would lose our live stream. Chris can't make any more wisecracks.
So are you into the wireless here? Or
Yeah. Yeah. Wired would be better because it's just a more solid connection, faster. But go with what you got. So I think for the first time doing this is pretty good.
Yeah. I mean, I'm glad to hear it's working. I mean, you're getting 5 experts in a row, and you got the data or the program right there.
Yep.
And it's shorter, so you don't have to sit there and edit single one for 2 hours like you did with Josh.
Yeah, so I'll just have to, and like I said, I might teach Jasmine how to do it. We'll pick her up one day. Let her get to town on editing, combining them. You're doing a great job on Twitter, by the way. I've seen a lot of your comments. That's good. That's what I've been looking for. I just could never get George to really get with it. I'm just looking for summaries or quotes.
Mm-hmm.
And so, because that also draws people in. They're like, oh, what's going on? So they click on it. Especially if it has a link or, the hashtag on there, then people follow that and see what else has been said. So. Bill, they're not going to be here tomorrow, so you're going to have to carry the load.
Oh, they're not? We have class on Tuesday, Thursday. Teach class all day.
See, I was wondering that. I thought you had told me that y'all were going to be last week and this week y'all were going to be busy. I thought y'all were onboarding last week and this week.
We are onboarding on Monday. So instead of doing clinical rotations, they only do onboarding. So, for example, Monday we did introductions and science paperwork, and then Wednesday we toured some facility, toured the campus, that kind of stuff. And then today they're doing human subjects research training. So it's like a 5-hour course, so they're just doing that today. Tomorrow we have class, and then Wednesday we're touring Memorial Sports Medicine, and then Josh and I are talking to the Texans, and then Thursday they have class again, and then Friday is kind of the last onboarding day, and a week from today they start in the U of H Sports Medicine. So they start the actual clinical rotations.
Was Josh going to grab?
Well, she's
Dr.
talking. Okay, I just said she probably knows half the people out there. So.
He's trying to get her. She's just talking to people.
Hey.
Hugging her neck.
He's very likable.
It's got the sheep's hook or whatever they call it. The old cartoons.
Shepherd's crook, yeah.
Shepherd's crook.
I only know that because of his lifeguarding. I was a lifeguard instructor, and that's what you had to. Oh, that looks like Dr. Bajani's about to walk in. So I'm going to go ahead. Yeah, he said he was going to try and get both of them at the same time. Step out of the way.
All right, here we go. We got the Dr. Bajani.
I'll
sit on this side.
Some are gonna. You weren't there because we want you facing the camera.
Yeah.
Some are gonna make it, or she.
Yeah, Summer's finishing up signing autographs, and then she'll be.
Signing autographs.
Yeah. So actually, I don't.
Need your best side.
No, I want this side. I'm used to this side. I've got obsessive. I've got obsessive.
About 15 minutes, and I'm gonna come in and jerk you out of here.
Okay.
And then you're gonna take a spot.
You know what? Since Dr. Benson has 2 hernias, she can do a dog. I couldn't even do that with a straight face. You see that? Now with the straight face.
Okay, you ready?
So, go ahead. So you can ask that whenever after
You recording? We're still on. As we're
So
making fun of
Dr.
all
Higgins is now
Wow.
35 minutes with commentary from Jeremy and I.
Is that a camera? That's pretty slick as a camera.
Yeah, it's cool.
Jeremy,
Go up there
Jeremy
and see
Jackson
the view. It's
is,
pretty
I
cool.
mean, it's pretty.
That's a pretty sophisticated camera.
I mean, I'm telling you, Jeremy Jackson's got this thing.
Now, if you want to flip it, we can get that rainstorm that we're about to hit outside in the background. Create the ambiance, you know.
Well, that's a bad omen.
I know,
You're about
it
to
is.
talk, and here comes the storm.
Hey, how you doing, everybody? This is Dr. Josh Yellen with the Master of Athletic Training Program at the University of Houston. You can look us up at www.hhp.uh.edu/MAT. I'm here again with Dr. Mark Knobloch, who is our clinical coordinator, one of our co-medical directors, Dr. Rahul Bajani. Dr. Bajani, thank you very much for being with us.
You're most welcome.
Dr. Bajani, tell us a little about yourself. Where'd you grow up? Where'd you go to school? Where'd you do your residency, your fellowship?
Well, I grew up in Houston, Texas. Born in Houston, Texas. Grew up in Dallas. Did all my schooling in Dallas, UT Dallas for undergrad, UT Southwestern for med school. Decided happy wife equals happy life. Came back down to Houston. Did my family medicine residency at Memorial Hermann here in Houston. And went up for my primary care sports medicine fellowship up in Detroit, Michigan. Settled back down in Houston. Figured it was a good place to live, and been chugging along ever since. I've got a family medicine, sports medicine practice now coming on to 3 years in Sugar Land, Texas, and just hanging out with you guys now.
Now, we interviewed an orthopedic surgeon not too long ago, Vishal Shah, who I think also went to the same medical school you did.
Yes, he did.
Were you in school together?
He was there the year I started school. He had graduated, so I had met him in passing coming up. But he's a local Houstonian also.
Yeah, that's right. So you guys know each other.
We know each other. I got to actually train under him while I was in residency for a couple of years.
How about that? That's pretty neat.
Yeah,
it was common ground.
Yeah, he's a good guy. Trained at Andrews. You know, he's done himself well.
The hip guru.
The hip guru, indeed.
As they are. So let's talk about a little bit about your background and your training, and let's make a distinction between the sports medicine field, where everybody, when they think about sports medicine, they only think about a few different specialties. But you are family medicine with a fellowship in sports medicine.
Correct. So it's a unique field. It's been around for about 20 to 25 years. It's been more prominent in the north. It's starting to make its way down to the southern part of the country. There are about 100 and so fellowships now, creating about 140 slots. So there's not that many people going into it. When most people think about sports medicine, it's all about the orthopedic sports medicine, the arthroscopies, the ACLs, and the shoulders and the elbows. So we do a completely different thing. We do a variety of different facets of medicine. We do general medical conditions, dermatology. We do non-surgical orthopedics, kind of doing the initial screen to an extent, doing all the imaging modalities, doing the injections. We can do the concussion work, which is a big important part of sports now. We do exercise physiology, VO2 studies, and whatnot. So there's a lot of different things that us as a specialty bring to the table that might end up creating us as a gatekeeper for sports somewhere down the line.
Sure.
So it may have been easier to say, what do you not do?
Well, there's plenty of things I don't do, but there's plenty of things I do. We'll leave it at that.
A tremendous asset.
Hey, Jasmine, on the video here, are you able to see Dr. Ott, speaking of concussions?
Yes.
So with us, that just joined us as a part of our medical team, and again, we're really fortunate to have Dr. Bajani as one of our co-medical directors, and we also have to my right Dr. Summer Ott, neuropsychologist. Dr. Ott, thank you very much for being here.
Thank you.
Dr. Ott, tell us a little bit about your specialty. I learned something not too long ago that a neuropsychologist has gone through the training to be a psychologist and goes through an extra fellowship. So tell us a little bit more about your specific training and how you got into the field.
My degree is in clinical psychology with a specialization in neuropsychology. So licensed as a clinical psychologist and then did a 2-year fellowship. So as Dr. Bajani may have mentioned, fellowship training within his specialty, we also undergo the same type of training in terms of perfecting our craft, if you will. And you can go into different areas. So there is forensic neuropsychology, there's health neuropsychology, I'm sure I'm missing some other fields right now, but and then sports psychology is a new and evolving field within neuropsychology, and that actually was by default. So as an athlete going through high school and playing some post-high school ball, I really felt that as I had this opportunity, it was a good niche for me, being an athlete and understanding and empathizing with athletes as they're injured, and this particular injury being concussion. So really went into the field thinking I'd be a therapist. Really didn't want to do that part after I started doing some therapizing and learned that people didn't maybe get better or do the things that I wanted as quickly as I had hoped. So I'm now more of a diagnostician and then also researcher. So how's that long explanation?
That's outstanding. I think people need to know, right? A lot of people that are listening to us are just getting into the sports medicine field, or they're listening to this as continuing education. As we're talking about before, you know, if you're not directly involved in that umbrella, you may not know all the different spokes that happen. So let's talk about, the two of you have some overlap, and that overlap is in diagnosis of concussion. Can you, the two of you, talk a little bit about the clinical relationship that you have, and how does this interact? So I'll kind of play the scenario. I'm an athletic trainer on the field. I see a concussion happen. I diagnose it as a, whatever, grade 2 concussion, whatever it is. And Dr. Bajani is my team physician, and I refer on to Dr. Bajani. Take it from there and take us through the process of the difference between what Dr. Bajani does and what you do as a neuropsychologist.
So I will answer that question in two separate scenarios, because I think the scenarios really play themselves out. The first scenario is the one, Josh, you just so mentioned, that kid comes in, has a concussion. The way we determine, from my standpoint, I'll come in, I'll do my initial evaluation and physical and do the neuropsych testing, the computerized neuropsych testing if needed. And Dr. Ott will chime in on this a little bit more, is such as younger age, comorbidities such as ADD, dyslexia, or any other prior history, or that they are having issues with vestibular speech issues. This is where Dr. Ott's expertise comes in much more valuable than my initial assessment. The second scenario is the vice versa scenario, where Dr. Ott's seeing a kid or adult with post-concussive syndrome, for example, and needs my expertise as far as the medication management and bringing the symptomatology scores down, as well as bringing the exercise threshold back while they're still recovering from the injury. So that's where, we play hand in hand. A lot of times we will share patients and discuss how we can make things better. I know Dr. Ott and I just started working on a submaximal symptom threshold exercise protocol that we're going to try to implement here, and come up with ways to make the program more advanced, and then bring the research part of it in also. So I'm going to let her chime in now on her part.
Well, I think the fact that we just all three spoke, Josh, you spoke, myself, and Dr. Bajani, the point is it's multidisciplinary. So no concussion really is maybe managed by one particular discipline. Really, effective concussion management is having multiple specialties involved, because concussion is complex, and there may be the medical component, like you mentioned, the medication management. There may be a psychological component. There may be the exercise piece. There may just be the education that the family needs about what is the background of this particular athlete, and how might we expect that they go through the recovery process. So we definitely do a better service to the athlete when we're all involved.
So let's go one step further. Dr. Bajani, you brought up a really interesting scenario. Let's say that you have a concussion. It's a high school kid. This high school kid is being treated for attention deficit, for maybe anxiety, something like that. And this is a situation where, obviously, you just said it's referred to Dr. Ott. She's going to go through some more extensive testing, and that maybe there needs to be a manipulation of some medicines. At that point, is she going to go back and have a conversation with you to manipulate some of the medicines, or is that another conversation with another specialist?
It actually depends. I mean, it's a conversation that will be had based on who's taking care of the meds. If it's a patient, if it's going to a psychiatrist, I can trust. I can make that phone call and start teasing it out and saying, we might up or down the dose of their medication just to make sure that we get them through this part, and then we'll bring it back up. If the psychiatrist wants to see them in the office, we will by all means facilitate that appointment, and we'll make sure that that appointment gets made in a timely manner. Due to the acute nature of the concussion, and the recovery process is pretty, very stringent and very prudent. We got to make sure that these kids recover appropriately in a timely manner. If the conversation happens where I feel comfortable with one of my kids that I've taken care of, and just say, hey, we can do this. We'll make the medication adjustments. It's an art. It's not. There's no science that truly dictates what you should do with all these medicines. It's more of just trying to figure out what makes them recover to an extent where we can get them back to their baseline.
So I have a question for you. So you have these. You've all seen the different levels. You've seen from middle school football to professional football, and I hate to use football as the only example, but how do you, as an athletic trainer, how do you treat concussion symptoms, or how do you diagnose, or how do you treat the individual differently? Is everybody the same, or do you allow in professional sports a little more leeway? Are you more conservative with the middle schooler? And I guess, Dr. Ott, I'll direct this to you. But how should we as athletic trainers recognize the differences? Are all concussions treated the same by you?
Listen, I'm sorry to interrupt, but for all those listeners, Dr. Bajani just went off and he's going to go give a lecture about sports hernias, so we're one-on-one now with Dr. Ott.
So this is a really good question, and much of what we do in terms of concussion management is research driven. So for example, we have learned that professional athletes, both orthopedically and from a concussion standpoint, recover more quickly than, say, high school athletes. We learned that collegiate athletes are a bit more faster on the recovery trend than high school athletes. So we are more conservative with the younger kids, not only because research has shown it, but we also know that younger athletes have developing brains. So if the brain isn't developed until we think the age of 18, it may be debatable for some people that it's much longer, but for 18, then we maybe want to be more conservative because there isn't that plasticity that's there that we believed before, that it's more vulnerable to re-injury. And also there could be some other circumstances where the threshold for symptoms isn't there in a younger person that like it is for someone that's older or more seasoned, if you will.
So you'd say that the return to play is the change. It's not, I'm going to let you play even as a professional football player. I see some symptoms, but you're going to play. It's more of you're all out of the game, but it's more of a return to play that you're more conservative, would you say?
Right. I would say yes, the management return to play. We may also elongate the return to play, though, a bit more for a younger kiddo that's, say, age 6, because we see those people in our clinic too, than we would somebody that is in the professional level where we may say, okay, 24 hours, as long as you don't have any symptomatology, will progress you. So the idea is definitely the same, but the time frame may be extended somewhat based on age.
Gotcha.
So, Dr. Ott, going back to your interaction with the athletic trainers, right? There are a lot of people listening to the show wondering, okay, I can hear what's happening and I understand all the concussion research. From a clinical standpoint, tell us about, from a neuropsychological standpoint, what are some of the key factors that you want some of the athletic trainers to know in diagnosing concussions, managing concussions, when to refer, why to refer, and who to refer to?
Well, I think athletic trainers play a large role in concussion management. They're our first responders. They're the persons that are making quick decisions on the sidelines. You don't want to mess with the athletic trainer. I mean, they definitely know what they're doing in that particular arena. They know their athletes. And I would just say that moving forward, we've seen a long and a great progression in the way that we manage concussion, but moving forward, I'd like to see more athletic trainers also be more confident in that many times, because they know their athlete better and they are the person that has to see them day to day, that it's okay to say to maybe a physician or someone else that I don't think they're ready, and be comfortable with maybe having that role, because that can be uncomfortable at times to tell someone else that's maybe cleared the athlete that you know or you feel like you have evidence to support the athlete isn't healed.
So being able to take you brought up a great term, right? Being able to take some of that evidence-based practice is what we know it, and say, look, based on what I've seen, I understand that you've cleared this athlete to play, but I just don't think that they're prepared to be released.
Correct.
And so along those same lines, what kind of training do you think needs to go into athletic training education to make sure that these new athletic trainers that are coming out that are going to have to stand up to some of these big bad coaches and some of these other people to say, hey, listen, the athlete is out at this time, and this is just the way it is.
Well, I would guess that with any kind of injury that you manage as an athletic trainer comes confidence and experience. So the more that you have under your belt and the more experiences in the good ones that you have, and sometimes even the bad ones that you learn from, will make you more confident as an athletic trainer. So going to these workshops and going to talks like what we have today, where we talk about concussion management and the ways to diagnose and to help someone through the recovery process, is key. I would also say that peer review is helpful. I think many times people are too shy to ask their fellow peers about, hey, here's how I manage this case. Was there something that I did, that I could have done differently, or what did you like about what I did? And kind of talking about those things. Case studies are really the best way to learn. And I gave one today. This is the most problematic athlete for me, and I would have loved to have any feedback from somebody that would have said something I missed just to help them. So I think, again, making sure that training never stops is really the most important.
So you're always trying to refine what it is that you do, sharpen the saw, as they say.
Correct.
I've heard, and this was 10 years ago, it was a common talk among athletes, do bad on the pre-test. Do you still see that in the pre-concussion test? So that way, when you take it with concussion, your scores doesn't look like it decreased, and they actually continue to play. Do you still see that in your experience?
It still happens, but not as frequently as it did before, which is a good thing. That means that we have had the benefit of education and talking to people about, please take this seriously. And I think the more you can tell an athlete that's supposed to help you on the end to get back to play maybe more quickly and safely, that's the way to say it, then kind of guessing about what your scores can be. Maybe that would motivate them to perform well. Plus, we have all kinds of nice little nerdy ways of statistics to look and see when somebody doesn't perform well. So we get to say, hey, this is like way worse than somebody with Alzheimer's, dementia, and you're actually going to school and you're somewhat performing and remembering, and you know, you're talking and you're chatting and you're texting and you can do all those things fine. So we have a lot more sophistication in the ways that we can identify people who are also giving suboptimal effort.
Have they ever, this is probably a kind of a dumb question, have they ever looked at test fear on the concussion tests, for example, impact? Does that ever come in, or is that kind of a different, is it, since it's not a multiple choice necessarily, do you still see that at all? People get nervous in the computer, or is that not a big deal with the concussion testing?
Well, I will disclose that I actually had test anxiety, is what we refer to it as, and mine was more in the math arena. I always did poorly in math and algebra, but there is athletes who do have, and not athletes, but students in general who have test anxiety, and so part of our interview after we do complete the testing and we talk about their performance is to ask about those things. Was there any environmental issues that interfered with your performance? Do you feel like you're just not a great test taker? Historically, mom and dad, are there some evidence-based things that on the SAT they don't do as well as maybe they do academically? So we get to learn our athlete and find out that there could be some other reasons for their performance that aren't necessarily the concussion.
Okay. Now, off of the testing side, you know, everybody knows the classic signs of concussion. You got a headache, possible memory loss. Is there anything that you've seen that is not a well-known concussion symptom that athletic trainers should look for, or something we've seen recently that maybe is a emerging trend or anything like that that's outside of the common knowledge that you may tell people, you know, watch for this or pay attention to this? Is there anything you've seen lately that's come out that you can think of?
Well, I will add that one of the things I think that first I'll address before I answer your question is that athletic trainers are really great at distinguishing, I think, in many ways, dehydration from concussion. I think that there's been a good emphasis on disentangling those types of syndromes, so that's a good thing. The next thing I would say is take it a bit further in that we talked about psychological effects today during today's talk, but there are a lot of people that have headaches, that have dizziness, have memory and concentration problems that are due to psychological illness or mental health issues that have nothing to do with a concussion. So really getting in front of your athlete and asking them, you know, give me some more information about this. Let's talk about when it started or how long you've had these things, so you all can disentangle where it is so you can get them to the right path or the right specialist.
So you have to weed out the extraneous factors and they're on the concussion itself.
Right, just like you're doing with the physical exam for a knee or anything else, you're ruling out what it could be, or if it's a strain, or if it's something more surgical. I mean, just it would be the same thing.
So you both are dancing around that, you know, is new in the continuing education world for athletic training, is that you hear a lot of people saying, oh my God, I need 10 hours of evidence-based practice. But really what you're starting to see is that everything really dances around this fundamental principle of, is this evidence-based, or how are we making these decisions? How do we go forward with this? Along those same lines, I have a question for you. So again, you know, bring up the case of a scenario, and we diagnosed as a concussion, and now we're on the return to play. And we just distinguished that there's a difference between pro, college, and high school, maybe because of the maturity of the brain, etc. Do you have a specific return to play protocol? So when you've cleared that patient to return to play, is it day one, no pads, 25%? You talked about a little bit about physical exertion. When do you start to integrate back collision and contact? When do you start to integrate they can go 25, 50, 75, 100% back?
Well, we definitely do our protocols based on sport as well. So we're going to be much more aggressive with, say, a track person than we would be with a football player or soccer player. So there is a progression at which one goes back, and I feel like it's you know, there's several return to play protocols, but there has been a consensus in that generally the first day is more light aerobic activity, no more than 10 or 15 minutes, maybe 50% of maximal heart rate, very light. We wouldn't have people doing any kind of weight training the first day. It would just be maybe 10 or 15 minutes stationary bike, and that would be it. The next day we might increase those things to 20 and 30 minutes depending on how they did the day before, and that might be to incorporate some sport-specific activity that would be non-contact, and then by the third day we would expect that it would be strenuous physical exertion, more like a practice but not the contact. So in the case of the soccer player, they may be doing the ball dribbling, they may be scrimmaging, but they would not be taking any headers or get into a position where they would go full up, you know, and body, you know, hit somebody or whatever in soccer. So and then by the fourth and fifth day we start implementing some light contact for one day, and then followed by more of a full contact practice. So it's really important to get those contact opportunities in there before a game, which is maybe less controlled, so that you can it gives the athlete some confidence too, that I took some shots here, I took some hits, I encountered some contact, and I feel good, and the symptoms didn't come back. So making sure people have that and don't use the game as the contact opportunity. Sometimes people want to do that.
And at what point do you start to say, hey, listen, I'm confident with you being able to even return to participation? Is when they're completely clear of symptoms? It's when they're completely clear of symptoms plus 24 hours, plus 48 hours? How do you make that determination?
Well, some people may start exertion if they're having slow recovery times, and that's a whole different maybe situation. But not everybody that starts exertion may be completely asymptomatic, but we certainly want them to be completely asymptomatic before they start the light contact components. And even if they're saying to us that they feel good and they're not reporting any symptoms, if there's still some deviations on their neuropsych testing and some cognitive issues, then we would still hold them from doing any contact, because we feel at that point that's still a vulnerability for a re-injury. The brain's function has not restored.
You're giving me a kind of a good segue to my next question. Is we've all been talking about athletic competition. What about the injured athlete that has a concussion, held out of athletics, but he has a major exam, or he has academic work which could require focus, he's got a lot of studying, and he can't do that? Is there, I've heard of a trend or a possibility that they're going to start talking to things like school nurses and instructors for these individuals. Have you heard about that, or any involvement of actually limiting, not necessarily kicking him out of the test, but letting others know that this kid has a concussion? He may be a little attention deficit in class because he's having, it's a bright room or anything like that. Is there anything we should be thinking about modifying outside of academic or outside of athletics?
I would say that for me, I'm not on the sidelines with the athletes, so that's probably, as athletic trainers, really your bread and butter, and my bread and butter is probably the academic side of things. So looking at the neuropsych testing, listening to the level of symptomatology, and guiding a plan for them for return to learn is what we call it. So we do formulate a plan for each athlete and or student that's not even an athlete, so every person that has a concussion gets the same kind of benefit. And we will say that, if there's some reaction time deficits, we'll say maybe the person needs extra time on their test completion. We may say that they can't take any more than one test in a week because the mental demand's too much and their symptoms are so severe. We may say that the person has to sit in the front of the classroom because they have an attentional problem, and so it helps them be free of distraction. So we come up with a tailored plan, and people need to be symptom-free not only with rest, but with rest and then also physical activity, but also doing the mental types of things in the classroom, such as taking tests without symptoms.
So along those same lines, let's go back to something that I think for the athletic training world was huge. I think it was last week, maybe 2 weeks ago, the National Athletic Trainers Association, the NFL, and the Professional Football Athletic Trainers Association, they all come together and via the help of the White House, they come up with some of these concussion laws, and that they're going to now, the NFL is going to try to put athletic trainers in every, I guess, NFL team populated city to help the diagnosis of concussions. What are some of the things that you think really needs to go as a part of that sports medicine team? You think every area also needs a neuropsychologist? They also need sports medicine, physician trained, people. Elaborate a little bit more on that.
Well, it was actually, many people credit maybe the NFL with a lot of the concussion management tools and protocols, but really the NHL was one of the first organized professional groups that really mandated neuropsychological testing, had a multidisciplinary team, so the NFL, falling behind that. But the point is now at the professional level, we have multiple specialties managing concussions. We have neurological, consultants on the team. We have the eyes in the sky, and in terms of the, making sure that if there was something missed that someone didn't see on the sideline, it's called down to the athletic trainer working the sideline. We take them in for formal evaluations on the day of the game to kind of see and really to utilize that stuff to kind of predict some stuff later on, and a formal, more standardized approach to where everyone gets those things. So I think that the biggest thing that we should be asking is, can we provide the same level of care for our amateur athletes, our high school and our young tykes that we can for the professional athletes? And we can. So I think in our program at the Ironman Sports Medicine Concussion Institute, I think I said all that wrong, but all the words got in there somewhere. We do have that multidisciplinary team, and I think it's a good model, modeled after some of these professional teams where we have our team physicians on the sideline identifying concussion, and then we have the specialists carry out any kind of needs that there may be.
And so you're a part of a really unique collaboration between Memorial Hermann Ironman Sports Medicine Institute, and UT Physicians, right?
Correct.
And all that is, we've been fortunate enough to affiliate with all of those entities: Memorial Hermann Medical Group, Memorial Hermann Sports Medicine Rehab, Memorial Hermann Ironman Sports Medicine Institute, and UT Department of Orthopedics. And we were fortunate enough to incorporate Dr. Ott. Well, she's agreed to teach our psychology class, and she's going to teach all of our graduate athletic trainers exactly about concussion management and use some of her psychology skills and sports psychology skills. What are some of the things, you're going to talk to some of these graduate students in athletic training. What are some of the things that a new grad you think needs to know coming out? Obviously we've all been in practice for a long time. We've learned along the way, but coming right out of the gate, what are just maybe a couple things coming from a neuropsychologist of what they need to know?
I think the most successful athletic trainers that I know, and even people within my field and even physicians, it isn't where they went to school, and it wasn't the program that they came from. Nobody ever asked me where I went to school, really, honestly. What it is about relationship building. So, and I think you all would agree, sitting across from me here, that we've been very fortunate in that we can build these relationships, and that's what's really going to make our patients and our students and everyone successful and have good outcomes. So being able to ask questions, being able to take initiative, formulate relationships with people. They may not want to meet with you the first day. They have a lot going on, but keep being persistent and continue to make those meetings with people happen. And it's a give and take. They would expect that you would be there for them and to help them with their programs. So I think that for me is the best thing. I mean, it's about personality and relationship building, and the rest sort of comes into place.
Well, if anybody else has any other questions for Dr. Ott, Jasmine, you have any questions for Dr. Ott?
We actually got a question from Chris Sadok.
Hey, Chris.
He said, what are the major differences between the 2008 and 2012 Zurich consensus statements?
That's a good question. So he must be an athletic trainer. Hi, Chris Shattuck.
Hairland.
So good question. For the most part, they were very similar. I think more recently there's been less focus on some of the baseline testing as being a mandated sort of effective concussion management, although useful for maybe populations where there is a learning disability, attentional disorder, maybe psychiatric concerns beforehand. But so that was one of the chief differences. But generally the guidelines in terms of return to play were fairly similar. They talked about the place for medication management, defined concussion more significantly, but for the most part, the second Zurich guideline was to build upon the first Zurich guideline.
So not a whole lot of fundamental differences. They really emphasize just on a few key components, and ultimately, for what we need to know clinically, it's all about the same.
Generally, yes.
Great question, Chris. Thank you very much. Jasmine, anything else from your way?
Nope, that's it.
I think we can judge the expertise of our guests by the time it took them to get from their lecture to this interview.
Yeah.
And by far, some are
Dr. Ott
took the
Dr.
longest.
Ott
Everybody else could
yeah.
just walk right in, but Dr. Ott had 15
Dr. Ott
people.
has got 15 people. She's got a Sharpie. I'm
She's
surprised her
talk to them,
entourage.
and they're going to make her hug
I
her,
had to
probably a
stand in
picture.
line.
So
Yeah.
it was very nice for you to take your time to come on in here too.
Yeah, it is.
It is.
She's incredibly.
Well, she's got some great
valuable
relationships
component.
because we were just talking, and Jeremy and I kept talking. It's like, well, she was done, I think, and then it's like, well, Josh is out there. He's trying to pull her in
Stand
here.
in line just to ask her to come in. Yeah, I'm going to stand in line for 10 minutes just to ask.
She is a
Dr. Ott.
recognized expert in the field, so we really appreciate her coming on.
Yeah. Now, Dr. Ott, just real quick, I want you to go back. You did your training your fellowship training at UPMC. Is that right?
Correct, in Pittsburgh.
And there are two pretty well-known neuropsychologists out there. Is that right?
Yeah, when I was going through the program, Mark Lovell and Mickey Collins were my supervisors, and both are co-developers of the impact test, which I'm sure is familiar to most. And Mark Lovell has now since moved on to concentrate more on impact and its applications. Mickey Collins still is training fellows in sports neuropsychology and very active in the field of research, and then also consulting to professional sports.
Mickey did a great interview. If you've ever seen, I think it was Outside the Lines, maybe, I don't remember, maybe it was ESPN. I forget what it was, but if you Google second impact syndrome, ESPN second impact syndrome, there's a story about a young man, college football player, that had second impact syndrome and all the horrible things he had to go through and some of the misdiagnosis, and Mickey served as a consultant for that. And he did an outstanding job.
Yeah.
So.
Yeah, Mickey Collins and Mark Lovell really paved the way. I mean, we really should be thankful for them for a lot of the concussion management that we have, and then the policies we have. They were implementing long before HB 2038 got implemented in Texas. So we have a lot to learn still from them.
Yeah. Okay, if we go around the table, no other questions. This is Dr. Josh Yellen for the Sports Medicine broadcast, and I'm sitting with Dr. Mark Knobloch, and thank you very much for talking to us, Dr. Ott. We really appreciate all of your knowledge and your support of athletic training and our athletic training program, which again you can find at www.hhp.uh.edu/MAT. We're fortunate enough to have Dr. Ott as one of our adjunct professors, and she's going to grace us with a number of incredible statistics and knowledge.
Thanks to Pasadena High School
and
as
thanks
well.
to Pasadena High
Bill
School.
Hale is just off camera, but
yeah,
he's instrumental.
Yeah, thanks to everybody for doing this. All right, Dr. Ott, thank you very much.
You guys are naturals. Dang, you love this. I can tell. I can tell. It's hilarious. And then I'm like, place in your last name for a second. I'm like, great. I'm Dr. Yellen. I'm sorry. I didn't know you were Josh.
Okay. Josh Yellen. Nice to meet you.
Yeah. Rolling live. We're just gonna start with the recording.
Well, you know how to start was Mark identified that this program existed. So we reached out to Jeremy and Bill, said, hey, can we come on your show and talk about the program? And then,
this is
What's that?
Brett's 2 hours or something like
Lima. So we can go ahead and start if you want.
I'm Josh. I'm the director of the graduate program.
Oh, okay.
And this is our coordinator, Mark Knobloch. Yeah, we typically call each other.
I'd like to throw some shout outs to y'all tomorrow.
Yeah, dude. I've tried to tweet and then my phone battery died.
Down so I can get a plug like them.
I was tweeting each interview and everything, and my phone died, so it's out in my car charging. So I'm trying to tweet that who we were talking to, but we'll see.
My charger with me. My phone's almost dead. I didn't get my charger. No, it's like on your hat.
Are we ready?
Officially,
Everywhere.
Recording started, so we're ready to go. So this is Dr. Mark Knobloch with U of H Sports Medicine, or U of H Master of Athletic Training Program. I am the clinical coordinator. And Bill, since you're sitting there, Bill
Hale from Pasadena High School.
He's going to be helping us out. And we're sitting here with Brett Singer. He's a registered dietitian with Memorial Sports Medicine Clinic. Brett, could you just give us a brief background of your education, where you come from, and then why you went into dietetics?
My background is I went to Texas Christian University at TCU and did my undergrad in nutrition there. I'm currently working on my master's right now at TWU. I'll be done there in December. Been a registered dietitian for about 4 years now. I started off in clinical, working in Memorial Hermann Texas Medical Center, so working in oncology, trauma, etc. for nutrition, and then eventually moved on to sports nutrition, where I've been here for a little over a year now, and then also a board-certified sports dietitian as well. So that's kind of my education, why I got into this. Love sports, wanted to play sports, knew I couldn't, and decided to do nutrition
the generic
instead.
answer most of us give.
So I decided that was my route, and I didn't want to be a strength coach, and there's very few guy dietitians, so I figured that was an easy route to go, and it was something I was interested in, so I went that route instead. So
here's my first question to you.
Yeah.
Why do I care about lean muscle mass? I can watch something on TV that's getting for $19.95 plus shipping and handling. I'm going to take this product and I'm going to lose 30 pounds in 30 days.
Yeah.
What do you say about that?
Perfect. I try and tune that out as much as possible. I try and ignore that stuff as much as I can, just because it gets me annoyed and frustrated. But
can you tell us why? Because I think that's the key point. And I agree with you 100%. Yeah. But what is it about that? Why are they allowed to say that? And why is it that stuff doesn't work as well, but they can still say it does?
So the way it is, at least for supplements, there is a law called the Diet and the SHEA basically. So Dietary Supplement Health and Education Act in 1994, and when that was started, basically they gave rules of what you could and couldn't say. And we have something called structure function claims in supplements. And what a structure function claim is, it's a generic claim. And as long as your claim is generic and your supplement isn't harming anyone or killing anyone, then it's okay to say whatever you want. So I can say it makes you feel better or makes you get stronger or jacked or shredded, or as long as I use a generic term that's not a clinical definition of anything, you can say whatever you want and nothing can happen to that company. And then to further that point, what I try and stress to a lot of my supplement users is that the burden of proof for any supplement is actually on the United States and not actually on, it's on the FDA, and it's not actually on the supplement company themselves. So if a supplement is found to harm someone, the FDA actually has to prove that it harmed that person, and the supplement company doesn't have to prove that it didn't.
Really?
So they can continue to sell the supplements that's been on the market. So that happened earlier this year. DMAA, or dimethylamylamine, was on the market, and a couple different supplements. Was a drug that was banned in the 60s, and they continued to sell it. A couple different supplement makers continued to sell it despite FDA telling them to take it off, because their claim was you can't prove that it caused heart attacks, so therefore we're just going to continue to sell the product.
Wow.
So generic claims are really frustrating, and people fall into that trap all the time. And I have so many clients that come to me with every supplement possible under the sun, and some of which I've never heard of in my life.
Most of probably.
Yeah, and then I'm trying to read studies, and some of the studies are going to be in rat studies, and it's just going to be very minuscule amounts of evidence.
You segued to my next question. Before we get to the lean body mass, do Americans need to supplement, in your opinion?
Do they need supplements? No, they don't need supplements. Not really. It's just you can focus on your diet, and that's the thing I try and emphasize most is we focus so much on the little tiny details and trying to find the shortcuts when in actuality all of us are pretty poor with our diet. If we could just focus on getting that right first, then you can start to worry about the other stuff. If you're still deficient in something, or you may need something for whatever reason, but I think most of us can improve our diet first and our exercise habits first, and then we can start focusing on the other things. But until then, there's really no reason to supplement unless there's specific circumstances where maybe someone requires it for whatever reason.
And what would you say the biggest, when you say we need to fix our diets, what is the biggest fix? Is it still too high fat? Is it high sodium? Is it not enough protein? What do you see?
I think it's different for everyone. I think people skip too many meals. I think people make a lot of mistakes with too many processed foods. I think portion control is always an issue. I think not enough people are preparing foods themselves. There's too much reliance on going out to eat all the time. I think really it depends. Every person, including myself, has our faults of what we could do better. So there's a number of things that we all could do a lot better. So, but those are the portion control and lack of ability to prepare food for themselves, I think, are really the things that are the biggest issues that we see in American diet right now.
So you just gave a talk to a bunch of basically athletic trainers about lean body mass, and like I alluded to somewhat jokingly before, is you see a lot about lean body mass and how to fix it on TV. Besides the advertising, what do you see as the current trends in terms of in research or whatever? What is the current hot topic, would you say, in lean body mass improvements? Is it a supplement? Is there a new kind? Is it still on the paleo kind of diet, the Atkins diet, or is there a workout? What do people come to you most often with and say, does this really work?
The trend I see in populations right now is pre-workout supplement drinks. I think is one of the biggest things that we see. Which are very poorly researched, and that's where we start to see much of the concerns that I kind of mentioned earlier. So the DMAA that was found in pre-workout supplements. There was another one earlier this year that there was methamphetamines found in that supplement.
Wow.
So,
really?
Yeah, so there's a couple of supplements that have found meth analogs in their pre-workout supplements. So that's a trend I see in populations. Trends in research, and that researchers are tending to talk about, there's a lot more emphasis on protein spacing, quality of protein, and leucine being an important amino acid. So that's what we tend to see in the research. So two different concepts. You see the supplement concept and the population of clients I tend to work with, over-reliance on that. And then in the research field, we see more on quality of protein and how to space it and portion control.
And that's actually a big point, because when you say quality of these supplements, there is no FDA regulation. Can you talk on that? How do people know?
There's not, and there's some evidence out there. Well, we know that even batch to batch on some supplements may be completely different. So there's not a lot of regulation on it. That's kind of what I mentioned earlier on that structure function claim. So as long as you make your generic claim, you're okay. Any of us can make a supplement and put it on the market. As long as you submit your generic claim to the FDA within 30 days of putting that supplement on the market, they're not going to do anything about it. So in other words, I can go to my garage and make a supplement and put it on the market as long as I have the financial ability to do that.
And as long as I put in the thing to the
that
FDA within 30 days before I put it on the market.
And it's okay. As long as...
I use the generic...
Correct. Generic claim, and if nothing happens, now...
As long as nothing happens.
As long as nothing serious happens, because if something kind of semi-bad happens, then the supplement company doesn't have to really report it. So they're allowed, like they're suggested to report that, but they're not really.
Now you mean something happens to an athlete, or something happens to their manufacturing?
No, to any person. So, so if someone gets just somewhat sick, then they don't have to necessarily report it, although it's suggested that they do. But why would you if you don't have to? If something happens like liver failure or death, then they find out that it was that supplement that caused it, then that would lead to something. But even then,
and that's probably years and years of research to definitively link the liver disease to your supplements.
Yeah, there was
More
one.
likely that liver disease is going to take a while.
Yeah, exactly.
There was one earlier this year that was really, I don't remember where. I think it was CBS wrote the article, or someone like that wrote it, and it was a supplement. There's a supplement on the market right now that's called Craze. It's a pre-workout supplement, and they were found to have meth in that pre-workout supplement. But the story, or the background story on that particular supplement, was that particular supplement maker had actually been in prison prior to making this supplement, and he had been in prison because a while back ago he had he'd taken pesticides and put them in capsule form and sold them as a weight loss supplement.
And why would he do that? Was there a pesticide that actually affected metabolism, or obviously he didn't just randomly?
I honestly don't know. The pesticide was actually a drug in the 30s, I think, or something like that. It was a very long time ago, but it was found to be very harmful.
So he took a drug that was long ago shown to cause weight loss.
It was banned.
Wow.
Well, and I don't think it was really for weight loss back then either, to be fairly honest. And
I don't think anybody back in the 30s was injured.
True.
Weight loss.
Well, and so he posed as a farmer, because you can buy that pesticide for farming purposes and then capsule it with baking soda or baking powder or something like that. Sold it on the market. Someone died from it.
Wow.
Went to prison for 2 years. They got out of prison earlier because that person they were trying to commit suicide, so he didn't get the full effects of that. And then back on the market, opens up a new supplement company, creates one of the hottest selling pre-workout supplements on the market, and there you have it. So very minimal regulation to answer your question.
And so if you recommend a supplement for somebody, do you recommend I don't want to say a brand, but is there a standard that there's a company that tries to give some credibility to them?
There's different supplements that you can use that you can feel pretty comfortable with. You can check out supplements that are NFS certified. And you can, there's different websites that you can use that I have access to that can be used to help determine if the supplements are safe. But there's different companies. EAS, I believe, is related to Abbott Nutrition now. Abbott is the same company that makes Ensure, so the same type of supplement that you would make for that we would provide hospital patients. So I feel pretty comfortable with them. Muscle Milk is another one that's provided at all colleges, at U of H, I'm sure, and everywhere else. Muscle Milk Collegiate is a supplement that's provided there. So there are companies out there that you can feel pretty comfortable with. But a lot of these random supplements that you just find that are kind of in and out of the market very quickly are the ones to be a bit concerned about.
So you talked, like we said, about lean muscle mass, and so obviously lean muscle mass is a tremendous health benefit. Is what do you, from a dietetic standpoint, people say, well, you lift weights. What can they do in conjunction with that from a dietetic standpoint to help improve? I mean, obviously you're not going to get big overnight, but it's, you want to give the best scenario. So do you recommend sticking with that and control your diet? Do you recommend weightlifting or whatever plus supplements? What is your official stance on that?
To me, like I said before, it's you focus on diet first. So let's get that fixed, and then from there we can focus on supplements later if we need to. You have to do both. You can't just do a poor resistance training program and eat healthy and hope for the best, and you can't do a good resistance training program and eat poorly and hope for anything. You really need to combine both of those two things. The first thing you've got to do, along with your appropriate resistance training, is taking in enough calories. If you're taking in too little calories, you're going to have a hard time of gaining any muscle. So taking in ample calories, and then making sure taking in quality protein. And so that's the topic of my presentation today. So your meats, eggs, dairy, soy, those are quality proteins. They're complete proteins. So they contain all the essential and non-essential amino acids. So incorporating those as part of your diet throughout the day, as opposed to 1 or 2 large meals, is what's going to be helpful for growing lean body mass. So a major mistake that a lot of people make is that they take in their full protein intake in 1 or 2 meals, and what we're seeing is that there is some point where you're not utilizing all that protein the way that you would like to be. So once you exceed that amount, you're essentially oxidizing it and excreting some of that protein out. And so what we would rather do is, in order to get the most bang for your buck, rather than take in all that protein in 1 or 2 meals, space it out adequately to where you're having protein every 3 to 4 hours while you're awake, and that way you're building muscle mass with each of those meals. When you're taking it in 1 or 2 meals, you're not going to be growing as much of the day. So what you have to think of it is, after every workout, you have 24 hours to grow. So that's what the anabolic window is. And so utilize that full 24 hours to grow from that workout, not just the first 30 minutes after the workout.
And what about these high protein diets where they have no choice but to take protein all day? Not do you recommend them necessarily, but does that affect lean muscle mass? Is there actually a point where you over metabolize? I know there's talk about kidney, issues with kidneys, but
I don't worry about kidney health as long as the individual is healthy. I'm not worried about that. We haven't seen any real research to back that claim, but what I will say is that taking in a large portion of protein is okay, but there is a point where you're exceeding the limit where you don't need to be. We're not getting any benefit out of it. It may not harm you per se, but it's not going to provide any benefit. And for us, it's about 1.8 grams per kilogram. And to make that more simplistic, really less than a gram per pound of body weight is what we need to be taking in. So what you hear in the gyms is often take at least a gram per pound of body weight, and actually that's significantly more than you need. So realistically, about 1.8 grams per kilogram is about the max that you would need to take in, and then spacing that out, every 3 to 4 hours. So basically 20 to 30 grams for most athletes. What that's going to look like, unless they're just an exceptionally large athlete like an offensive lineman, 20 to 30 grams is about the max that they would need of quality protein, though.
And is there obviously you can get protein from so many sources. Is there obviously I've heard of eat chicken breasts or lean meat. Is there a difference in without excluding performance, like not you don't want to eat something really heavy before, but is there a big deal on what kind of protein you take in, or do you really recommend lean meats and that
to me, lean meats, eggs, dairies, soy, those are all good options. So those are all complete proteins. So it's up to the individual themselves. Roughly 3 ounces of chicken is going to be about the same as 3 ounces of fish, and it's going to be about the same as 3 ounces of beef. It's not going to be much of a difference in terms of the quality of the protein or the quantity of the protein. About 3 ounces is going to be about the same for either one. So that's kind of my focus is taking it in quality form with those options.
Okay. Bill, do you have any questions from the high school last side?
Well, as far as asking or giving high school kids recommendations, because they all like to do these protein shakes. and you said EAS and
Uh-huh.
a few of the others. But as far as what I'm getting from you is to tell them to fix their diet first, make sure they're eating.
Yeah.
Because all these kids, especially the school I work at, is the income level is very low. These kids don't eat like they should eat. So what kind of foods could I suggest to kids that are on the just above poverty level as far as athletes? As far as it's not going to be really expensive, not hard for a high school kid to make. When you're looking at my school is Hispanic majority, try so they stay away from the Mexican type foods and stuff. So what suggestions could I give?
To me, first off, don't skip meals. So that's a trend I see in a lot of high schools.
They don't eat breakfast.
Breakfast is never. So remember what I talked about. So you've got 24-hour window for growth. So if they worked out at 3 p.m. today, then that breakfast meal tomorrow morning is potentially every bit as important as right after that workout.
Correct.
So their breakfast tomorrow morning is crucial to have something. So if you're trying to grow throughout the 24-hour period, then utilize breakfast because you don't want to skip out on that. So some sort of dairy or egg for breakfast. So even if you're on a school lunch program, there's going to be dairy available for there. Milk is a quality protein.
Oh, yeah, we got a big sign up about milk and everything.
And so we know that's helpful. So taking in that, taking in some form of meat, ideally not fried, but grilled, baked, sauteed, some type of meat with your lunch and your dinner, as opposed to a recovery workout drink, like a protein shake. If that's not available, because that's not going to be very affordable for most cases, milk is just as easy. Whole milk has been shown to be very beneficial in terms of growth. Even a smaller dose of there was a study at UT Galveston where they used essentially 8 ounces of whole milk in comparison to I think it was 20 ounces of low-fat skim milk. And actually with that whole milk, they had just as much growth compared to the larger dose of skim milk. So potentially for lean body mass, even whole milk would be a potential option for a recovery drink. And then again, having some sort of protein for dinner, whether it's, ideally some sort of lean meat, 3 to 5 ounces there as well. So not skipping meals.
Let's say they work out early in the morning too.
So for me, I would have something light beforehand if they can. If they're doing fruit, some sort of small piece of fruit beforehand, and then having some sort of recovery meal afterwards. So having their breakfast then, or having their meal or their milk, or some sort of along with some sort of grains after the workout itself. Because you want the protein from the milk, but you also want to get some sort of carbohydrates also to help replenish the lack of carbohydrates. Peanut butter is an option. I would incorporate it as part of it potentially, but I want to have some sort of quality protein. So whether it's the dairy, the eggs, or the meat
eggs
is an option. The reason again for that is because that's going to contain all the essential and non-essential amino acids. And what we find is that leucine's the key amino acid. And leucine is going to be found in a lot larger dose in those types of proteins compared to things like grains or nuts or nut butters. And so leucine triggers the start of growth. So if you don't get enough of that, then you're going to have a hard time growing after a workout. So that's where dairy and meats can be beneficial and affordable. It's not it's not hard to do that. I mean, that's something that we can make work compared to these $3 and $5 recovery drinks.
Right. That's true. Yeah. Sweet.
Any Twitter questions by chance? No. Well, Brett, we really thank you for taking your time.
Yeah,
you had a very good talk, and you had a very good turnout, and you had a nice pool of athletic trainers to talk from. So I'd like to thank Pasadena High School for setting this up. I'm Mark Knobloch with U of H Sports Medicine, along with Bill Hale from Pasadena. I'm going to get Pearland out of my mind. Pasadena High School, and Brett Singer was here to talk about lean body mass. We thank him for his time.
Yep. Thanks.
Is it live? They came up with the question, what's the difference between the Zurich 2009 and 2013? I'm like,
4 years.
Thank you, Chris Shadid, from Pearland. And I just, at that point I'm thinking, like, no one ever asked a question. And it just seems like
I'm not on the same as like Bubba. I'm just with her. So I'm in the, yes, but they do all of what she does. It would be advantageous, especially when you're doing the exertional stuff.
Yes. You'll give her, well, are you doing
Me, that's right. Yeah.
So every is there for sure rehab, but I mean, you should go where they can what to do. We have the overall umbrella clinical agreement, so you do there. Site, they can do. It's just, I gotta figure out how to do it. I'm sure somebody can do it.
Do y'all not have them set up to go to any of the local high schools?
We don't yet, because the first year you're usually you exclude them. Well, we don't want to send them there. They can't do anything until you full six school. So if you go to high school and just want to have a trainer, they're gonna say, well, go, you know, go test for that year. Like, can't. So we're doing full year. Which would give them a lot of pressure. They're gonna have bad neighbors care.
So if you stay on the minute you saw
Then we're gonna start rotating. The second year, we're gonna rotate, we're gonna try and match it. So, we do 7 half-week rotations twice. And then they do Texans, so we do that, and then that's how we're gonna do it. Based on what we do. But you have to be careful where we send this, so we send this, like, they know it's gonna be X amount. Because this is, they were to a certain like Shay, I'm here from 4 to 8 to 5, until 10 at night. Can't do that. It's not that. So eventually, we haven't got any high school set up because we don't have 20 high school. So he can rich. That's what we're meet with Texans on Tuesday, and once we get all of the first year rotation set up, then we're gonna start looking at a couple high schools. Yes, sir. If they go, let's say another goes to Bay Area Christian High School.
Hey, by the way,
do we have to have a common agreement with Bay Area, or just with the corner?
Because we have the agreement, so it shouldn't matter.
Yeah, it doesn't matter. We have affiliations with, all the people. Bubba's one of our preceptors, so wherever Bubba goes, they go.
Yeah,
It doesn't matter.
All of us athletic trainers and one have agreements with all the schools
Yeah,
that we
it
work with.
wouldn't matter if Bubba showed up, so as long as they're on Bubba's hill. And they do what Bubba says, not what that athletic trainer is at Bear Christian says. They're not a preceptor.
I am the athletic trainer. First of all, I've never
No, it's
seen.
just like
We look at, we look at, we look at.
Well, Carolyn, I was at Carolyn High School before this, and I'm just going to tell you about my background, because I went to the entry-level master's at SFA. So, and Matt Thomas, the head trainer at Carolyn High School, he did as well, so he understands the entry-level stuff, so that's just a thought.
We had a couple, but we don't want to, we got this, and then they're like, I talked to them, and I hear they're sitting over there, so kind of waiting to sit in the high school.
We just don't have much students.
Are you interviewing?
As soon as we get, our next cohort, let's say it's 20, then you have 25 kids in the program.
Yeah, but only 13 will be ready to talk about 2 years from now.
Get that straight.
Oh, you did?
Then it's like.
Where my painter over there?
Yeah, we want to try to keep everybody happy, but do we have a?
Is that the WTA? Yep. So what does the WTA stand for?
Because that's what I was thinking when I was listening, dealing with it.
Y'all are doing the live feed right now? That's fine.
They just had her nails.
Yeah. Bubba doesn't need recording.
You got some headphones for me? Or are we just doing it like this?
You don't need them.
Okay.
You going? Okay. We're right here with Bubba Wilson. He's going to talk about we're going to have a little conversation about a case study, and I need Bubba to explain that to us here. This is Bubba Wilson from Memorial Hermann.
In essence, the case study is in one of my schools that I deal with. I had a 16-year-old football player have a stroke on the football field, which was it's obviously uncommon in a 16-year-old, and ultimately the reason for his stroke was he had a cardiac abnormality. He had a hole in the septum of his heart, so that's what caused it.
So caused it. Okay. So he had a hole in his heart.
Mm-hmm. Right.
But there was no way to detect that, right?
There's two ways to detect. Three, in essence. To give a little background, 25% of the population probably has this defect, but the hole is small enough that it doesn't affect them, and typically that number is under 5 millimeters. Now you can be born what I call the blue baby, where the baby looks like a Smurf, where it's not oxygenating. They know those babies have this defect and they're not oxygenating, so it needs to be fixed. But that 25% of the population that has it that may not know it, their defect hasn't been a problem. Okay, and he had this defect. His ultimately was 8 millimeters once they found it, and they had to close it. Anything over 5, they tend to close. Under 5, they watch, and if you have symptoms, then they go, okay, this is problematic, and we need to close this. But anybody under age 55, roughly, that has a stroke, in all my research on this, they have a high suspicion of this type of defect being the cause of that stroke.
Okay, so this child or this young man, or is it a young man or a young woman?
16, yeah.
16-year-old man. So what happened to him as far as having the stroke? What is his?
Basically, no medical issues. Until he had gone to the ER, he basically couldn't recall ever having blood drawn. He was at second day of football practice in pads, made a tackle, got up and was dizzy, and then started having blurry vision and a little tingling on his trap. Coach calls me. I go and see him and evaluate him. And honestly, he also had a little facial droop by the time I saw him. I thought stroke immediately, but then you're kind of going, he's 16. My mom has strokes, not 16-year-olds. And so I go through the stroke eval, which is FAST, which is the acronym is FAST, which is face, arm, speech, and time. Well, he had the facial droop, but he could raise his arms and hold them up. He could speak. We could understand exactly what he was saying. And time is of the essence, but I wasn't panicked on time at that point. So it's like he's got 25% of the stroke signs. Well, come to find out, if they have one of the 3 signs, they need to go get evaluated. Right. But these are the things you learn after the fact. Didn't change it because I still sent him to be evaluated.
Correct.
Went to Memorial Hermann Southeast, and they started the workup and realized he needed a higher level of care, so they sent him to Children's Memorial Hermann up in the medical center, and got there. They did further testing, did an MRI, found out he had a stroke. It's interesting in reading the medical records in the hospital. The neurologist that saw him after the stroke made a notation they needed an echocardiogram for this PFO. So the 2 ways, to get back to it, the 2 ways to know is you either get an echo or they find it on autopsy. You can't do it with this. You can't find this with a stethoscope, with listening, and it's not going to show up on an ECG. So you've got to be able to visualize the heart muscle and see this defect.
So being as athletic trainers and doing pre-physicals,
right?
This is kind of scary.
Well, it is, but
because there's no way a doctor can just listen to the heart.
No, but you can't, even if you do, as we all know, if you do a physical, you're not going to catch everything.
That's
you
right.
can do an ECG, it's not going to catch every cardiac
Even an
abnormality.
echo is not going to catch everything.
And and he had a big defect. What if his defect is small? Maybe it doesn't show up. I don't know. I don't understand that. But there's still a lot of unknown that we don't know, and I think it boils.
But did this kid survive?
Yes, did fine.
Fine.
Did fine.
Is he playing?
Yeah, he had the test done to find the hole in the heart and a couple other things. Look for everything else. Worry about clots.
You said they repaired it?
They actually went a month later and repaired the hole, which is a pretty interesting way to do it. They go in the cath lab and snake a thing and pop it out kind of like an umbrella, pull back to the other side of the septum and pop out another one. They kind of cinch them down tight, and it closes that hole.
So did you get to see this?
I didn't see the procedure, but I have the images.
The images? Cool.
Yeah, so it's pretty neat. But he did fine. He played soccer this year. He's a musician. That's doing fine. They would let him be the holder in football, but the risk of him getting a hit to the chest or something back to the head to have a problem is pretty high right now, and so the risk is less with soccer. It's still there, but it's kind of one of those that we can mitigate some of this, and so he's just going to play soccer senior year and work on his academics.
Would he wear like a
no,
jacket
he didn't
or
have to wear
something
anything.
underneath his shirt or?
No.
That's pretty cool.
No.
Okay. Well,
because of the fact that he didn't have a cranial bleed, it was a cardiac abnormality that they could fix. It's just we're still early in the healing in the grand scheme of things. So it's like,
yeah.
Let's
so
be safe.
basically, from this study or from what you're getting is that, so if you do your fast symptoms of a kid with a stroke or anything, and any one of those symptoms comes up, any one of them,
send them.
Send them.
Right.
Don't hesitate. Just
right. Send them. And then as I said, and there in some of the stuff I was looking up, they're now saying just have them stick their tongue out. Their tongue should be in a straight line. If it's off to one side, then that's another sign. And it's not the hold. It's one of those.
Yeah, it's one of those. Yeah.
Facial droop syndrome. Well, it could be Bell's palsy, but that's not my decision to determine.
Right. We don't make those.
What's his arms? He can't hold one arm up, but he can do the other. So it doesn't matter. Send him.
Yeah.
If they got all three, it's like, ooh, now I think that's bad.
Yeah.
So.
Most definitely. So cool. Nothing coming up or anything. Okay. Well, I don't have any more questions on that.
Easy enough.
That was a pretty simple one. Well, we just want to thank Memorial Hermann for this update, and Bubba and the Pasadena broadcast. This is Bill Hell and Bubba Wilson.
Thank you very much.
Thank you for coming on, Bubba.
Yeah, here, I'll show you. What it looks like. Right. So there's his stroke lesion right there.
Okay.
That's it.
That's it?
Very small.
And that's normal on the other side.
Yep.
Right?
See, there's no white there. So over here, I went through that thing about 30 or 40 times, couldn't find it, got frustrated, went up to the Iron Man in the medical center and talked to him on the radio. I said,
so it's that white part?
It's that white part right there. I said, can you find this for me? I said, here's what I know. And they went through and said, there it is.
So being that we don't know what we're looking for, I see white there and I see white.
Symmetrical.
Yeah.
It's just fluid.
Yeah.
You're looking at blood.
Yeah, but if you look at that side there, it's nice and gray.
Right, and that has
white.
White, exactly. I mean, that's cool. It's just another one of the vascular studies they did, but I just like that. I think that's a neat picture.
Yeah.
I mean, it's cool. But if you go through here. So here is the defect. So if you look at it, he had what's called a PFO, so it's more like a flat valve, like a toilet. Opens up and goes as a pressure changes. So what they think is when he wrapped this guy up, he's doing like a Valsalva maneuver, takes him through the ground, and it blows the clot from one side to the other, and then goes up to his brain.
That caused the stroke.
Right. Okay. And then this would be, if you look at it on echo, there's a little line through here, and that's his PFO. Just a little disruption. I had to go find a picture. I couldn't figure out what I was looking at on those. Oop. And then here's the closer device. So they snake it through, pop out one side, pull it back, pop out the other, and it closes that defect. And that's what his looks like.
Sweet.
So it's
kind of like a little.
The septum sitting right there. So it's like they go through, open an umbrella, pull it back out, open another umbrella, and kind of cinch them down. In essence.
So when it works, it just.
Well, it basically stabilizes it.
Yeah. So.
It's closing that hole.
That's a valve, isn't it?
No.
Or that's a hole.
No, that's the hole. Yeah.
Oh.
Yeah. So they don't even move. No, because it's in the septum.
Oh, it's in. Oh.
Yeah.
So he was having. going through, kind of
Right.
like it was like one like
Right.
that.
You know, it worked like a valve, but it should never open. It should be closed.
Yeah. It
So
shouldn't.
so under normal circumstances, blood's flowing like regular, so you don't hear it on the stethoscope when you're listening to it.
Only when he's stressed.
When he's big stress in his valsalva maneuver,
Yeah.
you're like so I
Kind of like doing a big bear hug.
right, or you're maxing. Okay, you really strain it, go in the bathroom. So my point was, you can make an argument that this is one of the times that athletics saves this kid's life. Because, okay, his heart rate's up. He's at football practice when this happens.
Right.
What if he had maxed? And then I kind of feel bad, but no big deal. And he's driving home, and he can't see, and he goes weak, and he has a wreck.
Yeah.
You know?
Cause more.
Right. You know, and now he's a statistic, you know, as opposed to, well, okay, we had to send him to the hospital. We had to send him to another hospital. That's fine. We found this, you know.
Right.
So
That's pretty cool.
I'm going to try to write him up as a case report and publish it if I can.
Is this thing over? How far down were you?
Third from, there were two after me.
Jeremy, you gonna help me tomorrow?
Yeah, I can help. I got to do a few things in the morning. And then our cup size. Cup size. You know,
for Halloween, I want to be a man.
look, all you do is just get a box and cut it out.
That's it. Well, from, yeah, well, I'll film that. I'll tell you, yeah, good.
I wish I'd worried about you. He said, "I'm too testicular."
For Halloween, I want to be prostate.
Which, okay, fine, but if they ask for a second opinion.
Yeah.
Like the guy that had the 4 gunshot wounds in his back, the worst case of suicide I've ever seen.
Oh, my God. Yeah, my dad actually had a case like that. My dad's a shrink. And so he had a kid that came to him because he attempted suicide. And how he attempted suicide is put a gun in his mouth and he tried. Well, the blood goes through.
Didn't make it back.
Yeah, goes through and goes through, essentially chips off one of his dad's car. Recovery, plastic surgery recovery. And decides that he's going to overdose. So pounds a bunch of pills and chases the devil out. But before he can take enough to actually kill himself.
Start puking.
Yeah, and not only he starts puking, but he just essentially falls asleep. That's what he wakes up. Then he decides to run himself off a cliff. Like, okay, I shot myself, it's not going to work. AOD, and I just fell asleep, so that's not going to work. So I'm going to drive my car off a cliff.
No time he gets a flat and stop right before.
He was wearing a seatbelt. Straight off the cliff, rolls the car, walks away. And my dad was like,
Don't you think somebody said you ought to live?
yeah, my dad was like, all right, so let's talk about it. And then I saw him do another case where for a long time he worked for LAPD as a profiler. And one of the people they were looking after was between the LAPD and FBI. Something had happened that spooked this guy, and now he's ready to jump off the building and kill himself. And so my dad gets paged, and he says, I'm not trying to take photos, you got to. He says, you can stay in the car, don't say a word, don't say anything. So of course you see all this going on, the guy's gonna jump, I'm getting out of the car.
You want to see this?
Yeah, but I'm on the hood of the car, I'm just going, my dad, talking with me. And my dad finally says, I don't think you got it. Yes, I did. I do. Stop wasting everybody's time, Joe.
You didn't do it.
No, you don't want to see. I mean, I'll actually do it. Joe. I'll be back. Well, other guys like, man, maybe I am seeing it.
Did you ever see the movie Bachelor Party?
Yeah.
Remember the guy's got the electric razor trying to cut his wrist?
Oh my God. And then my dad turns to me as the guy gets back up, they arrested him, called him to 450 for 72 hours. And my dad turns to me, whew, you know that was. I'm like, what?
What's the first rule of psychiatry? Yourself. Yeah. Right. That's the guy that walks in.
Have a break right now. Dermatology lady still speaking.
Good. That's a good one.
We done?
Two more.
You want to interview Dr. Jonathan?
You've never been a microphone he doesn't like.
He's never been to mirror. He doesn't like.
You're just so happy to see me. You can't stand yourself.
Hey, listen.
No.
When we're all done with this, I want Bill, Jerry, right, and all the people we can get. Mark had a great idea. We'll take a picture. We'll do it with my iPad this time. We'll send it to the NCAA news and say that we did this. And as a part of the picture, we're going to put the sports medicine broadcast. So you get some national publicity. Again, Mark's a genius. I'm just here for Braun.
Josh.
You got Braun.
He's a genius, you're just the eye candy.
By the way, the follow-up conversation you and I have privately, I haven't heard anything yet.
Say it again?
The nasty, I didn't hear anything yet. They haven't called me.
You're not going to hear it for a while.
All right.
But you're still, I think you're on the air, so. Yeah, you're not going to hear anything for a while. All right, we're back here at the Sports Medicine broadcast at the Memorial Hermann Ironman Sports Medicine Institute UT Physicians Sports Medicine Update 2014. Again, I'm Dr. Josh Yellen with the University of Houston Master of Athletic Training Program at www.hhp.uh.edu/MAT. And to my right, we have Dr. Rahul Bajani set up second part of his interview. Dr. Bajani, thanks again for being with us.
Oh, you guys are most welcome.
So let's talk a little bit about, we talked about your training as a physician. We got into it just a little bit before Dr. Ott showed up, so let's go back to that.
Absolutely.
All right, so you went through medical school, and then you do a 3-year residency
in
family medicine. And then how did you decide that you want to do a fellowship?
So it's actually kind of peculiar. I had decided I want to do a fellowship before I even started residency. Quite interesting story. I did all my undergrad and medical school research in heart and vascular surgery, published about 30 papers, worked all the way through, thought I was going to do the whole shebang-a-bang, got accepted.
I'm sorry, shebang-a-bang?
Yeah, shebang-a-bang is a medical term for those who are paying attention. Shebang-a-bang is a medical term.
I understand.
Yeah.
It's one of those rare diseases like anaelexia.
Yeah.
Okay, go ahead.
But, kind of fourth year came around. I was on the fall rotation, getting ready to do interviews for residency, and I did my first rotation with a primary care sports medicine doc. Thought it'd be cool, get to see what's out there, get to go some Friday Night Lights, football junkie like myself. And 4 weeks later, I was like, okay, now I'm going to have to rewrite my personal statement. I'm going to have to redo my application. My dean was pretty upset with me. My mentor / boss who added all these papers was really upset at me, but it was just one of those things. I knew I wanted to do it. I came into residency as an intern knowing I wanted to go into sports medicine fellowship.
And so let's talk about, just briefly, some of our listeners learned earlier that, again, we have some listeners that are younger, maybe an undergraduate. We have some listeners that are professionals. So it's a broad age range. And just to keep everything on an even track, everybody goes through the same 4 years of medical school.
Correct.
And when people think about sports medicine, they think about the orthopedic side, and that's a 5-year residency.
5 plus the fellowship.
So that's a 6-year, right?
6 years.
Tell us more about family medicine. What's the residency years about for that?
It's usually 3 years. There are a couple of programs across the country that do what's called the P4 project, which is a 4-year residency, which incorporates a year of research. 3 years is pretty typical. You get a wide range of experience in all the different subspecialties as well as the general practice. You basically get a grasp on everything from the time you're born to the time you're passing away, which gives someone in sports medicine a unique advantage because you got, the level of athletes you take care of can be anywhere from middle school to high school to college to professional to even, we can call the elderly in their own athletic class, which has its own subset of injuries. So it gives you that wide range.
And then after that, you do a year of fellowship.
You could do 1 to 2 years of fellowship, depending if you want to do research or no research. Like I said, there are about 100, I think it's about 106 this year, fellowships in the country. We have 2 here in Houston right now, and it's a difficult field to get into. It's been getting, like I said, getting very, very hot now. I think this year there were close to 700 applicants for 140 spots.
Really? Across the country?
Across the country. And so it is a very competitive field because everyone realizes that it's the next new thing in medicine to be.
And so there are a couple different ways you can get to, if you're not going to be a surgeon, there are a couple different ways to get that sports medicine fellowship. So talk to me a little bit about the difference in your training as family medicine, and tell me the difference, right? Because you hear these terms that are pretty interchangeable. I'm family medicine, or I'm general practice.
Right.
What's the difference?
There isn't really a difference. It's, you can use the word general practice for an internist, which is an internal medicine training, which is 3 years focused on adults. You can use the term general practice for family medicine. So there are, and you alluded to another question, which I do want to address, is, how many different ways can you get into a non-orthopedic based sports medicine fellowship? You can go through a 3-year residency in family medicine. You can do a 3-year residency in internal medicine. You can do the 3-year residency in pediatrics and go that route. You can do a 3-year residency in emergency medicine and go that route. You could go 3-year residency in physical medicine rehabilitation. So there are 4 or 5 different ways you can actually get to the non-orthopedic, or what we call the primary care sports medicine fellowship. Each different residency kind of dictates what you do when you come out. It's pretty fascinating. So the guys that do the PMNO, or the physical medicine rehabilitation, do a lot of spine injections and do a lot of rehab work. And guys that do the emergency medicine, sports medicine route, will tend to end up more in the acute high events, the marathons, the silence for NFL games, because they're more trained in all the acute stuff, and they're much more useful in those
airway management, C-spine precautions.
Exactly. Pediatrics. Sports medicine is a very unique field in itself, because they really only deal with up to the age of 18.
Right. Junior high school athletes.
Exactly, and so they're actually more trained in child development and injuries that result as a development. A lot of fracture care comes in the role. So this is where, we don't have enough pediatric orthopedists across the country, but we do have pediatric sports medicine docs that can manage fractures non-operatively for those that are clinically indicated.
Right.
And it's become a huge field for those. Internal medicine, sports medicine is a relatively rare combination, but it does happen. Used more in the adult setting, can be used for a wide variety of different adult problems, as well as the elderly with training exercises, as well as the fit model for using exercise programs for chronic diseases like diabetes, high blood pressure, high cholesterol, and whatnot. So there is a difference on which route you take. So for those kids that are in undergrad that are thinking about getting in, and even those in med school, kind of have to predetermine that just a little bit. Hard to do, but if you're really gung-ho about doing sports medicine, you kind of want to know which route seems best
how to
for
get
you.
there and why you want to be there. So we're talking to Dr. Rahul Bajani, who is our co-medical director, along with Dr. Jim Muntz, for the Master of Athletic Training program, founded at www.hhp.uh.edu/MAT. So really unique interaction that we have, and I send out some emails, and I'm looking for a medical director to satisfy our CATIE, the Commission on Accreditation for Athletic Training Education Standards, and I come across your name through a common friend we have, Kevin Bastine, who's now head athletic trainer, I believe, over at the Detroit Lions.
Yep, where I trained. Kind of ironic how that works out.
I'm happy for Kevin, and I think he's doing really well. And Kevin, if somehow you're listening to this, congratulations, and we miss you.
Yeah, I agree. Kevin, was a huge influence. I think he was the one that brought us together. It was a interesting story. We were doing Sugar Land Middle School physicals, and after physicals were done, Kevin is a very simple, no nonsense kind of guy, because and when he comes up to you and says, "Doc, I got to talk to you," my radar goes from, okay, I'm just hanging out, to, okay, what's going on? And pulls me aside, tells me about Josh, tells me about U of H, and says, hey, this is a very unique opportunity. And I said, you know what, Kevin, I trust you. You want me there, I will interview, and I'll do what I need to do to get there.
And so you and I have a conversation, and we talk about the different roles of the medical director, and we talk about what you'll be doing. And so you have a really unique position with us in that you're going to be serving as co-medical director again with Dr. Jim Muntz, and you're also going to be teaching a general medical course for us.
Correct, and so I will be teaching the Summer 2 course, General Co-Medical Conditions in Sports, which I'm going to use as a dual-purpose class. One, obviously, to get the accreditation and get the students ready for athletic training from a general medical condition standpoint, but two, also to show them tricks and pearls, but things that they will see out in the field. Athletic trainers are very underappreciated field in general, and you guys deal with much more than just the orthopedic stuff. I mean, you see it every day. I interact with my head trainer, Max Mahaffey at Sugarland Skeeters, and more often than not, I'm walking into a training room dealing with a medical condition, not a orthopedic condition. And it's important for our students to know what to do, how to handle certain things without having to get the physician involved.
And so from a physician standpoint, I was taught to, I know how to use an otoscope and an ophthalmoscope. I know how to look in somebody's ear and say that's not normal. I know how to look in somebody's retina and know that's not normal. Or I know how to take a blood pressure and evaluate the pulse and know that that's not normal. And I know how to auscultate lungs and know that, okay, I know this sounds like Darth Vader, that's not normal, and this one, it sounds normal. Tell us some other things that you think from a family practice side, sports medicine fellowship trained. What are some other things that you think athletic trainers need to know from a general medical standpoint?
So I would take what you just described, and I want to take our students to the next step. What you described as phase one, being able to do common physical exam and be able to try to say what's normal and abnormal. We got to take it one step further. We got to be able to say to a certain extent, hey, you know what? This heart does not sound normal, but what specifically does not make it sound normal? In sports medicine, as vast of a knowledge base as I have, there's very discrete patterns that will basically say normal versus not normal, but more importantly, normal, not normal versus, okay, you know what, this is something that we can manage. The classic example.
And what's an not normal, you think?
So the classic example I give is when we do physicals, which is the heart murmur. The abnormal heart sound that everyone has been so freaking out about in high school physicals and college physicals. So there's very specific symptoms and very specific things that murmurs can do that will make you say, The things, most often not, murmurs are abnormal, but they're not, okay, we need to get this checked out tomorrow abnormal. So that's where I want to help take the next step and say, you know what skill set, what questions do I need to be asking to make me believe that is this particular finding, physical exam finding, abnormal, relevant, or something that we can just wait on?
Because that's really something that you're going to be looking at on a pre-participation examination, right? And if you don't have the fortunate ability to be in a city like ours or at a university like ours where we have access to some of the best medical care in the country, and you're an athletic trainer in a small town anywhere in the country, you're going to need to know the skill set so that you know when to refer, when not to refer, who to refer to, etc.
And I think that the last part's the key is, who to refer to and how quickly we need to get the referral done. Sometimes athletic trainers are going to be, as smart, if not smarter, than their general practice docs that they're going to be referring to because of the fact that this is a very specific field. And unlike general practice where everything is, has to be worked up, sports medicine is you have to figure out if this kid needs to be worked up or this athlete needs to be worked up. And more importantly, is this workup going to prohibit them from playing sports? So there's a very focused algorithm for which we need to go down this pattern, which is why I think that athletic trainers are first lines, and that's always been a big principle of mine. I got trained in Detroit where our athletic trainers were our eyes and ears, and you trust them implicitly as long as you had confidence in them, and you teach them, and you have a symbiotic relationship, because that becomes very, very important to how the whole medical team works.
So you brought up a couple different things here about some of the areas that athletic trainer may be lacking in what you're going to teach them. And you and I have discussed a few things about some of the things that you can learn from athletic training. What are some of the things that you think you can learn from athletic trainers?
So athletic trainers are, like I said, my eyes and ears. I will use my example once again with the baseball team, the Skeeters and Max Mahaffey. He and I interact every day. But he is the gatekeeper for me. As much as I am the gatekeeper for the next step up, he is the gatekeeper for me. He has full interaction with all the athletes. He knows the psychological component to these athletes. I mean, I put my eyes on them for 5-10 minutes. I can get certain finite information, but it's the trainers that know the kids, that know the situation, that know what's going on. In addition, it's their ability to remember injury histories. One thing that's extremely important for athletic trainers is that they can pretty much tell you on the bat which athlete has which injury and how bad the injuries have been, previous history and whatnot. It makes life for me as a person a lot easier. So when I come into the room, I can come in there and do the whole exam blind, but I actually will ask my trainer first, what is going on? Give me some relevance, give me some psychological components. So when I go examine, my mind is already 10 steps ahead of where it would be if I just walked in the door completely blind.
What are some other things? We talked about in medical school, I've had some conversations with some other fellows and physicians, and boy, in medical school you learn a lot about disease, but you don't learn a whole lot about health, right? You don't learn a whole lot about prevention.
Primary prevention is a key word.
That's right. Prevention and health promotion.
Yeah, I mean that's a huge component. I mean we have athletic trainers in our Memorial Hermann system that are out there promoting wellness in ways that I would never even know. A lot of my personal workout regimen has been basically done by athletic trainers that have taught me how to work out in a way that makes me more efficient in what I need to do.
Right.
Diet. You'd be surprised how much that athletic trainers have educated me on just simple dietary principles, electrolytes, hydration patterns, things that you can learn in med school, learn in fellowship, but may not be fully able to implement unless you have someone that's doing it every single day, show you how to do it.
So it's probably similar to some of the skills that we have in terms of rehab, in terms of modalities, in terms of return to play. It's a lot like, hey, look, you're doing this every day. Similar to what you just brought up about being able to, listen to a heart and understand, okay, this is a murmur, I need to refer to a cardiologist, or this is a murmur that I'm fairly confident that it's a benign situation and that we're just going to watch it.
Correct. And so the rehab situation, it's huge. It really is. I mean, I don't fully think everyone realizes how important an athletic trainer is to the rehabilitation of an athlete. Every day I walk in and I'm watching my trainers work on athletes, doing the programs and everything. It's almost like the doctor walks in and says, okay, you know what, you guys are doing exactly what you're supposed to do, good, kudos, but it's, in the back of my mind, I'm like, wow, this, here's a throwing program that I've never even known about. Oh, wait, there's this mortality that might do this and this, and, if it's evidence-based, it's amazing that what you will learn. Every trainer is slightly different in the regimen, but it's just understanding the biomechanics that you guys have learned as far as rehab makes you guys much more valuable than me. I'm more of a diagnostician and trying to get things rolling for you guys, but then you guys run the show. It's always going to be your training room. It always has been.
So what are some of the things that you think are going to be needed? It's a really unique position that we have here at the University of Houston developing this new Master of Athletic Training program. Again, you can find that at www.hhp.uh.edu/MAT. And as we're developing this program, I'm constantly thinking, God, what can I do to enhance the student's ability? What can I do to enhance the clinician's ability to be a better clinician, a better healthcare provider? What are some of the things that when you look, what can athletic training do as a profession to make themselves a more valuable commodity?
Well, that's, coming out of the training room. I think, there's a piece to the puzzle that most people haven't started realizing, is that whole quote-unquote physician extender role that, has become a big issue in medicine in this country. Everyone's thinking of PAs and nurse practitioners coming in. I do see a huge role for athletic trainers in the clinic.
Let's harp on that for a second. Physician extender versus physician assistant in your office. Sounds like there's probably two different roles. Physician assistant is really on your family practice side.
Correct.
Whereas physician extender is really on your sports medicine side.
Correct. So there's the component. I do have a physician assistant. She's wonderful. She does help get me moving and get me through some of the clinic day, and she does take care of a lot of my family medicine stuff. But a physician extender and an athletic trainer is a perfect example of a person that can take this role, is someone to get in before me, screen out the athletes, get the necessary evaluation done, and more importantly, once the diagnosis has been made, verified by myself, start getting the rehab piece going. This is the comprehensive care that we so want, is that most people go to the doctor's office, oh, you have this diagnosis, here you go, walk out the door. This is where you can actually bring in this whole big multidisciplinary approach and say, we actually have an athletic trainer in the office here. Let's get them to show you some rehab exercises. Let's get them to start figuring out how we want to progress you, so you're not lost when you leave this office. You actually know exactly day by day, week by week, what your game plan is when you walk out the door. And I think it's a much higher patient satisfaction for them to know that they actually have been coached on what they need to do.
Yeah, there's some really interesting data out there right now about athletic trainers, physician extenders, and being able to increase productivity of the office, and obviously increased productivity leads to increased generation of funds.
Correct.
Increased generation of funds, obviously more money, everybody's happy.
Right, everyone's happy, right? So the big study came out of Emory. It talked about how they've increased from an average of 22 to 23 patients a day to 27 patients a day in the same setting I'm in the primary care sports medicine standpoint. Increased productivity, but they also showed a second component. The secondary outcome was increased patient satisfaction. Right. So yes, everybody wins because the patients are happy, which is the most important piece of the puzzle. Physicians can get in and see more patients, which we always have a shortage of healthcare professionals in this country. And most importantly, there is a role for an athletic trainer to come in there and bridge that gap.
Right.
And that's huge. I mean, that's a role that I think will become much more prominent in sports over the next 10 to 15 years.
Well, I can tell you that I think this is a really unique system that we set up, and I have total confidence in you as a physician. As I think back to a couple months, I called you when I was almost on my deathbed saying, can you please call in some antibiotics and an inhaler for me because I can't breathe? And you said, okay, I'll do this for you one time.
Yeah, it's kind of funny. He's throwing me under the bus there, but it's like I said, it's a very mutual respected relationship that we have, and it's about team. And if you're thinking about going to athletic training, the big thing you got to remember, you got to be a team player no matter what.
It's about team, and it's about trust, and it's about relationship building, like Dr. Ott said.
Yeah, agreed. 100% agreed.
Well, if you want to learn more about Dr. Bajani, again, go to our website, www.hhp.uh.edu/MAT, and on the left-hand side, you're going to see a link called Partnerships, and under Partnerships, you're going to see Memorial Hermann Medical Group, you're going to see Memorial Hermann Sports Medicine Rehab, Memorial Hermann Ironman Sports Medicine Institute, and UT Department of Orthopedic Surgery. Dr. Bajani has been instrumental in developing these relationships for us, so much so that we were able to get some nice gifts for our students in the first week. And Dr. Bajani has been an incredible asset for us, and we are very fortunate to have him on board. I want to thank you very much for your time, sir. Again, I can't tell you how excited I am that you're on board.
Well, the excitement's mutual. I can't wait to get this started.
And for the Master of Athletic Training Program, I'm Dr. Josh Ellen with Dr. Bajani. Thank you again.
You're welcome.
All right, bye-bye.
You got one? Oh, you got the job one?
They would like you to sit here so they can.
By the way, Alicia, even though Bob's like a very serious person here, he will throw curveballs at you. Just be ready for him.
What did I throw at you? Did I throw one at you?
He didn't throw one, but I'm gonna tell you the story about the marathon when he just came out and completely ignored me, just walked around.
Oh no, dude! I had my Meniere's attack, and I was so mad at that point.
I think I have a shot to get all of us the iPad. You do? Let's do it.
No, I promise you, there was no match.
See how easy this is.
Jeremy, ready?
By the way, you got deep Swahili for me now.
What?
Yes, speak Swahili for her.
Slowly?
The Swahili.
Oh, Swahili. This is for slowly. She's a doctor.
Get to the Swahili again.
No, I can only do that.
Can we pull this out?
Yes.
Let's put it right here, and then we can all stand. Oh, look at that.
That's fancy.
That's it.
Jeremy, we're going to get you and Bill in. We're going to put this in the NAT News.
Did you see that going away?
That's right.
Yeah.
Oh, that's good.
Actually,
What do we do?
We're going
is it Dunkin'? The like.
Yeah.
Or you put it that way.
I'm surprised you normally didn't get the flop of the night of that.
Turn around so it's facing.
So I was texting Anthony.
I have a Twitter name, so we should be tweeting live, so I'm not going to throw that out there.
All right, Jeremy,
You're
Bill,
tweeting.
Mark.
Oh, I got something funny this later.
But I don't tweet very often. It's mostly pictures.
Yeah, Jeremy, you two need to be in the center because we want to make sure we highlight you.
I'm gonna do my hold me up.
Do whatever. I'll tell you, we'll hold you if you want. By the way,
May?
M8.
I'll have you look up on my knees. You're like,
Yeah, well, like I'm just coming in back.
Okay.
Yeah, we're not there. I have one. I don't have one. Before we do get about the council, we have one.
Oh, okay. I never really knew what the council was.
Alicia.
Where's Hollywood?
Yes.
can I have you take a picture of that?
Yeah.
It's one of those guys.
Do I get credited on this?
If I was someone that's Hollywood.
Photograph taken by.
Photograph.
All right, let's arrange ourselves here. Bobby.
There you go.
Of course, middle back, like you always probably are.
I'll go back right and back left.
All right, Jerry, you're gonna have to. Yeah, Jerry, let's go this way.
Make sure everyone's coordinated with the colors. I
Go get the
know,
back.
distribute the colors.
Go
Bro.
back.
Everybody hug.
I was gonna say, group hug.
No, right there. This one?
Or you're.
Okay. Oh, there we go.
I'll lean this way toward no, and they'll break the iPad.
Alright. Yeah, you'll cover the memorial for me completely.
That's okay. It's okay.
Alright, one. Alright, 1, 2, 3. Alright, come like
Yeah, it's like family Christmas pictures.
That's right, and then we need a stairway and y'all can all like.
Just a lot.
Usually there's always one on
That is
the
outstanding. Thank you.
All right, now let's put that behind you.
Now put that back over behind whoever's talking.
Give it to you.
Huh?
Give it to you.
Yeah.
Tomorrow.
I think we want to go a little bit.
Okay.
Is that? Do you still see? Is there space on that side over there? Can you move it back?
Yeah, sit down.
Test it out.
Yeah, that's good.
Good. Good.
That's the first time
You out?
That's what you want to say, yeah.
Okay. Thank you for coming.
Hey, thanks. Pleasure. Meet you guys.
Two interviews. Did you even talk on Sports Army yet?
And it's someone this whole big 2-hour fiasco meeting, and it's fucking full of video. I
started on it, man. I said, he didn't have enough yellow. And I said, what's this almost got to start? Yeah,
Hey, Mark, did you hear about this?
What?
Dan, text message, Matt. Did you do the CITA training for Dr. Knobloch?
We just need to sit down. So.
Well, I'm almost done. You must be hanging out with these guys.
Yeah, he did. I think he texted me that he finished his report. It's not. If you've ever done it, it is miserable, and you have to get an 80%. Well, technically you're right. It was supposed to be done today. We gave him today to do it, but I told him about it on like Thursday. I said, don't wait till the last minute because it's hairy. I mean, it's 5 hours of brain drain. And so a lot of them did it early. I think Matt did it already, but
yeah, he said he was.
Has to be due. I said by class. Or actually, you know what? I didn't give him. I put in the email. I'm not giving you a final deadline. I expect you will have it done as described.
I said I've started working on it today.
Okay.
Which was, well, I got one. I texted him at like 2 o'clock or something. So.
Just ask him how it went. That's the funny part.
Text him, so how fun is it?
Yes.
But you already talked.
You want it?
I was waiting on this one.
What, want me to?
No, yes, you.
So what I've done is I'll just introduce myself real quick. I'll just say your name and what you do, and if you'll go into your education background, that kind of stuff, and just say, what your area is, and then I'll start with some questions. And, you said you want to talk about anything, but we'll try and keep it towards athletics, obviously. So.
Okay. Is it more aimed towards like high school athletics?
It's actually aimed towards the people that will be listening to this will probably be high school, college athletic trainers.
Okay.
So whatever the current, I like to ask, what are the current topics? Like, what is, we all know about MRSA. We all know about athlete's foot. Is there anything new that's progressing, or is there new treatments or anything like that? Because this is for CEUs, so I'd like to ask questions that are maybe help somebody learn something. But it's dermatology. It's probably one of our weaker areas. So, you ready? Okay, this is Dr. Mark Knobloch. I'm here with Dr. Josh Yellen and Dr. Alicia Bedgood. She's a dermatologist. Dr. Bedgood, could you give us a brief background and probably a better explanation of your actual job for our listeners?
Yes. So actually, I do primary care sports medicine, and I work here in Houston with the Houston Baptist University. And so with my football players, my basketball players, even soccer, I see a lot of skin issues. So I do get a lot of experience in the dermatology realm.
So you're not a dermatologist. I misspoke.
Correct,
My apologies.
correct.
I'm sure your friends or your colleagues are cringing right now. I apologize.
I'd probably have a nicer
So you
car
gave
if
such
I
a
was
good talk. You were
dermatologist.
obviously
Probably have a nicer car.
you gave such a good talk. You were an expert in dermatology. So
Dr. Bedgood, we just had Dr. Bajani here, and he talked about the different routes they get into sports medicine, family practice, general medicine, PM&R, that kind of stuff. You brought up another interesting topic about primary care. So can you tell us a little bit about your education? Where'd you go to medical school? What'd you do your residency training? And then obviously you did a fellowship.
Yes. So I took some detours in that I went to medical school here at UT Houston. Thought I was going to be an OB-GYN. Spent some time up in Brooklyn. Decided I was not a surgeon, so came back and did family medicine, where I felt like I didn't have to call a consult for everything because I was the one-stop shop, which I really liked about family medicine. And when I went into family medicine, I didn't realize there was a specialty of sports medicine. I had always been really interested in sports when I was younger, and I've always been a runner. I was a dancer, and so I like working with athletic people. And I actually, when I was doing OB-GYN, wanted to work with athletes from the women's health side. And so when I got into family medicine, I kind of sought out a way to do that through family medicine and learned about the primary care sports medicine training system. And I did my fellowship at Methodist Willowbrook here in Houston, up north with Dr. Scott Rand, and I just started practicing with UT Orthopedics as one of their primary care sports medicine doctors last August.
And so you're with UT Physicians?
Yes.
With Dr. Lowe and that whole group?
Correct.
So so it's very possible that our Master of Athletic Training students are going to be able to work with you because we just signed an affiliation agreement with UT Physicians Department of Orthopedic Surgery.
Yes, and
So
I
they're gonna be able to
love
rotate
having athletic trainers with me. I've had some physical therapists with me. I've had a couple of residents with me. So I really enjoy having new minds hanging out with me.
So you brought up two interesting topics. Dr. Knobloch brought something up, and then you just brought something up. I want to ask you a little bit about what do you think the athletic trainer needs to know in terms of disease recognition for the skin, MRSA, etc. And I understand there's a Versa coming out now,
Yes.
Vacillin resistant.
Yes.
And then the other thing you brought up was female issues in sports medicine. And the thing that pops up is the female athlete triad. So can you talk a little bit about skin disorders, what you think what we need to know as a profession, and then transition into women's health?
Absolutely. So skin issues, I mean, they run the gamut. You've got everything from your kids who are so worried because they have acne to ones who have more serious issues like the staph infections, where it can actually turn into something extremely dangerous if you don't take care of it. The biggest thing is for athletic trainers is being on the prevention side of things, really teaching athletes what they need to be doing to recognize those lesions, because they may come to you a week or 2 weeks later and say, hey, I've had this going on now for a while, and you're at the point where you're really chasing the ball there. So if you teach them, hey, I want you to bring anything suspicious to me. If you have a cut and it's just not healing the way it's supposed to, or if you have a cut or you think it's a pimple or a spider bite, I need to see that sooner rather than later. At least let me lay some eyes on it so I can tell you what you need to do for it, as opposed to home remedies or trying to pop things with their nails or all those fun things that our athletes try to do to self-remedy the skin problems.
Dr. Knobloch was the head athletic trainer at Lamar University for I think 7 years, 8 years, right? And so I'm sure he came across a lot of these different type of incidences that you're talking about. Dr. Knobloch, can you elaborate on that?
Worst thing I ever saw was surprisingly just an ingrown toenail. And I remember, and I saw there was a book, I can't remember the name of it. It was a picture guide to dermatological issues. I mean, if you're having a bad day, look through that. Your day's not that bad when you look at some of the things in there. And to me, I was like, I never want to see this, eczema. But I remember the ingrown toenail was the closest I've ever come to being sick as a trainer. I don't mean that funny. I mean, it was just, pretty strong stomach. But this person, ingrown, and it built up, for lack of a better term, pus and everything else in there. You touched and it just oozed out. And it was the worst thing ever. But toenail actually moved. And so I saw that, but I think it's key because we are not trained in. I mean, the only time we're going to see, or are training mostly in skin injuries or skin conditions is when we see them. We don't have a formal course like we have shoulder evaluation, lower leg evaluation, spine evaluation. We have pharmacology. We have general medical conditions, but skin is very small, and things like MRSA are a very big deal in athletics, and it's a very big prevention. But I think one of the things that's very key is the spread of it and the prevention of the spread of it. And what else is out there that you commonly see in athletics that we don't maybe see on a daily basis, but it's a very important topic to understand?
Really, the big things that's right, your funguses, your bacteria, like your staph that's normally on the skin, the herpes, the warts. Those are going to be the big ones, and it's just a matter of which bacteria are out there at the moment. It's going to depend on where you're at. If you're in a very dry environment, you're going to have a different group of issues than if you're in a very warm, moist environment. So knowing what's around where you are. You may be more at risk for things like bites, mosquitoes, mosquito-borne illnesses in one place, whereas you're more at risk for your typical MRSA in another area. So you have to know where you're at. The big things are always going to be your staffs, and the way that we use antibiotics these days, bugs do develop resistance. And so if something's not getting better on a antibiotic, you need to realize that it's not getting better and address that, get a culture, make sure that we're throwing something else at it and not just ignoring it and letting it continue to get worse.
So would you say is it a safe assumption, and correct me if I'm wrong, that you can do all the prevention in the world and MRSA still can happen? It's not that you were for example, lack in your sanitation. It just can happen. Would you agree?
Yes. I mean, I know that people who they shower regularly, they're doing all the things they need to, and they just have an environment that bacteria likes to grow in. So it's very individual as to who's going to be more affected than others. The bacteria that they have living on their skin is different. It can be affected by your diet. It can be affected by your clothes. It can be affected by your family. If you come from a family that has a lot of bacterial infections, you're more likely to have it. Not only are you more likely to have it on your skin, but you're also genetically more susceptible to it. So that makes a difference.
So what are some different funguses and bacteria that you think grow in a more humid environment versus a drier environment? Obviously, because I'm originally from Southern California, and so a lot of the things that I saw when I got to Louisiana and then again here in Houston is different than what I saw in California.
I mean, I still think we see, I see a lot of your typical athletes, the tinea pedis, tinea corporis. I see a lot of people with it when they shave their head, very, very short hair, particularly in the summer, that they're more likely to get the fungal infections actually on the scalp because of those open wounds. Mm-hmm. And sometimes improper cleaning of barber equipment.
Gross.
Yeah.
You mean in guys' bathrooms they don't sanitize it every time they use it?
Unfortunately, I have to talk with my athletes all the time. I'm like, quit rubbing your wounds together. That is not a good way to treat them. But yeah, and staph is always a big one around here. I see just your typical Staph aureus is the most common one that I see. Every once in a while we'll get some of the we'll have random things pop up, but Staph aureus is going to be our big one.
It's always there.
Yeah.
And tell us some of the topical treatments that are out there, right? There's one in particular, a topical treatment that's out there for the treatment of staph.
So I really like the bacitracin. That's my favorite. I'm not huge on the decolonization. It hasn't really been shown to do great things, particularly in athletes, but I will have them do if they have a really bad infection, I'll have them do the bacitracin in the nose for a couple days, as well as the Hibit cleanse on the skin a couple times a week, just to try and decrease the bacterial load. We're not going to get rid of all of it, but at least decrease that load somewhat so that they're less likely to get those infections.
And there are a lot of people that can't make that connection with decolonization, right? Taking the bastration and rubbing it in the nostrils versus how does that affect, what's the correlation between my nose and my skin? Can you talk about that a little bit?
Well, I mean, the skin is one way that we get things into our bodies, and then the respiratory system is another. And so, as you're breathing things in, that's a block. It's kind of like putting up a wall to it. It's probably, I don't know if an appropriate example, but similar to like a spermicide. It's going to block anything that's trying to come through in just a gel form. You don't necessarily need a physical barrier. You can have that antibacterial barrier that sets itself up and blocks it before it can get into the rest of the system.
Then you talk about Hibiclens and Hibistat. The Hibiclens, always reminds me of the bright red soap. And then the Hibistat. So, we have a lot of clinical athletic trainers out there that deal with staff day in and day out. Tell us a little bit from what you think. I'm an athletic trainer on the field. Obviously, I don't have soap and water with me. I've got some, just general hand cleanser, and maybe I've got some Hibistat. And what are some suggestions that, from a clinical side to protect the clinicians?
Always wearing gloves. That's really the biggest thing, is making sure that you're always wearing gloves no matter where you are. Because it may not be blood. That's the typical thing that people think of when they put on gloves, but there's lots of other body tissues and body fluids that you can be exposed to that are dangerous. So that's going to be the first line. And then both protecting you and the athlete in terms of washing your hands before and after you do any of these procedures, even if it's just with a little bit of soap and water. Soap and water did great for hundreds of years, and it's still a really good way of cleaning your hands.
And what do you think about the combination 1 part bleach, 10 parts water? You have all these commercial, blood busters out there and everything to deal with bloodborne pathogens and OSHA standards. What's your take on, kind of poor man's OSHA standards, 1 part bleach, 10 parts water?
I really like it. Actually, other than the drying aspect on the skin, if you're putting it on a skin, you want to be aware of the fact that it can dry out the skin and cause more cracks in the skin. But in terms of cleaning your equipment, I think it's great. And actually, when I have kids with ingrown toenails, I'll have them do bleach baths very early on to try and keep that from becoming a full-blown, nice, pussy toe.
We did betadine soaks. Would you recommend bleach soaks over 1 to 10 bleach over betadine?
I haven't done a full-on study comparison in my athletes, but I've always had good results with the bleach.
And I'll be honest with you, I don't think we did a controlled betadine. I think they poured some in.
Yeah, that's
so
right. That's how we used to do it.
There probably wasn't a real good study, or it wasn't a real good evaluator, because 1 to 10 is the common. Betadine is like bloop, bloop, bloop. Okay, that's enough.
Well, nowadays too, I mean, with the betadine, you get a free tan. With the bleach, I mean,
That's right.
Temporary, yes, 1 foot tan.
And I agree with what Dr. Knobloch said earlier was 2 times I ever got, I guess, queasy or nauseous in any procedures. One was seeing an ingrown toenail procedure, and the other one was seeing a rhinoplasty. And both times when these got a little bit weak, where the podiatrist came in and, we got an ingrown toenail, and then injected him with a 10-foot needle, and that made me a little bit queasy, and then came in with some pliers and yanked the toenail out, and I just about passed out. And the other one was when there was a patient that he had fractured his nose and it was displaced, and they had to let it heal and then go back in and to see how they refracture a nose. It's barbaric in nature. They send this thing up your nose and then smack it with a hammer.
And some people pay for that.
Yeah, that's right.
They'll pay a lot of money to have that done. So do you see, and this is geared again towards athletic trainers, is MRSA still the kind of the gold standard of problems, or is there a new kind of is there a new condition or a new strain they should kind of educate themselves on, or what's the growing trend for, and I know you're not a dermatologist full time, but what do you see? Or is it still pretty much MRSA is the big concern?
MRSA is a big concern, and we now know of good antibiotics to address it, so I don't think it's quite as scary as it was before.
What are some antibiotics that you'd use?
Actually, Bactrim works really well on MRSA, so which is nice in this area. But like I said, it really depends on where you're at, and most of the hospitals will have what we call a bacteriogram that shows how effective different medications are on different bugs. And that's really helpful because you may have a more resistant strain in the area that you're in. MRSA, there's always going to be new bugs that are coming that are resistant to, and you may get that culture back and it's resistant to everything except for the most simple thing. And so you're like, all right, well, we can use ampicillin on this. That's great. So it's just a matter of knowing when what you're doing is not working. There's not really anything specific that's coming up in the roots that's real scary at the moment, but it's just always being adaptable with
It's
your
really more of the treatment, the more effective treatments is where the studies are probably geared. So
yeah.
Can you talk a little bit about, along what Dr. Knobloch just said, I read a paper, the bacillin resistant, this Versa, which I think scared a lot of people. Oh my God, there was MRSA, and now there's this Versa. What's that all about?
Truthfully, I haven't come across very much of it at all. It's just a different variation on the same game. Like I mentioned in my talk, the bacteria are always adjusting and trying to find ways to stay alive, and so we're always trying to find ways to kill them. So there's always the new and up and coming fancy medications, and those are not always the ones that you necessarily need to use. I'd prefer people to save those for the really bad infections and actually stick with the basics of what is working, and what if you have a infection and most of the team has been susceptible to one type of antibiotic, most likely this next infection is going to be susceptible to that as well, because it's probably coming from the same source.
So let's talk about, just briefly, right, in your practice, your family medicine, primary care, and you have a mom, kid's a high school athlete, he's got a little bit of a cold, started cold on maybe Wednesday, woke up not feeling well, sore throat, stuffy nose, needs to be able to play a game Friday night, really important game. Hey, doc, can you put him on some antibiotics? What's your gold standard?
So typically, first day I see people, if it's the first day of their symptoms, I tell them it's really difficult to diagnose this, and so I'm not going to start you on antibiotics. We need to, most of the time, this is a virus, and we need to let it kind of declare itself. If I see that warrant antibiotics, I definitely will. There's a few instances where I will use antibiotics. Sinusitis is one of the times where it may not necessarily be a full-blown bacterial infection, but if there are certain signs like sinus tenderness in the frontal or the maxillary sinuses, I will do an antibiotic because of the risk associated with a really bad sinusitis. Getting into from the sinus to the brains is not a very long trip, so I'll usually err on the side of precaution with that. And the Z-Pak, it's not good for a lot of other things, but it is great for that. So that's the one time where I will take care of that. But if people are concerned, they come in, they always, I've got a sore throat, I'm worried that I have strep. Well, if you don't have one of the 3 out of the 4 signs in no cough, fever, tender lymphadenopathy, and exudates, I'm not giving you an antibiotic because it doesn't meet the criteria, and it's going to be a waste of your money, and it's going to put other people at risk in the long run.
Because as you're exposed to this antibiotic that you don't need, it really starts to make more resistant to the, right? And that's where we get to methicillin resistant.
Absolutely, and it also, you're putting things in your body that your body has to process that you don't need, and so you never know when you're going to have an allergic reaction to a medication. So you're taking a risk there by taking something that you don't need and that's not going to help you.
So is there a time period? I remember going through grad school and our head athletic trainer had said, it's really 7 days worth or without. And I said, well, what does that mean? He says, if somebody comes to you with a cold, let's say you're on the road with a team, give it 7 days, within it, give it 7 days to run its course, and that course will dictate what it is. And with or without means antibiotic, no antibiotic. So just let that week go by. Do you agree with that?
Absolutely. If it's gone on longer than 7 days, it's much more likely to be a bacterial infection than a virus. Viruses are going to run their course. And if you're still having symptoms at 7 days, I actually say it's either allergies or bacteria.
Bacteria, right.
Yeah. In Houston, we definitely have to throw that allergies into the mix. These people who come in and have, I've been feeling horrible for the last 3 weeks. Okay, that's because your nose is inflamed and it's dripping down the back of your throat and your eyes are all nice and itchy. That's not strep throat.
I like that. I like that diagnosis better than what I was taught, which was if it's clear, it's a virus. If it's colored, it's a bacteria. I said I don't think it's that simple. I mean, I could be wrong, but
And I try not to look at nasal drainage that closely. So.
Go back for a second. You talked a little bit about recognizing the signs of a bacterial infection. So you have an athletic trainer that's traveling with the team. Let's say they've got a long 2-week road trip, right? And they've got to be able to talk to you as the team physician, but you're really relying on them on what they're going to see. And athletic trainers, the new generation now is trained to use an otoscope and use an ophthalmoscope and be able to use some of these tools and report back to you and say, hey, look, doc, this is really what it is. So what are some cardinal signs of that bacterial infection?
So, it really depends on where you're looking. So if you're looking in the throat, you're looking for the exudate. You're looking for a lot of erythema. Your fevers, how long it's been going on. In skin, you're looking for the redness or the warmth around the side of it. Is it increasing? Is it staying the same? Stomach bugs generally are not bacterial unless you're just having really, really special types of diarrhea. Your urinary tract infections, those are pretty much always bacterial, and so knowing what the signs and symptoms of a urinary tract infection are important. But the majority of things are, you just have to go in with the knowledge that the majority of things are viral. Pink eye, pretty much always viral.
Understand. So if we're going to be educating our students on some of these things that they need to see in the general medical condition, or Dr. Knobloch is teaching our emergency care class and some other things. And you can learn more about our curriculum for our program at www.hhp.uh.edu/MAT. And we want to thank Dr. Bedgood for all of her time and expertise. I think we're getting the sign to wrap up here.
Yeah, it's from our sponsors, so we have no choice.
Yeah,
we have to wrap up.
We have to wrap up.
We would like to thank Pasadena High School for putting this on as well. Opportunity to spread some knowledge here.
Yeah, Bill and Jeremy are doing an excellent job over there with Jasmine. She's doing a great job. Well,
Dr. Bedgood, thank you for your time.
You want to sign off for us?
No.
Okay, I will.
You're the pro at that.
So I'm for the sports medicine broadcast and the Master of Athletic Training program at the University of Houston at www.hhp.uh.edu/MAT. You can look us up. We have our own Twitter now at UofHMAT. Catch us on Facebook. You can look us up on Sports Medicine Broadcast. Also look at the Twitter page for the Sports Medicine Broadcast and the Sports Medicine Update here at Memorial Hermann. I'm Dr. Josh Yellen, Dr. Mark Knobloch, and Dr. Alicia Bedgood. Thank you very much.
Thank you.
Sorry if I repeated myself on that. I'm very very broad picture, so I'm always.
Hello. So when did you get, how long to make it what?
So I moved here from Houston. I've been in Houston for a year and a half years now. So in school here at UT Austin. I'm from Austin.
Oh, really?
Yeah.
You're trained?
Yes.
Got it.
Actually, my fiance is a female. She's a rice assistant farmer.
Oh, awesome.
So,
Yeah.
Allison Martinez.
Well, but
And I actually know. No, it's okay. That's the normal assumption. But yeah, I actually know the U of H associated.
I got a bunch of kids now, so I can't remember. So what's it like? Well, to get here early, my wife had to take it, so she has to work.
Oh my gosh, this group just called. They have a liberal parent there too. They're going to surgery like 3 months before they're coming. Yeah. Very nice to meet you. I am sure you will. I'm always hanging out with this person.
I can't. I actually have to go get my
Academic school.
Sorry. My wife is take care of her. Probably next week.
Dermatology. Dermatologist.
Like I said, I would.
Hey, maybe next time.
What's that?
Maybe one time.
I saw that. It was, well, it's on my computer.
10 years, Josh Yellen, 10 years, $80 million. Kelly just off of John Cowboy.
He's already been there once. He didn't. I should have been at second best. He's been in the
Jay Fisher this time. Jay Fisher can go to the next.
Jay Fisher is?
And Knickerbockers.
I mean, it's Steve Fisher.
Jay Fisher was just playing basketball a few weeks ago. Don't know what that is. But it's the biggest franchise.
The best coach in modern times is Phil Jackson. Good.
No, I honestly think that Greg Pop was
Figure out the best way home. Traffic everywhere.
We're in the middle of everything, so.
I was trying to find one that's the best route. I know how to get home, which way I want to go.
All right, well, that's the end of the sports medicine broadcast for today. We'll do the same thing tomorrow, starting around 8 a.m. Start the, I guess about 8:30, start the interviews and the live stream, and go from there. Thanks for listening to the sports medicine broadcast. This is Jeremy Jackson. Check us out. Rate it on iTunes. Download it. Tell your friends about it. Get your CEUs while you work or do whatever.